So a very warm welcome to all of you on our second day of the ICNC 2022. I also welcome all the delegates who are watching us live. We had missed out on 2 sessions yesterday because of paucity of time. So we'll first have Dr. Mansi Patil, who is going to talk on veganism and CVD. So can I welcome Dr. Mansi Patil? Thank you. So before that, I'd like to introduce Dr. Mansi Patil. I think most of us in the dietetics fraternity know her quite well. She is a PhD holder. She's a committee member of the International Society of Hypertension. She's the committee member of the American Society of the Preventive Cardiology, also a NEC member with the IAP in India, and of course has a lot of credits to her accounts in terms of the books she's written and the research papers. So with this, I welcome Dr. Mansi Patil.
Thank you. A very good morning to all of you. At the outset, I'd like to thank Delhi chapter for having us here today. When we talk about veganism, it's a pretty interesting topic because veganism ultimately is a philosophy a person believes in. It's a philosophy where a person would not consider animals as a commodity. So it is not restricted only to the dietary aspect. For today, we would be talking especially about diet. But again, I would just like to stress that this is a choice that a person does make. There's been a huge trend commercially with a rise in veganism, the kind of diets that have come up, the kind of the advances that we've made with respect to the options that we have for the vegan diets has been incredible. When we talk about vegan, we are talking about purely plant-based diets where there is no animal source, be it eggs, be it meat, be it milk. So it's completely a completely plant-based diet. There is immense evidence supporting veganism. I would try to probably strike a balance between both the pros and cons of veganism. Somehow, the evidence for veganism seems to be, the research evidence that we see seems to be a lot in favor of veganism. And we've seen that the 9 major diseases in one of the largest studies that have been made support veganism. They've been linked to the consumption of meat. But why are we talking about veganism, or is there a pathogenesis that we can relate plant-based diets to them being cardioprotective? Around the world, a Mediterranean diet has been considered, it has been labeled one of the best diets, the topmost diets for the year of 2021 and 2022. Mediterranean diet and and the DASH diet both are, I would not say just cardioprotective, but then yes, they are actually protective against metabolic disorders as well. When we talk about a plant-based diet, we realize that the oxidative stress, the pro-inflammatory markers, let's say TNF alpha, be it IL-6, be it IL-18, all of these are pro-inflammatory, and the inflammatory burden with the Western diets or with a meat-based diet is very heavy. We do realize that with a meat-based diet, there's evidence that the adiponectin levels would go up, and they also contribute to a pro-inflammatory effect leading to an endothelial dysfunction, which ultimately we all are aware does impact the or becomes a precursor for metabolic syndrome. It has also been established in various researches that an inflammatory a pro-inflammatory environment in the body would not only lead to or become a risk factor for ischemic changes or an ischemic event, but it also leads to the pathogenesis and an ischemic event. There is evidence, I think in 2017, a paper in the Journal of American College of Cardiology had stated that vegan diets have demonstrated a significant reduction and even a reversal in coronary artery disease. It was noted that these diets have significantly reduced the prevalence of heart disease, cancer, and type 2 disease. This was a study which was where the cohort were followed for almost 13 years. If you look at the results, you would find that the results have been significant for following, once the cohort followed a vegan diet, for weight loss, for a reduction in the total cholesterol levels, a reduction in the systolic as well as the diastolic blood pressure. And we all are aware, we've seen in the previous lectures yesterday, that all of these are potent modifiable factors for metabolic syndrome and cardiovascular diseases. There was a randomized controlled trial which was done in northern India, where they had given a high protein, a vegetarian diet basically. They did include the dairy sources here, but it showed again a significant weight loss, improvement in the body composition. The cardiometabolic profile had improved considerably with this as well. It was called as the PACER diet. There has been, again, I think 2018 study where they again had followed this cohort to look at the anti-inflammatory effects of a vegan diet, and they had compared the vegan diet against a group of people following the AHA recommendations, and it was noted that the risk factors and the even the inflammatory CRP levels, they had reduced more with a vegan diet as compared to the AHA diet. But yes, the question does arise that if you're following a vegan diet, are you compromising on the protein quality? Going back to our basics, we understand that protein quality would not solely be dependent on a single food item. We do study, we do teach very often about the complementary value of proteins. And it has been noted even in athletes that if a complete protein is given, if we are we are combining two proteins to get a high quality, a high biological value protein, we are not really compromising on the quality of protein. Yes, quantity could be a challenge, but quality is something that is achievable. Comparing the cholesterol profiles across the world is very important to understand where we stand today. Today, compared to probably the developed and the high income countries, we do not have the cholesterol levels as high yet, but yes, we are progressing towards it. Be it the Framingham study, be it the America's cholesterol study, be it the PURE study or the Indian Heart Watch, we do see a change in this cardiometabolic, the cardiometabolic profile. We were talking yesterday about the transitions, the malnutrition. So yes, we are in a nutritional and an epidemiological transition. The 7-day Adventist study had studied the risk of ischemic heart disease, and it did note that the non-vegetarian men had a higher prevalence of IHD as compared to vegetarian men. The EPIC study is something that we cannot not talk about when we talk about veganism or when we talk about cardiovascular diseases. And this is again where there was seen a consistent reduction with the elimination of non-vegetarian food items in the cholesterol levels that the people had. So a meat eater had had an average of about 204 plus minus 5.8 milligrams per deciliter, whereas a vegan had almost, one third of it less at about 170. The lifestyle heart trial goes a little further and says that it is not only the diet that you can talk about, it is not only a vegetarian or a vegan diet that you can talk about. When we talk about cardiometabolic syndrome, or we talk about CVDs, it is a lifestyle disorder. The modifiable factors are very, very important, and hence we need to talk about stress management, alcohol. We need to talk about cessation of smoking, as well as modest exercise, which is consistent and regular. I would not talk a lot about microbiome today because we did discuss dysbiosis at length, and just a point which I felt that we could maybe stress upon is that the lecithin and carnitine consumption is higher in meat eaters, which feeds on the gut bacteria, leads to TMO production, which is going to have deleterious effects on our cardiometabolic profile. But yes, all said and done, we would face a challenge with the calcium, with the vitamin D, vitamin B12, protein, omega-3, iron, zinc, and iodine consumption if we are depending solely on veganism. There have been numerous studies also talking about the mineral and the micronutrient deficiencies of a person consuming a vegan diet, and it was seen that vegans tended to consume a much higher or had a much higher consumption of supplements. There was a systematic review that was done to, again, talk about the adequacy of a vegan diet. And again, this is a study which said that vegans have been associated with a lower intake of vitamin B12, B2, B3, iodine, zinc, calcium, potassium, selenium, vitamin B12, among the other nutrients. This is a very average, this is the average macronutrient consumption of vegans as compared to omnivores and vegetarians, and we would see that the protein consumption is lower. So what I would reiterate is, it is not the quality of protein, but the quantity of protein that we do need to look at when we're talking about veganism. And yes, planning a vegan diet, a plant-based diet, does require skill. It requires the knowledge of what is locally present and what is the choice that this person has ultimately made, and what would this person actually like to have. It is not that we do not recommend a vegan diet, or we do recommend a vegan diet. It should be as per the patient requirement. It should be as per not only the clinical requirement, but also the personal choice that the person has made. Ultimately, it's probably all about what we always study in nutrition, and that is striking a balance between adequacy and the requirement that the person has. Thank you.
We're going to be, what are we with the calcium and the vitamin B12 deficiencies in a totally vegan diet? So yes, that is an issue. So I think a fine balance, which you've shown on your last slide, is the way forward. I think vegan is good, but then you will definitely miss on the micronutrients.
I think, ma'am, another point probably would be that the cost effectiveness of a vegan diet in an Indian scenario, as well as the sustainability and consistency that these patients have. So it does become, it's pretty effective, at least in the initial 3 months that we initiate a
definitely
vegan diet.
Definitely, I support you on that totally, but including milk and including eggs, and as you said in your last slide, a very, very fine balance. It's a balancing act. Thank you. Any questions from the audience?
Any questions from the audience? I think very well said, Mansi, and especially the research articles. Yes, sir. Viju sir has a question.
So absolutely, a very huge number of studies have been done in the West, probably because this could be a personal observation that I have, that as Indians, we do not tend to recognize veganism as something very different. Vegetarianism, veganism for Indians was a concept that has come in recently, probably in the last decade or so. We have very few studies. One is the PACER study that I could find, but again, the PACER study also focused on vegetarianism. And again, yes, the confounding factors when it comes to the statistical significances, the confounding factors, the evident, lack of advanced statistical analysis, the comparative terms that they have kept, the baseline values and the comparison with which they're doing is absolutely something we'll have to again relook. The methodologies that most of the studies show lack this kind of the interplay of the groups that have been there. So what is normalized is again something that I agree, sir, is questionable.
Also, to add on this, not exactly to the question, but I feel what most of the studies are done in the foreign countries, and when you see the consumption of meat is very high compared to our country, and the kind of meat they eat is mostly processed, the sausages, bacon, salami. So the processed meat and its effect on the parameters, and when as an India country, when we cook our animal product and eat, and the quantity we eat always differs. So I think if more studies done on the Indian population will give more insights to that.
Something needs to be, yeah. So we need to work upon the vegan concept in India specifically, maybe. Thanks.
Thank you.
Start with the next session. Do we?
So I would request Dr. PC to felicitate Dr. Mansi Patel.
Very well presented.
Morning, everyone. We'll begin with the next session of the day now, that is latest COVID challenges. I would now like to introduce our chairpersons for this session, Dr. PC Vijay Kumar sir, who is the Director Academics and Chief Anesthesiologist in the Critical Care Physician of Surya Hospital, Chennai. Anita Jitana ma'am, who is Chief Dietitian at Indraprasth Apollo Hospital and has more than 35 years of experience. Ms. Datta Patel, who is Head Department of Nutrition and Dietetics at DY Patil School of Medicine and Hospital. Ma'am, can we introduce our first speaker of the day now? Dr. Meenakshi Bajaj.
Yeah. Good morning, everybody. A warm welcome to another academic feast. We had an excellent session yesterday, and we are going to start with another one. And this one is a challenge we've all faced since the last 2 years, COVID. So I would like to introduce Meenakshi, a great friend, a colleague, and a real academic inclined dietitian, Meenakshi Bajaj. She's a registered dietitian with 29 years of experience in clinical and therapeutic nutrition, presently working with Tamil Nadu Government Multi-Super Speciality Hospital, Chennai. She's a certified pediatric and critical care nutritionist, SPEN LL certified in everything possible, I think, renal, onco, obesity, to name a few. She's Chennai Capital Convener Netprofan, National Executive Committee member, Indian Dietetic Association, was the former president, IDA Chennai chapter. She's authored many books and chapters in textbooks, journals, and manuals, and received the Best Nutritionist 2019 award from Fit Up Fest 2019. So over to you, Meenakshi, to guide us on how to handle COVID, which was a real challenge with huge figures.
A very good morning to one and all present here. I'm thankful to warm
Meenakshi,
welcome from
online?
Ma'am, am I audible?
Yes.
At the outset, I'm truly grateful to IAPN Delhi chapter, as well as Dr. PC Vijay Kumar sir, Shiva sir, and special thanks to Shilpa Thakur, as well as IAPN Delhi team for the opportunity to be talking to you today on COVID challenges, especially when it comes to pre-ICU and post-ICU. Give me a moment, I'll just share my screen. Is my screen visible, madam? Is my screen visible, ma'am? At the outset, I'll be talking to you about the practice, what we've had with patients, as well as some personal experiences with COVID-19, especially with reference to adult COVID patients, pre-ICU and post-ICU. I would want to put a small note saying that we've been crippling not only with hidden hunger, but also on one end of the spectrum, we've had about, in the 2019 Lancet, we've had about 4 million women super obese. So one end of the spectrum is hidden hunger and the other end of the spectrum is obesity. And today's COVID meter shows us these numbers. But thankfully, yesterday I got to speak to one of the COVID task force person in one of the premier medical colleges in Chennai, and he said we have 0 COVID cases. I hope this persists. So when we talk of hidden hunger, we also have the other concept of there are patients who are, trying to work on to lose weight, for several reasons, whether it may be cosmetic or health reasons. In other words, when they bring down their calorie intake, we are also bringing down the micronutrient intake. And it's interesting and distressing to note that, the nutritive value of Indian foods, published in 1999 and way back before that also, talks about nutrients in food ingredients. But the 2017 Indian food composition tables talks about the same nutrients, but the nutrients are much lower in the food ingredients today's date, maybe because of soil erosion, deforestation, insecticides, pesticides, whatever you may call for. But the present status is the present food ingredients, what we are consuming, are lesser in the micronutrients. There is always a confusion. Is it always only the undernourished and the anemic and the short or the stunted are suffering from micronutrient deficiency? It's not like that. The fact is, even the obese and super obese are having micronutrient deficiencies. And being a part of the Tamil Nadu Health System's Pediatric Committee member, I have noticed that all the morbid obese patients have vitamin B12, vitamin D, iron deficiency, the list just goes on, including obviously calcium also. So very common in obese patients is micronutrient deficiencies. It is not prevented by supplements. Reasons are unknown. wide variations in report, but deficiency of every vitamin and trace element has been reported in our obese individuals also. It's not an unknown fact that the immune impairments associated with nutritional inadequacy increase susceptibility to infection and permit infections to become more severe and fatal. That's why we have seen, with this audit report also, which tells us that 96% of the cases were recorded as having comorbidities when it came to COVID-19 deaths. And most unfortunately, we feel and we find that mortality and morbidity go hand in hand with comorbidities. The topmost in the list being diabetes. Sometimes diabetes does not come as a single, condition, but it is associated with hypertension, CAD, CKD. And if you see, a lot of women population are associated with hypothyroidism when it comes to type 2 diabetes. The forgotten ones are the cancer patients. And recently I had an opportunity to talk to the state TB nodal officer, wherein they were planning a program for not only for World TB Day, but, giving us a lot of insight on saying that a lot of tuberculosis patients also lost lives during the COVID-19 pandemic. Now, when we talk of the most important and the fatal comorbidity is diabetes. And unfortunately, the first type 1 child whom we lost was in early, COVID in the year of, 2 years ago, in the month of March, where we lost a 17-year-old type 1, I would say type 1 child. And she was brought to us with DK and we lost her in less than 2 hours. So that's the, I would say, the major effect of poor HbA1c on saturation and leading to mortality. We all understand that there is no immunometer which can tell us that our immunity is compromised. Though for all patients who are suffering from COVID, the moment they walk into COVID pneumonia or even prior to COVID pneumonia, when their saturation levels are really poor, we are trying to do their LDH, their CRP, ferritin, and all of this to tell us to what extent they are affected. But unfortunately, we see that CRP is raised whether you've had an MI, when there is an inflammation sitting inside, or whether there is a large cancer sitting inside, we find the CRP raised. And once, the patient improves from the infection or, he's been operated or resected from the tumor, the CRP improves. So is it a marker? Are these markers to tell us that what is the immune nutritional status of our patient? Definitely, we are not aware of it. But the other end, we know definitely that somebody who has a poor gut health. Why am I talking of gut health? We need to understand that 80% of our gut health is directly related to immunity. And those patients, it could be, as Dr. Mansi very beautifully put up, that, how a plant-based diet would improve gut health. And this gut health is directly related to opportunistic infections. If the gut health is poor, you're giving way to a leaky gut and opportunistic infections like COVID pneumonia, walking into a patient who's suffering from COVID pneumonia. And how do we sort this out? Can we sort it out? I'm sure we can't sort it out once the patient has walked into, COVID pneumonia, to prevent COVID pneumonia, obviously. So it's like you're missing the bus at the bus stop. Before we miss the bus, if we plan to walk in time, I'm sure we would not miss the bus or the train. The same way, if we are going to improve the immune defenses with probiotic, prebiotic, micronutrients, amino acids, I'm sure we can at least attempt to hold on to the train or to the bus. So next came the era of, all the spices and herbs which have been used, I would say abused, not used. Though we know very well that all the spices and herbs have a great role to play when it comes to fighting disease. That's why in 2000 BC, they said, here, eat this root. In 1000 AD, they said, no, don't eat the root, say a prayer. Then they felt in 1850 that it is a superstition. Here, drink this potion. Potion, nothing was venom, which is, they said that it is poison, so don't have it in 1940. In 1985, they said that the pill is ineffective, so take the antibiotic. And 2000, they said the antibiotic does not work anymore. Take the root. I'm not trying to promote and say that we need to, rely on our roots and spices, but this is the scenario presently with COVID-19, wherein we do not know which antibiotic or which medication will do its best. But at the same time, remember, we have to follow the acceptable daily intake. I've seen a lot of patients consuming a lot of concoctions, herbal concoctions, spice concoctions, coming to us with, bleeding PR, with GERD, with ulcers, with a raise in the potassium levels. And not only that, so many of them, so many renal failure patients walking in with too many concoctions consumed with fluid overload, hyperkalemia, and requiring emergency dialysis. So I think we need to remember ADI, and several patients have been reported to have, hepatic complications associated with overconsumption of turmeric. So beware that, yes, we need to choose on our spices and herbs which belong to our country, but at the same time, follow the acceptable daily intake. And remember that these are the ORAC values which do wonders when it comes to improving the immunity. But at the same time, we've seen a lot of patients with diarrhea, with star anise, consuming star anise more than 3 to 4 times a day. And also remember that you can raise your sugars when you're going to consume concoctions of honey with ginger and tulsi leaves. And there is some data also to tell us that when you consume more than 2 to 3 grams of tulsi leaves, it also interferes with spermatogenesis. So the list just goes on when it comes to ADI, but remember there are foods like drumstick leaves, turmeric, cumin, cinnamon, cocoa, all these, but they all have an acceptable daily intake. In fact, we had a lot of people, entrepreneurs coming up with food products being developed. Imagine this turmeric basil bread. Anybody would fall prey to it. But then only a nutritionist or a healthcare professional knows that bread prepared from a refined flour, though may have added turmeric and basil, is high GI, high GL. It's not going to improve gut health. It's only going to worsen gut health and the associated complications. And remember, whenever turmeric was consumed, it had to be added on with pepper because the piperine in pepper helps to improve the bioavailability of the curcumin from the turmeric. And similarly, when one chooses on nuts, you need to soak them, roast them, or sprout them. Only then you can have the zinc bioavailable. And similarly, when one is moving on to millets from the refined grains, they need to be sprouted, roasted, or fermented in order to deactivate the anti-nutritional goitrogens. So apart from this, we've had a lot of papers telling us from the NIN to, several research guidelines and papers talking to us about balanced nutrition. We need to remember, for example, when we take a tomato, it's not only the lycopene and the vitamin C, it's also the fiber. So similarly, when you take on sweet potato, it's got the beta carotene, it's got the phytonutrients, and it is a resistant starch when you squeeze some lime over it. But we cannot take a single food ingredient or a single vitamin or a single mineral and say it will help our immunity. At the same time, when we see a lot of patients, when we saw during the second and the first wave, waiting for oxygen, waiting for admission, sitting in autos with oxygen cylinders because of poor saturation, we did some reading to understand that our humble beetroot had a role to play when it came to nitric oxide availability. And there is enough data to tell us that nitric oxide is useful in the management of acute respiratory distress syndrome. But does this mean that if the patient is crippling with 92, 93 saturation, we are going to give a beetroot concoction? No, that is not the aim of me discussing this here. What I'm trying to say is each food ingredient has a role to play. And we did tell our patients who were normal, stable, hospitalized, not hospitalized, at home, to consume beetroot in the form of a salad in order to avail this benefit. Obviously, we are aware that vitamin A, B6, B12, C, D, E, copper, omega-3 fatty acids, all these micronutrients play a role. But among 640 records and 22 studies, the 4 important nutrients which they identified, which had a major role to play when it came to improving immunity, was vitamin A, D, selenium, and zinc. But remember that when all of them was this part, we had also one important segment called stress. Stress had taken a big toll, whether you're a diabetic, non-diabetic, cardiac. Everybody knew that who was an elderly, who was suffering from diabetes or any comorbidity, is going to have a rough pathway if they got stuck with COVID pneumonia. Not only that, even those patients who were healthy individuals, when they were hospitalized for reasons so many, when they did not improve, obviously they were put on steroids, and drug-induced diabetes was also one important segment, along with managing those patients when it came to medical nutrition therapy. It's a very tall order to say, provide medical nutrition therapy, personalized nutrition, customized nutrition. But in a war room, is it possible for you to do it? It is a real tall order. But against these tall orders, if you are able to make even a small difference, I'm sure you're going to reduce the mortality and morbidity in these patients. So go ATP based on assessment, tailor-made, and practical. In fact, during the second and the third wave, we did see the entire family was COVID positive. Among the entire family members, 3 were in the ICU, 1 was in the hospital, and 1 was left at home. Food itself became a real issue. So were we able to do justice by telling the patient that you follow a diabetic specific diet or a renal failure or those with cirrhosis of liver? but it was a real challenge. But I think the challenge is more that if you are able to communicate the right message, even about 50% of your message is handled, nothing like it. As I mentioned to you, new onset diabetes during hospitalization increased mortality and morbidity. I would want to share a simple anecdote. What happened to me when I was hospitalized with COVID pneumonia. I was coughing continuously through the day. Yes, sir. I was coughing continuously through the day, and I had to take almost 20 lozenges, which did increase my blood sugar. And I realized I was a non-diabetic, which I could replace with warm water, 20 lozenges equivalent to warm water. So hydration was very, very important. And diabetes management during those patients, during the COVID-19 lockdown situation, a lot of patients became really sensitive. They wanted to lose weight, follow keto, paleo, but these are not the right things to follow. Follow a balanced diet. And obviously, if you could make a small difference by telling the patient, first the fiber, then the protein, then the cereal portion, that made a world of difference in the postprandial glycemic control, whether the patient was hospitalized or whether the patient was at home. So follow the lentil carbs, which do a great job when it comes to having a second meal effect.
Meenakshi,
Yes,
yeah, try and wind up.
Yeah, I'm just winding up, ma'am. Now coming up to the resistant starch, which does wonders, low GI, low GL, portion size. And we also understand that, we've had 10 guidelines as per ESPEN 2021 talking to us as to what should be done for those patients suffering with COVID-19, especially start slow, 12 to 25 calories, minimum protein 1.2, going as high as 2 grams, EN preferred to PN. And in case the patient is hemodynamically unstable or on an ECMO, one can put the patient on trickle feeds. And remember that EN is better than PN. And even prone position, you can feed the patient enterally. And you do not need to do the GRV regularly unless and until, the GRV depends on the institution where you are hospitalized. And there is not much agreement when it comes to the nutrition screening. It's a tall order. You can't practically screen these patients. But remember that if the patient is on high flow nasal cannula, 20 calories and 1.3 grams protein, ONS played a major role, whether hospitalized or not hospitalized. Mechanically ventilated patient, you need to remember to go slow and to help the patient wean off the ventilator. And when you are post-extubated, there may be a chance that you may have to be fed orally along with enteral parenteral nutrition. Remember, ICU-acquired weakness is a major issue, and the patient has to be fed enterally. Remember that a lot of patients were fed enterally with ready-to-hand bags, like peptide bags, that worsened the hyperkalemic status, as well as those patients who had hyperglycemia. And remember that when it came to a role of disease-specific oral nutrition supplements, it played a major, major role. This is a mega aphthous ulcer, which one of the patients was suffering during COVID-19 post-hospitalization. And gut dysbiosis was a major issue with antibiotic-associated diarrhea. It did not improve even with probiotics, though we knew that it played an important role with immune system morbidity, mortality, occurrence of reducing the severity of ARDS and flattening the curve. But we do not have evidence to say that. Same way for vitamin D, we found a lot of COVID-19 patients who had deficiency of vitamin D, but correlation does not mean causation for mortality. Vitamin D, PETAL study, Violet study, vitamin D, all ICU study did tell us that vitamin D supplementation during COVID-19 phase did not improve the clinical outcome. Remember, hydration is the key to prevent the patient from walking into acute kidney injury. And in acute kidney injury, we definitely talk of high protein and not a low protein, even if the patient requires renal replacement therapy. During ECMO, yes, remember one term, hypoglycemia is very, very common with ECMO, though I don't have personal experience with it. There is no term called immunonutrition. There is no role for arginine, glutamine, or fish oil. We do not have enough recommendation for the same. Remember that malnutrition at time of admission, it worsens during hospitalization, and even at discharge, there is 36% as high as malnutrition. Remember that reduce disease negative impact, regulate immune nutrition, inflammation to come down, immune memory formation, all this depends on your micronutrient status. A hungry stomach, an empty pocket, and a broken heart can teach the best lessons of life. We've seen a lot of patients being lost, a lot of family members being lost, their pockets being emptied due to hospitalization. I don't think this should teach us a lesson. We should not wait for a lightning arrestor, to help us prevent from lightning. Here, our job is to improve the nutritional status and maintain the nutritional status during hospitalization and post-discharge. Thank you for the patient visit.
Thank you, Meenakshi. That was very well explained. You've took the whole journey from normal patients to patients who are in hospital, how to treat COVID patients. And as you said, there is a dose of all the spices. We did see patients doing a lot of overdoing of even haldi and ginger. It was too much. And we had patients who had problems with the liver after that. So there is a dosage. And as I said, again, a fine balancing act is required for everything that we do. And as I explained, vitamin A, vitamin D, and zinc were very important during this phase. So really well managed. So open to anybody for questions. Any questions? Yeah, please. On the mic. Meenakshi, there's a question for you, please.
Yes, ma'am.
Hi, good morning. Meenakshi, this is Orithro from Kolkata. So we can see him virtually, but we can't see physically. So thank you so much, as you are very an erudite and articulate speaker, we know. So there's a really nice presentations, but I have 3 questions for you. One is, there is some nosocomial infection during the hospital period. That is number 1. And number 2, there are a lot of patients after the post-COVID. There may be some in glucocorticoid and mineralocorticoid, prednisolone, this kind of steroid. So after that, there are chances to having diabetes. Then what could be your suggestions for that? And third thing is that after post-COVID, when people using some, lot of meats and lot of taboos are there, they have to take too much of protein. At a one go, they have to take 11, like 18, 20 eggs and all those things. And they have ended up with the osmotic diarrhea. And also their RQ level will be slower. And that time what we have seen in 2021, the oxygen saturations will fall due to this much of the hyperphagic tendency of our patients. And I want your comment on this in regards. Thank you.
Sir, your first question is nosocomial infections. Is we need to see to that the patient walks out from the ICU into the ward at the earliest and discharged at the earliest in order to prevent nosocomial infections. That is the first point. And second thing we have seen, as you mentioned to that because of a lot of steroids and there is definitely, diabetes. That's why I said 3 important keywords. First keyword is the food order. Second keyword is the lentic carbohydrate. Third keyword is the second meal effect. And fourth one is the resistant starch. So if you follow these 4 keys, I think you can handle whether it's type 2 diabetes or drug-induced diabetes. And this is sometimes, it retains even after you have stopped the steroids for a short while. And probably you need to monitor this so that the patient does not, left unattended. The third thing is you're talking of high protein. I always tell my interns or people around me that whenever you talk of protein, you have to talk of the second term called hydration. Most unfortunately, none of the guidelines talk about hydration. Whenever you talk of protein pushing, you have to talk of hydration. Same time, you have to remember to reduce the sodium intake because otherwise it is going to take a toll on your kidneys. And I've also seen during COVID itself, as you mentioned, whether it's post-COVID or before COVID, patients are pushing so much of protein, assuming that they can build up their immunity overnight. But on the other hand, they're increasing their uric acid levels. And, through these ketogenic diets, the hyperuricemia is there, which can also worsen their renal status. If they're plain diabetic, they walk into diabetic nephropathy. If they are already diabetic nephropathy, they walk into end-stage renal disease. I don't think it makes anything to talk of high protein post-discharge for a short while. Yes, for about, say, probably 6 weeks. But after 6 weeks, I think you need to go back to your dietitian to understand whether you still need to continue the high protein diet.
Yeah, actually very well explained because most patients who got COVID had long-term weaknesses. Most patients complained of this problem. So nutrition was very important for recovery, but as she's saying, not more than 6 weeks. We don't want to continue on those very high protein diets for a very long time.
Just a minute, I would want to make a single mention, ma'am. Most often, if you see post-bariatric patients, they have hair loss. And this hair loss is because of micronutrient deficiency and protein deficiency. So you need to encompass all the micronutrients and protein, not as a single nutrient.
Yeah. Thank you. Thank you, Meenakshi.
Thank you so much, Meenakshi ji. Now we move forward to the next speaker, Ms. Mukhtar Vashishta. She is a chief dietitian at Sir Gangaram Hospital. She has an active participation in government programs like Indian Dietetic Association's Diabetes Heal National Seminars, Healthy Lifestyle Exhibition at AIMS, and she has a lot of practices inculcated in her hospital and take initiatives to start various disciplines. So without wasting much time, I would like to request Ms. Mukhtar to start her session.
Greetings to one and all. I am Mukhtar, Principal Dietitian, Sir Gangaram Hospital. At the outset, I would like to thank the organizers for giving me an opportunity to give the talk on nutrition in rehabilitation of post-COVID patients. I'm unable to move on to the next slide. So let us understand the effect of COVID. Severe acute respiratory syndrome coronavirus is transmitted through droplets, respiratory droplets, and aerosols from person to person. In pre-symptomatic period, the infected individuals can be contagious and can transmit the virus to healthy individuals in the population. So most commonly present symptoms are fever, body aches, breathlessness, malaise, and dry cough. And some patients may also present with gastrointestinal symptoms like abdominal pain, vomiting, diarrhea, etc. So progression of SARS-CoV-2 is characterized by asymptomatic phase, which is the ciliated cells in the conducting airways are infected, but this lasts for a couple of days and immune response generated is very low. In spite of having a low viral load at this time, the individuals are highly infectious. The second phase is invasion of upper respiratory tract, whereby there is migration of the virus from the nasal epithelium to the upper respiratory tract by the conducting airways. Symptoms are fever, malaise, dry cough, and the immunity generated is greater than the one in asymptomatic phase. The last phase is involvement of lower respiratory tract, which moves on to ARDS, that is acute respiratory distress syndrome. About 1/5 of all infected patients progress to this stage, and there is the inflammation is very high, and finally there is death of host immune cells. So what are the challenges that we face during COVID? These are loss of taste and smell, GI symptoms such as diarrhea, nausea, and vomiting. There is about 62% of patients in ICU show dysphagia, which is inability to swallow. There is extreme fatigue and weakness, dry mouth, and loss of appetite. Now, about 10% of patients who have tested positive for SARS-CoV-2 virus remain unwell beyond 3 weeks, and a smaller proportion for months. Now, after recovering from acute phase, it is important to continue being cautious, especially after discharge. For the warning signs like fever, breathlessness, low oxygen levels, that is oxygen levels below 95%, unexplained chest pain, new onset of confusion, and focal bodily weakness. The length of recovery period is prolonged, and why it is prolonged is still unknown. This may be due to persistent viremia, that is due to weak or absent antibody response, relapse of infection, inflammation, deconditioning, and mental factors such as post-traumatic stress. Long-term respiratory, musculoskeletal, neuropsychiatric sequelae have been described for coronavirus, SARS, and MERS, and these have pathophysiological parallels with acute COVID-19. Criteria for measuring recovery is cough, breathlessness, pulmonary rehabilitation, fatigue, cardiopulmonary complications, mental health and well-being, and special care for older patients. Long COVID refers to when people continue to experience symptoms of COVID-19 fully after recovering for several weeks or months after the start of their symptoms. And it happens to anyone who has had COVID-19, even if the illness was mild or they had no symptoms. Now, some complications like multisystem inflammatory syndrome is especially found in children, which is characterized by organ failure such as heart, lungs, blood vessels, kidney, digestive system, brain, skin, eye, and eyes. This can be life-threatening also. Now, let us come on to the nutrition aspect. So what are the goals of nutrition? Our goals are to overcome the challenges of GI symptoms such as diarrhea, vomiting, and loose stools, which may persist for long. Then overcoming dysphagia and reaching calorie, protein, and goals. Overcoming extreme fatigue and weakness, regularizing normal appetite, gaining lean muscle mass, and bringing back the energy levels. So how do we do this? By taking a balanced diet comprising of 5 to 8 servings of grains, 2 servings of lean proteins, 4 to 5 servings of legumes and nuts and seeds, fats and sweets to be used sparingly, 2 to 3 servings of low-fat dairy, and by including a lot of antioxidant-rich fruits and vegetables, that is for around 4 to 5 servings. ESPN recommends 27 kilocalories per kg body weight for older polymorbid patients and 30 kilocalories per kg body weight for severely underweight polymorbid patients. But these calorie levels should be adjusted with regards to nutritional status, physical activity, disease status, and tolerance of the individual. The macronutrient goals are to prevent body loss, weight loss, to reduce the complications, prevent hospital readmissions, and to improve functional outcomes. Protein needs are around more than equal to 1 gram per kg body weight or more than 1 gram per kg body weight according to disease status and tolerance. Fats to carbohydrates ratio should be between 30s to 70 or 50s to 50, depending on the respiratory deficiency status. That is, the presence of oxygen in the blood. If the oxygen levels are high, then one can take about 30 grams of fat and 70 grams of carbohydrates. If the oxygen levels are low or carbon dioxide levels are high, then about 50 grams of carbohydrates to 50 grams of fats. High protein foods include legumes, pulses, dals, moong, soya bean, soya products, dairy products, and non-vegetarian items like chicken, fish, poultry, and eggs. Besides this, so regarding the calorie content and protein content of the foods, lentils and pulses give about 6 grams of protein per 30 grams of serving size. So 150 ml of dairy products provide about 5 grams of proteins. High protein foods like poultry, fish, chicken, eggs, etc. provide about 20 grams approximately of proteins in 100 grams of the amount. 60 grams of egg provides about 6.5 grams of proteins. Now, it has been seen that whey protein has increases albumin levels to 2.9 by 2.9% and immunoglobulin G levels by 4.8 levels, and it increases glutathione levels that helps in improving the nutrition status and immunity. Carbohydrates should be taken in the form of complex carbohydrates such as whole grain cereals, wheat flour, corn, red, brown rice, bajra, ragi, fruits, and vegetables. Refined carbohydrates like white rice, maida should be restricted. Also, sugars, aerated drinks, and sweetened beverages containing sugars and carbonated beverages should be restricted. Now, fiber plays a very important role in our diet. One should take about 35 to 40 grams per day of fiber in the diet. It helps in decreasing the inflammatory cytokines like CRP, tumor necrosis factor, IL-6, and it helps, and also it enhances levels of short chain fatty acids. Now, fiber helps in improving the gut health, which may slow down in improving the gut health, which improves the recovery from illness. Healthy fats are necessary for vitamins, for essential vitamins, because fats help in absorption of vitamin A, D, E, and K. So 20 to 30% of calories should come from fats. The ratio of types of fats for health needs are saturated fats to monounsaturated fats to polyunsaturated fat is 1:1.5:1. Some sources of saturated fats, as you all know, as animal products and dairy. MUFA is present in oils, olives, soya, groundnut, almonds, rice bran, and good sources of omega-3 are flax seeds, sesame seeds, pumpkin seeds. And EPA and docosahexaenoic acid is present in fatty fish such as salmon, tuna, mackerel, sardines, etc. Now, besides these macronutrients, micronutrients like zinc, selenium, iron, copper, and vitamin A, C, E, and B6, folic acid also have important influence on immune responses. Vitamin A is involved in development of immune system and plays regulatory role in immune processes. So about 600 micrograms of retinol or 4,800 micrograms of beta carotene should be included in the diet in the form of red, colorful fruits and vegetables, which include carrots, pumpkin, dark green leafy vegetables, chicken, liver, eggs, etc. Combination of any three of these items would help in achieving the daily requirement of the nutrient. Antioxidants like vitamin C and vitamin E also play a very important role in supporting various cellular functions, and it helps in boosting immunity. So vitamin C should be around 40 milligrams per day in the form of amla, guava, orange, capsicum, broccoli, red amaranth leaves, etc. And vitamin E, the recommendation should be 7.5 to 10 milligrams in active form, that is alpha tocopherol per day. Good sources are almonds, walnuts, nuts, garden cress seeds, zucchini, spinach, sunflower seeds, flax seeds, etc. Vitamin D, also called sunshine vitamin, is also affects the immune responses. So one should take about 600 to 800 IU of vitamin D per day. This helps in increasing the susceptibility. This is associated with increased susceptibility to infections like COVID-19. So vitamin D that is present in eggs, salmon, tuna, fortified cereals, fortified milk, sardines, etc., helps in absorption of calcium that supports bones and teeth. Seeds, garden cress seeds, walnuts, poultry. And magnesium helps in acts as a cofactor for immunoglobulin synthesis, which are the immune cells of the body, and plays a role in immunity and fighting infections. Heroes today, no single food is a superfood and functions alone in the body, specifically as an antiviral food to prevent COVID-19. Certain phytonutrients present in foods can help boost immune function, and these are found in ginger, turmeric, then tulsi, basil, neem, lemon, which are rich in antioxidant and helps to boost immunity, and they work at DNA and RNA levels. Prebiotics and probiotics are very essential for gut health, and these are present in natural probiotics such as yogurt, kefir, pickles, miso, kimchi, and prebiotics are present in some fruits and vegetables, including mushrooms, garlic, onion, ginger, berries, bananas, and asparagus. Hydration is also very important. About 1.5 to 2 liters of fluids should be consumed every day in the form of green tea, juices, milk products, smoothies, coconut water, etc. So one should remain well hydrated always. But in case of diarrhea or vomiting, one needs to take in more fluids to rehydrate and replace electrolytes. Physical activity is also very important to rev up metabolism and to improve the immunity. So about 30 minutes of walk per day or 3 to 4 days a week, exercising 3 to 4 days a week is also is very important to maintain nutrition status and to improve immunity. So some of the tips for eating calorie-rich food are to consume more calories are, one needs to take 3 meals per day, eat 3 snacks, then save beverages to drink towards end of meal so you do not get false sense of fluid fullness. Then choose beverages such as milk, juice, smoothies to add on to calories. Also, you can include laddus, panjiri, shakes, ice cream, custard, etc. in your diet. Use olive oil, nut butters, and other healthy fats to push calories. For example, coat pasta or rice in oil before adding other sauces or flavorings. Saute vegetables in oil. Add nuts to salads, vegetables, yogurts. Add jam to toast, chocolate syrup in milk, honey in tea. So finally, recovery will take time, but by combining nutritional rehabilitation with physical rehabilitation, one can have a robust health. So finally, consuming adequate proteins at every meal is essential. Nutrients in whole foods work in synergy to support immune health and promote overall health. One should include enough calcium and vitamin D for absorption of calcium. Then it is also important to have probiotics and prebiotics for healthy gut to reduce further risk of infection and maximize absorption of nutrients. Consider supplements only if there is need for it, only if it is required. Continue to wash your hands regularly, get adequate sleep, maintain social distancing, and consult with a healthcare provider on regular basis to assess your progress. Also, very important is one should avoid smoking and refrain from alcohol and keep symptoms of chronic conditions under control. Thank you so much. Being healthy is a success that many people forget to celebrate.
Now we are going to move on to the third lecture of this session. And this lecture topic is immune boosters in common respiratory viral diseases, preventive and curative. And the speaker is Professor Mohan Gurjar. He is a professor in critical care medicine and is affiliated to Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. He published more than 160 articles, and the books he edited, the two books he edited in the year of 2015, the Manual of ICU Procedures, and in the year of 2019, he edited a textbook of ventilation, fluids, electrolytes, and blood gases. With this introduction, Dr. Mohan Gurjar, you can present your lecture, and we request you to finish off your lectures within 15 minutes. We'll be very grateful to you because we are running out of time.
Thank you, sir, for your kind words, and good morning to all. Just want to share that am I audible right now?
Yeah, very well, sir.
Okay, sir. So this 12 minutes or so, next I am going to talk about the immune boosters in the common respiratory viral diseases, their role as a preventive as well as the curative. Is the next slide is visible? Because hello.
Yeah, your slides are.
So in this talk, just the other two aspects going to cover the concepts behind the using the immunonutritions and what are the evidences available in the clinical practices. Just to declare that I did not have any conflict of interest related to this talk. Also, I am not a nutrition expert. I am actually the intensivist, but yes, I had interest in this area also. In the respiratory infection, what we see, the majority of time we see the mild symptoms, and sometimes the host means human body get severely infected, requiring the hospitalization, and very sometimes that it is a life-threatening, requiring the multi-organ support system. Why it is happen actually? Immune response is a very complex phenomena. With the same pathogen exposure, different human body, different hosts, they respond differently. In the initial part, there is a pro-inflammatory stage because of the ongoing pathogen exposure and oxidative stress. Slowly, there is a response from the immune system. There is a counter check called as a anti-inflammatory. So there is a balance between that. So that is a host body destroy the pathogens and protect himself from the damaging of this immune response. We have to understand difference between the infections. Are they same as the sepsis, or it is some different kind of the phenomena itself? I can say that all the sepsis patient must be having some infection, but all infection does not having the really the sepsis. Infection that case, in the initial phase, there is a very much balance between the anti-inflammatory and the pro-inflammatory. It's a regulated host response. While if there is a dysregulated host response, means there is a more pro-inflammatory phases from the immune side, there is a possibility of organ damage of the host, which can then you can say it is a sepsis. Why the host response is different? It is not only that particular host body, it is from the various aspects about the availability of nutrients in the human body, which help actually, which modulate anti-inflammatory and act as antioxidants. So these are called as immunonutrients or immunomodulators. Very well known immunonutrients are the omega-3 fatty acids, arginine, glutamine, few vitamins, including vitamin C, D, E, and A. Some micronutrients like the zinc, selenium, as well as the iron also. Going to talk about the vitamin C. This is the vitamins which has been extensively studied related to respiratory viral infections. Vitamin C reduces the oxidative stress, very well known fact. So ultimately it reduces the organ dysfunctions. So it protects from the barrier functions and the immunity response. So ultimately the host body is protected when there is a adequate vitamin C level is available. What are the clinical evidences? In the community populations, this is one of the RCTs from the UK, 2 decades old, where the UK volunteers had took vitamin C as a 500 milligram twice a day for 2 months during the winter session. So in this RCT, it was very much clear evident that the participant who took the vitamin C has a less incidence of the common cold, and it was for less duration. The role of vitamin C also has been seen for the pneumonia prevention and the treatment. These are also very old studies through the RCTs has been shown that it helps in the prevention, it reduces the incidence of pneumonia, and vitamin C also helps in the decreasing the severity of the pneumonia. In the recent severe COVID-19 disease also, it has been used actually. So one of the RCTs we came across where the high dose intravenous vitamin C was used as a 6 gram per day in this RCT, but there was in this study no show of any clinical benefit in terms of the mortality, in terms of the stay or ventilator-free day. How much vitamin C we should use for the common respiratory viral illness? For the oral, restrict up to the 2 gram per day, avoid more than 2 gram, and because when you use in the higher dose, ultimately there is a adverse effects, mainly is the GI. Intravenous, of course, can go up to the 6 gram per day, and there is advocacy for using the high vitamin C because there is a relatively high deficiency of vitamin C in cases of the infection. So, and there is no adverse effect while using the high dose through the intravenous route. Even the 6 to 12 gram per day appears to be safe, has been found in the various studies. The next immunonutrients, it is omega-3 fatty acids. It has 2 fatty acids, EPA and DHA. So these are act as immunosuppressant by reducing production of the pro-inflammatory omega-6 fatty acid. It also reduces the macrophage additions, alter T cell proliferations, and stabilize the cytokine response. It has been found in the various studies that it leads to the very much beneficial effect in terms of the respiratory systems, both disease and non-disease. In the disease like the COPD population, there is less incidence of COPD or asthma exacerbations. There is a better control if the patient is asthmatic, symptomatic wise, there is a less dyspnea. While doing the spirometry studies, there is a significant reduction in the airway obstructions while using omega-3 fatty acids. Regarding the clinical evidence of using omega-3 fatty acids and the respiratory infections, so it is called as a lung vital studies. It is a part of the main studies, a vital study where in the community-based study from the US, the results are still awaited. The main study of vital, they are intended to look for the effect of the omega-3 fatty acids and vitamin D in the prevention of the cardiovascular and the cancer incidence in the old aged populations, male more than 50 and female more than 55, where they had randomized and making the 4 groups, completely no interventions, and 1 group will having the receiving vitamin D and omega-3 fatty acids, and either of them and both of them. So they are the 4 groups. It's a huge randomized control trial, 25,000 participants. Inclusion has been stopped, completed in 2018. Results are awaited for 5 years follow-up. A subset of this main vital study is lung vital. So they are also looking, because the omega-3 fatty acid is promising in the respiratory infections. So they are looking the incidence of the pneumonia and COPD and asthma exacerbation. But we have to wait for next few years to get a response. Is it beneficial or not? Another micronutrient has been studied through well-conducted RCTs is zinc. It has been found that zinc, it reduces the common cold duration when you are giving the supplementation of the zinc in comparison to placebo. It not only reduces the duration, but it also reduces the severity also. Of course, each supplement is not without any side effects. Using the zinc is a more adverse event, mainly the taste change, GI constipation or diarrhea has been found in comparison when compared to the placebo arm. I can summarize that the role of immunonutrients in the respiratory viral infections in next 3 slides, that yes, there is a recommendations of nutrient supplementation in respiratory infections. These nutrients are considered as immune modulators. We have a list like omega-3 fatty acids, vitamin D, vitamin E, zinc, selenium, arginine, glutamine, vitamin C, vitamin A, and the iron. But for the respiratory infections, only 2 immunomodulator has been evaluated through the well-conducted RCTs, which I had shown you, vitamin C and the zinc only. The results of omega-3 fatty acids are awaited. Others are from the cohort studies there that they had concluded there is a beneficial effect. So about these immunomodulators, like Dr. Meenakshi has highlighted, there is no role in the COVID of these adding immune supplementation. So we don't know that it is a cause-effect relationship really, or it is a just bystander. It is a marker of the serious disease. We are not sure until unless we have a more well-planned RCTs to be conducted in the near future. We need more clinical evidence. Of course, dose supplementation, we are not sure about the, in relation to disease severity, is there any different doses are required? In the patients who are having the pre-existing deficiency, are there different dose supplementation is required? Single versus combination of these immunomodulators, is there any really beneficial to adding more than one? We need answers from the near future RCTs. At least in the near future, the lung vital will clear the controversy about using the omega-3 fatty acids in the terms of respiratory infections. Thank you.
Thank you very much, Dr. Mohan. It was a very good presentation. Just short and sweet also. And you have covered the immune boosters like anything, all the immune boosters. And you said very clearly, it's not immune boosters, it is immune modulators. Because we should not be more of pro-inflammatory, and at the same time, it should also not be anti-inflammatory. So we have to balance with the immunomodulators, and you made it very clear. Any queries from the audience? Thank you, doctor. Thank you very much. Now we move on to the last lecture of this session, Nutrition in Pulmonary Medicine. And the speaker is Dr. Mahesh Jansari, and he's an assistant professor from Chem Hospital, Mumbai. He is ex-fellow in Sion Hospital, Mumbai, ex-specialty medical consultant, group of TB hospitals in Mumbai. He is ex-ICU registrar in Mumbai Hospital, Mumbai, ex-website editor, Indian Association of Bronchology, national and international publications with credit. And we welcome Dr. Mahesh Jansari for your lecture.
Thank you, Vijay sir, for your kind introduction. I would like to thank IPN for conducting this conference in physical form. I'm really feeling like being human after the COVID. And thank you for giving me an opportunity. Yesterday, Vijay sir, we heard your talk about how did you reconnect the nutrition with all other parts. I hope that today I would reconnect the nutrition with pulmonary medicine.
All the best.
Thank you, sir. So malnutrition and COPD, estimated incidence of malnutrition and COPD is around 30 to 60% of hospitalized patients with COPD, and around 90% of ideal body weight is found to be in around 50% of the patients. And malnutrition can affect the pulmonary system, and pulmonary system can affect the malnutrition. So we see how the malnutrition affects the pulmonary system. There is impairment of respiratory muscle function, impairment of ventilatory drive, impairment of response to hypoxia, and overall all this causes impairment of pulmonary defense mechanisms. Once this defense mechanism is lost, there are recurrent infections, and this recurrent chronic infection causes a further malnutrition. So this is a positive feedback mechanism. Now we see how the lung diseases can affect the nutrition. There is an increased energy expenditure due to increased work of breathing. And in earlier slide, I explained how there is a chronic infection, recurrent infection. It also leads to increased energy expenditure. There is a reduced intake, and this reduced intake is due to increase in pro-inflammatory cytokines and appetite suppressant hormone, that is leptin. There is a decreased oxygen saturation when patient is eating, thereby decreasing the intake, anorexia related to chronic diseases, and there is a gastrointestinal distress and vomiting. Additional limitations are like difficulty in preparing the food due to fatigue, lack of financial resources because of lost jobs, and there is an altered metabolism as well. There is an increase in catabolism. So respiratory diseases are broadly classified into a chronic and acute, acute being ARDS and pneumonia, etc. And chronic is subdivided into obstructive like COPD, asthma, restrictive, vascular, infective like tuberculosis, etc. All the diseases which are there as of now on the slide can cause malnutrition, but the two diseases, they cause a major part of malnutrition are COPD and tuberculosis. So I'll be covering briefly about the COPD and tuberculosis. COPD. All of us know that COPD is chronic obstructive pulmonary disease. There is a chronic airway obstruction, airflow limitation due to exposure to noxious gases, and which causes the chronic symptoms like chronic dyspnea, cough and sputum, chest tightness, wheezing, weight loss, etc. there are two phenotypes of COPD, like chronic bronchitis and emphysema. These two subtypes are differ in their BMIs. Chronic bronchitis is a bloater on a higher side of BMI. However, the emphysema is on a lower side of BMI. So dietary advice in these two patients differ a little bit. So poor nutrition causes fat-free mass loss. This weakens the respiratory muscles, specifically a diaphragm. This is a very important inspiratory muscle. And because of this weakness, there is a difficulty in coughing out the sputum. This causes a retention of sputum, causing a recurrent infection. And because of this recurrent infection, there is a progression of disease. So this is again, as I mentioned earlier, is a positive feedback. This is a poor nutrition will cause a disease progression, will cause a disease, and it will again cause the malnutrition. So weight loss in COPD. Gold guidelines are the most prominent guidelines to address the COPD. So 2022 guideline mentions that weight loss has a poor prognosis and there is an increased mortality. And this poor prognosis is independent of disease severity. Means even though patient is having a mild COPD, however, there is a weight loss. This mild COPD with weight loss has a poor prognosis as compared to a only severe COPD without weight loss. So diet low in fruit, vegetables, and high in meat and potatoes causes increased likelihood of developing COPD. However, this weight loss is reversible, and this weight gain causes of functional improvements, as well as there is a reduced mortality, and all these are related to a hormone upregulation of a pro-inflammatory hormone, that is a leptin. So nutritional management broadly divided into two things, like a stable COPD management and acute exacerbation. In a stable COPD, it is managed on the OPD basis. The calories targeted, actually I'm a clinician, and there are a lot of senior dietitians, nutritionists are sitting here. So this is for the beginners. You can manage this dietary management, protein supplements better than us. But in stable COPD, what we go for is a calories we target 25 to 35 kilogram per kg per day. Proteins 0.8 to 1.5 grams per kg. Fluid 30 to 35 milligram per kg per day. However, in acute exacerbation, it should be managed on the OPD basis. There is no specific recommendation for the dietary management. However, the protein we should target is around 1.5 gram per kg per day. About the fluids, acute exacerbation related to a right heart failure, we cannot go for 30 to 35 ml per kg per day. We have to restrict the fluid 1.5 to 2 liters, keeping in mind patient's vital parameters. Pulmonary rehabilitation plays a pivotal role in management of COPD patients. Vitamin D should be supplemented in patients in whom there is a deficiency. And it has been found that when we correct this deficiency, there is a 50% reduction in episodes and hospital admissions. Antioxidants should be supplemented whenever there is a deficiency, and exercise as a part of pulmonary rehabilitation should be encouraged. So pulmonary rehabilitation plays a very pivotal role. It includes exercise training, education, breathing and retraining, nutritional advice, and psychological support. So tuberculosis is a deadly infection, as we all know. The dynamics of nutritional management tuberculosis differ from a COPD. So in this slide, the factors influencing progression from latent to active TB, there are three different heads, on which the lighted one in the red, these are the factors which directly may affect nutrition, like nutritional status, poverty, diet, employment status, socioeconomic status, and public policy. So as I mentioned earlier also, undernutrition causes an impairment of cell-mediated immunity. And when this immunity is on lower side, infections like TB increases. And once there is a tuberculosis has been set in, it causes the further decrease in appetite, increase in protein catabolism, it increases the energy expenditure, and this further aggravates the undernutrition. All of us know the symptoms of tuberculosis like cough, hemoptysis, fever, weight loss, loss of appetite, etc. But point to emphasis here is the red flag signs. Whenever you find a BMI of 14 to 16 with no appetite, or BMI 14 to 16 with bilateral edema, or patient is unable to stand, or BMI is less than 14 or hemoglobin is less than 7, whenever you find these red flag signs, refer the patient to clinician immediately, and clinician may consider the inpatient management for such patients. So effect of undernutrition on different outcomes. There is an increased morbidity and mortality. As there is an altered metabolism, it causes the drug toxicity and default of the treatment. And whenever there's a default of treatment, it increases the chances of drug-resistant tuberculosis and treatment failure. One of the key drug had a subtherapeutic levels in malnutrition, and it may aggravate the drug resistance, thereby morbidity and mortality. Relapse have been found whenever there's a poor weight gain and there is a low BMI. That's how it increases the burden of the healthcare. And poor functional performance causes the loss of wages. And whenever there's a loss of wages, economical issues come into play, thereby the TB household contacts may have reactivation of tuberculosis. And whenever there's a severe undernutrition, there is an atypical presentation of tuberculosis. Whenever there is an atypical presentation, it delays the diagnosis, further aggravates the morbidity and mortality. So typically the tuberculosis presents in upper lobes. However, in severe undernutrition, it presents in lower lobe. Tuberculosis usually presents in a chronic form, but in a severe undernutrition, it may present in an acute pneumonia. And Mantoux test is a surrogate marker of immunity to tuberculosis, which is usually negative despite patient being positive in severe undernutrition. So tools for nutritional assessment, there is a ABCD approach. It's very easy to remember. A for anthrometry, B for biochemical lab assessment, C for clinical assessment, and D for dietary assessment. So in anthrometry, everybody knows about the weight, height, and BMI we calculate. However, if patient is pregnant or patient is having edema, then this weight is deceptive. So here we should go for the mid-arm circumference. Biochemical labs like hemogram, renal function test, liver function test, sugar levels to rule out the diabetes, and electrolytes in severe malnutrition. And clinical assessment, there's a famous acronym, PICCLE. This PICCLE stands for P for pallor, for anemia, I for icterus, C for clubbing, then cyanosis for respiratory failure, lymphadenopathy, and edema. Whenever there is a severe pallor, severe anemia, it causes a further loss of appetite. So that should be addressed. Icterus, patients comes to you and you find patient is having icterus, no appetite. You have to rule out a drug toxicity and jaundice. If you do not address these issues here only, patient is not going to tolerate drugs, neither he is going to tolerate the nutritional management. And edema, whenever there's the edema, the most common reasons for the edema is severe hypoproteinemia and severe anemia. So it should be addressed whenever necessary. And dietary assessment like appetite, what is the intake of patient, whether the patient is having access to nutritional programs, and food preferences like vegetarian and non-vegetarian, and type of food which patient prefers like Maharashtrian food, Gujarati food, Rajasthani food, or South Indian food, etc. So nutritional counseling, usually we target a calories around 40 kilogram per kg ideal body weight, proteins 1.2 to 1.5, fat and micronutrients similar to general population, and once daily allowance in the form of multivitamin supplement is recommended. However, whenever we advise a multivitamin supplement, we should keep in mind the drug interactions and pill burden. So practical points for nutritional counseling: balanced diet, it should include all food groups like protein, carbohydrate, fats, vitamins, micronutrients, etc. It should be cost effective and locally available. Frequent feeding like 3 meals, morning, afternoon, and evening, and in between this we can slip in 2 snacks. Tonics and IV drips, a patient from villages, patient from lower economic status, they usually ask for the tonics and IV drips, a colorful IV drips. This IV drips hasn't shown any benefit. However, it has increased the side effects of ATT. Whenever there are red flag signs you encounter, refer the patient for IPD treatment. Follow-up ideally should be monthly, but at least 2nd month, 4th month, and 6th month of the anti-tuberculosis treatment should be followed up. Weight gain target should be 5% of the baseline in the first 2 months, and the target BMI should be 21 kilogram per meter square. So about the anti-tubercular treatment, this is a very pivotal for the treatment of TB. All drugs ideally should be given on the empty stomach. However, it is very difficult to give a drugs on an empty stomach every time. So whenever there is a possibility, we should advise the drugs on empty stomach. If not, ask the patient to take a food, wait for 2 hours, give ATT, and then again wait for 2 hours. The reason behind is a increased drug absorption on an empty stomach. Higher the ratio between minimum inhibitory concentration and peak plasma concentration, better the killing of tuberculosis bacteria. So always and always ATT should be preferably given on empty stomach. Adjust the doses as per weight. If patient is on lower weight side, lower weight band, go for the ideal body weight. If patient is on higher weight band, go for the adjusted body weight. Avoid excessive use of proton pump inhibitor, that is pantoprazole, omeprazole. It causes a decreased drug absorption. However, antacids and H2 blockers are acceptable. Usually ATT is supplemented with pyridoxine to avoid the neuropathy related to INH. However, excessive use of pyridoxine, more pyridoxine has been given in drug-resistant tuberculosis treatment, and pyridoxine itself can cause neuropathy. So we should keep in mind about the pyridoxine supplements. Avoid unnecessary multivitamins and iron supplements. Our goal during the treatment is to go for anti-tuberculosis treatment than other supplements. First ATT and then others are supplementary. So conclusion, weight loss affects the pulmonary function and physiology, vice versa. Nutritional management is an integral part of multidisciplinary approach to pulmonary disease, mainly COPD and tuberculosis. Proper nutritional care is a fundamental to good clinical practice. Thank you.
Thank you very much, Dr. Magesh. For 2 things I like to appreciate you. One is for your physical presence here to present your lecture. And second, I think you are the first speaker who finished your topic in the stipulated time of 15 minutes.
Thank you, sir.
And
Congratulate him on another thing.
Yeah.
The slides are very clear.
Very.
Very clear. They were not cluttered. So congratulations.
Thank you.
And coming to the carbohydrates, which you had discussed in your topic, to me, I think you are so liberal in allowing your patient to take more of carbohydrates. But carbohydrates per se, we used to say that the end product of glucose is carbon dioxide and water. So they will tend to accumulate more water in the body, and at the same time, they'll produce more carbon dioxide. The respiratory muscle has to work more. Both in the acute stage and in the chronic phase also. Better to keep the patients in a very minimal carbohydrates. It's a non-protein calories we have to minimize. It's my thought. Do you have any other thing to highlight in the particular?
Yes, sir. I'll go with you, sir.
No, not like that. I'm just asking you to get enlightened from your side.
Sir, about all these infections, the main in tuberculosis, the pivotal treatment is anti-tuberculosis treatment. It has been, there are different things like appetite enhancers, like cyproheptadine or appetizers have been tried, different multivitamins have been tried. However, the randomized control trial hasn't shown any benefit with this. Only ATT is a pivotal. Rest everything is supplementary. As you mentioned about the carbohydrate having a high respiratory quotient of 1 increases carbon dioxide, that is a very well point you have mentioned, sir. But giving only too much of protein to a very cachectic patient, sometimes it becomes very intolerable for them. So giving a balance of 25 to 30 kilocalories, addressing 40 to 50% of carbohydrate in the initial phase is very important. Once the patient starts tolerating in a 3 weeks, 4 weeks time, then we can decrease the carbohydrate and increase the protein.
Normally see food fats with these patients because I normally have a lot of these problems. Nobody is taking curd, salmon, and banana, lemon. They all think it causes a lot of cancer. So what do you face this problem? I mean, it actually adds on to the malnutrition which they already are.
Ma'am, it has been earlier it has been thought that this extra sputum.
We can proceed.
Excessive sputum loss in this chronic diseases can lead to a lower proteins. However, all these things will improve once the patient tolerates the ATT. And this is a
You know that they had milk and it causes more problems. So they just go on eliminating the foods and they link it to the attack.
ma'am, most important part of any disease management is the patient counseling. Unless patient has been counseled properly, he is not going to take the treatment, however best your treatment is.
Does the medical team believe in it? Because most of the time they'll say, doctor ne mana kiya hai. Nahi mana kiya. So is that right?
No, that's
Does
not
the
right.
medical team also support that?
Sometimes, ma'am, we say that I have a common cold, and as per the Indian Ayurveda, we say that we should not be taking the curd and lemon. But however, you have already suffered from a common cold, it's not going to give you common cold. And now in the previous speaker has mentioned the role of vitamin C in common cold. So that's a misconception. So we have to counsel the patient.
Coming to the TB diet, doctor, in those days, when we have a TB sanatorium, there is specific diet for the TB patients, tuberculosis patients. Do you suggest any specific diet for them?
Sir, as I mentioned, India has around 30 states. There is so much diversity of population. One diet cannot fit all. So 6 years back, in a government program, I had given I'm not a nutritionist, but there was one competition. So I had given a super sattu diet, which I did not mention because of lack of the time. So I have devised one sattu diet, which targets the proper protein, fat, and carbohydrate. And this one single super sattu diet can be used in a sweet form, can be used in sour form, can be used with banana, which is available locally, can be used with coconut, and can be used with fish. So that is the only super sattu diet which comes to my mind as of now, which can address all the issues. But one diet cannot fit all.
What's your opinion on the fat intake in those people, the respiratory disease people? Because we want to avoid carbohydrates. We want to give more proteins. What's your say on the fat?
Fat is having very condensed energy. So initially there is a appetite is on very lower side. So you can give a condensed calories in the form of fat is okay. That is advisable.
Any questions from the audience?
Good morning. So you have done a very empirical presentations been made. Thank you so much. So I have 2 points. So respiratory said that the carbohydrate percentage for the lungs patients, for the respiratory patients, we have to always check the RQ value, the respiratory quotients, whereas for the carbohydrate is 1, for the protein is 0.7, and for the fat is 0.8. For the protein is 0.8 and fat 0.7. So in that cases, we have to check on these respiratory quotients. And the respiratory quotient is basically the amount of oxygen being released and amount of carbon dioxide being released after having the food. That's why the the too much of phagia or binge eater should not be there for the lungs patient. This is number 1. And number 2 is for the fat percentage could be very good amount of the MCT. The medium chain triglycerides is good for the lungs patient. But my questions to you, you have mentioned the heart failure. For the right-sided heart failure patients, though, basically the previous drug was the enalapril and what the gold standard therapy for the AC inhibitors. But nowadays there are some different drugs. Is the ARNI, angiotensin receptor neprilysin inhibitor. Those patients having after the drug can suffer from the hypotension or the hyperkalemia. So is there any kind of dietary changes that you want to make, or is there any kind of drug to drug interactions that you have to make? This is number 1. And number 2 is that there is any kind of chances for the obese people to get more affected for the COVID-19 patients, because the obesity have their diaphragm is, there is a very shrink kind of thing due to a lot of android fat or the visceral fat is there. So lung capacity will be very lower. In that cases, the lungs lobes are lower, so there are chances of the the respiration, everything is there. So is there any other mechanisms that you want to make, because you are a clinician? So that is from you. Thank you so much.
So first I'll address your second question in a very short time. That obesity, there is an increase in COVID morbidity. It is related to the obese patient have a higher blood levels of pro-inflammatory cytokines already. And whenever there is an added infection like COVID, which can further cause the dysregulation of the cytokine. So that's how in obese patient, there is an increased morbidity and mortality. Second, you mentioned about the right heart failure and drugs. So right heart, the treatment for left heart failure and right heart failure is a bit different. Left heart failure, we require drugs mainly. For the right heart failure, it is an end result of persistent chronic hypoxia. Persistent chronic hypoxia causes the pulmonary hypertension, thereby cor pulmonale, and whenever there's a decompensated failure, it causes a right heart failure. So the key treatment for this is oxygen supplementation and fluid restriction. However, fluid restriction every time is not possible. So sometimes we have to take the help of diuretics. So, but using a diuretic, it may cause an electrolyte imbalance. So you have to keep a balance between patient's fluid output and electrolytes. Okay. Thank you, sir.
Thank you so much.
Thank you, sir. I request Anita ma'am to please give a token of thanks to Dr. Mahesh. Dr. Vijay Kumar, sir, please give a token of thanks to Ms. Datta for chairing the session.
Thank you so much. Good morning, everyone. And with this, we go on to our next session, which is on transplant nutrition. And it's an honor and privilege to invite our esteemed chairpersons here, Dr. Manjunath. Dr. Manjunath is MBBS and MS General Surgery. He is additional professor, Department of Surgical Disciplines, AIM, New Delhi. And he is into renal transplantation surgery, pancreas and intestine transplantation surgery, vascular access surgery, advanced laparoscopic surgery. And we have another chairperson who is joining us remotely, Dr. Brahmadatt. Dr. Brahmadatt is MS and he's a fellow and presently working as assistant professor, Department of Surgical Gastroenterology, AIMS, Bhubaneswar since January 2020. So thank you so much for joining us, Dr. Brahmadatt and Dr. Manjunath. And may I request you to introduce our speakers and take the session further. Thank you so much.
Good morning to you all. Ma'am, वो paper दे दो ना. Good morning, everybody. I'm Dr. Manjunath. I would like to introduce the speaker, Ms. Himani Puri. She is the founder proprietor of Sattva NutriCare, Chief Dietitian, Apex Hospital, Nashik. She has a qualification of MSc and certified diabetes educator and trained on FODMAP for IBD, Monash University. Madam, you may proceed with your presentation.
Thank you, sir. A very good morning to everybody. And thank you to the organizers for giving me the opportunity to talk on the topic on renal nutrition. So I'll be very brief in my presentation and try to respect the time which is allotted to me. When we talk about the nutrition care for the patient, pre-transplant and post-transplant both are very, very critical for us. I'll be covering the pre-transplant and Zamrut ma'am would be talking about the post-transplantation. So before we head towards the nutrition, we need to understand that what basically is the kidney transplantation. Kidney transplantation is not the cure for kidney disease or for the ESRD. It is a part of the treatment for a kidney failure or for as an SPK transplant. Transplantation, however, requires a lot of follow-up from the patient side towards the medication and towards the nutrition as well. The transplant can definitely prolong the life expectancy, but cannot resolve the CKD issue completely. We also need to understand how the transplantation works. We all know that yes, the kidneys start working immediately many a times. Sometimes a few dialysis sessions might be required post-transplantation. Very, very rarely we might see a rejection. For that, the patient has to probably undergo the kidney transplantation again within the 90 days. There are certain criteria for the patient to be eligible for kidney transplantation. I would not be going into details of that because of paucity of the time. However, there are certain other relative contraindications as well. And the major one, the prime that we need to be concerned about as a dietitian is about the obesity one and the comorbidities which the patient might be having or pre-existing before the transplantation. Also, we need to know that when a patient is coming to us for transplantation, we are managing the patient on the ESRD protocol. The patient usually are on dialysis. Usually, it could be in ESRD or it could be that the 20% of the kidneys are still functioning. So we are working towards the macronutrients and towards the micronutrients both. There are certain times, days, durations, like probably a person might become eligible for the transplantation, but it might take from 1 year to 7 years for the transplantation to actually occur, depending upon the availability of the organ on the donor. So those 1 year to 7 year, or maybe lesser than 1 year, is very, very important from the nutrition point of view as well. We need to be assessing the patient for the nutrition status, and it should be done regularly. Ideally, 3 or 4 months, or maybe 6 months should be what we should be looking at. We should be assessing the patient for the food diary or for the food reviews and try to assess the multi-nutrient deficiencies or the micronutrient deficiencies that might be occurring because of the condition or the ESRD itself and because of the compliance of the patient with the diet. There are certain other biomarkers which we have to look at along with nutrition assessment. We all know about the biomarkers. It is the albumin, the pre-albumin, the transferrin, the TIBC. The assessment tools that we can use to assess the patient for malnutrition are the SGA, or we can use the MIS form. And both of these are good indicators to assess the patient for the malnutrition status and thereby form the basis for the nutrition management therapy. The nutrition management therapy should be individualized, as we all know. We should be looking at the macronutrients, the micronutrients, but we should be also addressing the inflammation. We should be looking at the electrolyte imbalances, anemia management, and bone health also should be taken into consideration. So nutrition care before the transplantation, as I said, we look at the macro and the micronutrients. We look at the multivitamin supplementation. And probably if the person is requiring, we might put him or her on the ONS also. The protein and the energy intake becomes the basis for the nutrition management. We all know that 2/3 of our proteins should be coming from the high biological value proteins. The ESRD patients usually have a very poor appetite. Therefore, nutrient-dense foods is what we should be looking at. Sometimes because of the volume management that we have to look at, the volume intake, the fluid intake would be low. And therefore, the challenge is on a low fluid and a high calorie and a high protein diet if the patient is on dialysis, and not on dialysis, then a low protein diet. So we could be probably looking at around 0.5 to 0.6 grams of protein per kg per day. Or if the patient is on keto analogs, maybe around 0.28 to 0.43 grams per kg body weight per day. The calories could be around 20 to 35 kilocalories per kg per day if the patient is on dialysis. And if the patient is on a high catabolic condition, we can go up to as high as 30 to 35 kilocalories. We need to understand that we have to induce an anabolic situation for the patient so that there is no malnutrition, there is no further wasting, and we are able to address the malnutrition which is already existing. So we have to advise on the patient. If the patient is overweight or obese, we have to look at weight loss, yes, but not at the expense of losing the muscle mass. So we should be looking after the nutritional deficiencies along with the weight loss, because excessive somatic stores can often overmark the nutritional deficiencies. We should be assessing for the lean body mass, for the visceral protein status, and for the micronutrients. And the BMI criteria set by the transplant doctor or the nephrologist before the transplant surgery. This was a study done and it checked upon the obesity and the outcomes of obesity after the transplantation. And what they observed was that obesity was an increased risk of adverse transplant outcomes, and there were more chances of failure, increased urine protein, and acute rejection. Therefore, obesity should be considered a relative contraindication to living kidney donation. As was observed, almost 28.3% of obese patients had more complications as against 8.2% only in the non-obese patients post-transplant surgery. Also, sometimes the patients come to us with diabetes prior to transplantation. Usually we see that towards the ESRD, there is better compliance or there is better diabetic or glycemic control. That is because of the reduced functioning of the kidney. However, post-transplantation, because urine excretion improves, because insulin excretion is improved, we would see a sudden rise in the glycemic value. So therefore, the duration from the assessment to transplantation should be used as a golden period to educate the patient for the glycemic control, to educate the patient for better diabetic diet. This was study done about the use of the ERAS protocol for the transplantation, and it was observed that following the ERAS protocol before the surgery helped reduce the length of stay in the hospital by 2 days. However, not much study has been done about the application of the ERAS protocol in the renal transplant situations. There was another study done which said that by using the ERAS protocol, there was definitely a reduction in the length of stay and the quality of life of the patient had improved. There was also significant improvement in the bowel movement of the patients, and also the bed rest post the surgery was reduced in the ERAS group of patients. However, as I said earlier, we still need to work more on the ERAS protocol pre-kidney transplant because a lot of not much studies have been done on that. So to conclude, as stated in the UCLA Health website, hydration is the key to surgery. Plenty of fluids, at least 2 hours prior to the hospital is what is advised. Solid foods or complex liquids at least 5 to 6 hours before the surgery has to be avoided. Make sure that the patient has a proper bowel movement and he has his clear movements at the day of the surgery. If not, the patient can be given laxatives for the same. So to conclude, we need to understand the dietary pattern of the patient, and we should be looking at diet which is going to reduce the metabolic complications. We also need to address the diet pre-transplant to avoid the post-transplant complications like dyslipidemia and CVD. And again, as I said, we need to have more studies done on pre-renal transplant nutrition to understand what is actually advised for the patients for the undergoing the transplantation. To conclude, the Renal Nutrition Core Group IPN is organizing a recipe contest because of the World Kidney Day, which was on 10th of March. The last date for the submissions is 25th. So you all are requested to participate in it. And there is a webinar happening tomorrow. You can take the screenshot and you can scan the QR code for the participation in the webinar tomorrow. Thank you so much. Thanks.
Thank you, madam. Is Miss Jamarud Patel is presenting? Yes. Yeah, I now call upon the next speaker, Miss Jamurud Patel.
Before that, may I request Himani to please stay on the stage. Dr. Brahma, may I request you to kindly felicitate her?
I am Dr. Manjunath.
Oh, sorry.
Ms. Jamrud Patel is head of the department, chief dietitian, Global Hospital, Mumbai. She is registered dietitian, Indian Dietetics Association, postgraduate in dietetics, SNDT. Yeah, she is a distinction award for excellence in nutrition practice 2020 district level by IPN. She has several publications and books published. I give it on to Ms. Jamrud for her presentation.
Thank you for that kind introduction and a very good morning to all. Firstly, I would like to thank my IPA team for giving me this opportunity. So, pre-transplant, you have heard Himani that nutritional counseling is very important, and ideally for a transplant candidate, it's very important nutritionally to be counseled well pre-transplant. Only then our results post-transplant would be good. So I'm not repeating because the slides were done by Himani, and it's basically that a new kidney is given to the person, a new leaf of life the person gets, and definitely nutrition is very important for this person. So the goals for nutritional management is to be providing adequate nutrition, to prevent deficiencies, to maintain good nutritional status. And actually, if you ask me, there is no basically a transplant diet. Diet needs to be tailor-made as per the person's requirements, as per the person's ethical background. And definitely you need to prevent the complications that happen post-transplant. And the commonest ones are obesity, diabetes. These are something which we commonly see in transplant patients. So there are changes that happen post-transplant in people. So first and the most important thing is that transplant is a form of replacement therapy that the person gets. You get new functions, your kidney functions get normalized now. So whatever were the complication that we saw pre-transplant, that is loss of appetite because waste were not flushed from your body, that normalizes. Person is able to eat well. So definitely the protein energy wasting that we saw when the person had chronic kidney disease is getting reversed. So definitely these people look better 6 months down the line post-transplant. There are immunosuppressive medicines which are used. There are steroids which are used post-transplant as medications. Definitely that also improves the appetite of the person. Overall, you find that when you feel good, you eat better. Okay, so that's what happens, and because of the medicines which are used post-transplant, definitely the appetite gets better. So this is just to show you that how we make a prescription for a patient when you have to do the nutritional calculations. So immediately when you are seeing a person for the first month after transplant, probably you will see that we give a protein intake of about 1 to 1.2 grams and calorie intake is between 30 to 35 kilocalories. After the first month of transplant, we bring down the protein intake to 1 gram. We don't go up to 1.2. And now we start thinking at this stage itself to maintain your or to achieve your ideal body weight, not to allow the person to gain more weight. Because whatever I have seen in 25 years of my career with transplants, I have seen that people get to gain maximum in the first 3 months. First, after the first month, they start gaining weight. So probably as nutritionists, if we start counseling them after the first month of transplant, you get better outcomes. And of course, this is a standard prescription that we use, where energy we will balance as per to maintain the ideal body weight, and protein intake probably we now have started keeping between 0.8 to 1 gram. The total calories coming from fat has to be less than 30%. And again, these diets have to be calculated for cholesterol. And again, if you ask me, a transplant diet is more like a diabetic diet. So you have to look up at your carbohydrate level coming from your diets. So there is a need for nutritional assessment in kidney transplant, because I've already highlighted weight gain, that is obesity sets in, there is dyslipidemia, you get NODAT, that is new onset of diabetes post-transplant, which are commonly seen in most of the patients of kidney transplant. So it's very important to assess the nutritional status, and probably we start doing this from the pre-stage of transplant. Nutritional assessment and nutritional counselings are being done. Now there are various tools that people use, and probably what we have been using is the SGA, the 7-pointer SGA that we normally use for our patients pre and post-transplant. So now let us talk of the 4 major challenges that you see post-transplant. First is the weight gain or and obesity. Second would be NODAT. Third would be hypertension and dyslipidemia. So when I talk of weight gain, is weight gain the real weight gain? Okay, so before transplant, we all know that when the person is having chronic kidney disease, there are metabolic and hemodynamic changes that are happening in the person's body, and there is development of protein energy wasting in these patients. So further, when they go on dialysis, further their nutritional status gets compromised. So therefore, at the time of transplant, you find people having low body weights. Okay. Now, unfortunately, as nutritionists, we get to see people not from the initial stages. We see patients from probably stage 3 or 4, where already there is a lot of wasting that has happened. So we really don't know actually what was the weight the person was having pre-disease. Okay. So after transplant, again, because there is normal restoration of kidney function, use of steroids, there is weight gain. And mostly we see that the weight gain comes in the first year. Now, this is just to show you our data where we tried to see that how much is the weight gain, and we found out that actually whatever weight gain comes, 10 to 12 kilos comes in the first year post-transplant. So probably nutritionists play a major role to counsel patients pre and post-transplant in the first 3 months immediately after transplants to avoid this happening. And again, one has to understand that the dietary prescriptions, as I've told you, it's a low carbohydrate, low calorie diabetic diet, as I have shown you the prescription earlier. In fact, I was just trying to assess a patient of mine, probably whom I was seeing when he was just a diabetic, and today he's reached in 15 years diabetic kidney disease, and he's undergone a transplant. So when I was seeing his weight, when he started as a diabetic with me, his journey, he was 95 kilos. When he reached diabetic kidney disease, he came down to 80 kilos. And when he actually underwent transplant, he was 70 kilos. So he already had a significant weight loss, where from a diabetic till end stage kidney disease. So probably this person, if we have been able to counsel, now he's completing 1 year of transplant, but still he's gained 10 kilos. From 70, he's reached 80 kilos. So probably we really need to still counsel them, but whatever said, once you start feeling good, your appetite gets better, you start eating. So you really need to counsel these people very well. So good counseling pre and post transplant is very important. And of course, we have started giving patients a lot of these handouts where we try to give them, behavior modification tips, low calorie tips, so that they are able to see and they themselves can help themselves. So the second challenge is NODAT, new onset of diabetes post-transplant diabetes. Again, because of the steroids, because of the immunosuppressive medicines, there are a lot of changes that happen in the body, and probably because of that, you find that the drug which is used post-transplant, tacrolimus, gives impaired sugars. So probably here we really need to work with the patients and provide them with diabetic diets. This is our data where we have seen 316 non-diabetic patients who had undergone kidney transplant. 119, that is 38%, developed NODAT. They had majority developed in the first 3 months post-transplant. 69% have recovered as steroid and immunosuppressive drugs were reduced, their prescriptions got down. 69% recovered, but 50 of them, that is 16%, have become diabetic. So you really need to understand that people who are non-diabetic, who are going for transplant, can develop diabetes, and probably they need to be educated about it, they need to be counseled about it, and the right dietary prescription needs to be given to them. So probably it's a diabetic diet. When as nutritionist, I can see most of the house full of nutritionists, so I'm not getting into the detail of actually planning these diets, but probably you need to think about how much carbohydrate you're giving, and probably look at complex carbohydrate rather than talking of any simple carbohydrate to them. The type of carbohydrate, again, as I've told you, complex is better, fiber is better for our patients than giving them simple carbohydrates. Again, sources I've just listed down, and this is, if you see a traditional Indian diet, probably these are the foods we all eat on regular basis. Talking about the third major challenge, that is hypertension. Now, is hypertension a real challenge? Because whatever I see today, hypertension is one of the renin-angiotensin system is also a part of your kidney function, and probably people who have chronic kidney disease may not be hypertensive, but as the kidney function deteriorates, they develop hypertension. Okay, so if the kidneys plays a major role in the pathogenesis of hypertension, and I'll just show you how one of our patients, this is our data, where we saw our transplant patients BP after the transplant. So we had around 50 total, 77 patients, 53 were males and 24 females. And I'm just going to show you the number of pills that they took. It was around 2.5 pills that was taken pre-transplant, and post-transplant after 3 months, the pill size came to 1 tablet. So definitely kidney plays a major role in the pathogenesis of hypertension, and probably once they undergo transplant, they would recover. But then you don't have to forget that because of the changes in the food pattern that happen, people start eating a normal diet, and probably if you see WHO's guideline, a normal person should be having about 5 to 6 grams of salt, and an average Indian diet ranges between 10 to 15 grams of salt. So we are almost eating 3 times. So again, this will happen with these people and they can have a problem. So you really need to work on blood pressure control of our patients, and the prescription has to be a low salt prescription, where again there is no definite guideline which says that you use 2 grams, you use 4 grams, or you use 5 grams salt. It has to be individualized on your patient's need. Again, talking of low sodium diets, not only in terms of salt, it's very important. And the salt substitutes, as nutritionists, we all work with our patients and train them as to how they can use these flavors of amchur, tamarind, kokum, or the herbs and spices which are unsalted in their diets to make the diets palatable with the limited salt intake that they need. We work with a lot of our patients where we develop a lot of recipes for them based on what they need. So this is just one recipe of a chaat masala, which normally we advise everybody to keep it, replace the salt shaker with at the dining table, and it can be used by the full family. It's just jeera, pepper, cinnamon, and amchur. So the sodium content is not that high. Again, coming to the last challenge of the dyslipidemia, again, because you have obesity, you have diabetes, high blood pressure, dyslipidemia sets in. The role here, the medicines play a major role in post-transplant cases. So you really need to give them a low-fat diet. I'm sure we all are doing this for our transplant patient, where the total calories coming from fat would be less than 25% to 30%. And again, you need to pay a visit to the cholesterol content of the diet. I heard a topic which was discussed on vegan diets in the morning, but if you ask me, it's easy to say, but whatever is the ethnic background, if you tell a Bengali not to eat fish, I'm sure it's not going to be practical. So you really need to check the cholesterol coming from these diets of these patients as per their preferences. The type of fat is very important. You maintain your proper rations or proper ratios of MUFA, PUFA, and saturates. That's very important. So to summarize, nutritional status is actually improves after successful kidney transplant with regain of the lost weight with that happens during the progression of the disease. NODAT is a challenge in 10 to 20% of the non-diabetic patients. Hypertension actually improves post-transplant, and dyslipidemia is a challenge and must be treated with the lifestyle modifications. So thank you for your patient listening, and these are some of my publications that can help your patients. Thank you.
Thank you, madam. It was a very good presentation. In fact, I have been doing kidney transplantation since 2016. I remember, and I would also suggest the same thing. We need to have a joint clinic because a lot of titrations of medicines tend to occur post-transplantation, and definitely a low sugar and low salt diet is done recommended. However, what happens is the patient keeps going in, some of the patients go in rejection. The medicines tend to we tend to increase the dosage of certain immunosuppressants, and the initial few months the doses of the steroids are quite high, and that is why the sugars tend to be at a higher side, and this is where a joint clinic would really benefit the patients. Thank you. It was a very good presentation, ma'am. However, I would ask the audience, you can ask any questions and the queries if you have. Any questions? The presentation is open for the questions and discussion. Well, it was a
Thank
good
you.
presentation, madam.
Thanks.
Dr. Manjunath, can you please felicitate Zamrud for the excellent presentation that she made?
Dr. Brahmadat will introduce the next speaker.
Okay, thank you, sir. So now may I invite the next speaker, that is Dr. Ashok Chaudhary. Am I audible, sir?
You are audible, sir.
Yes, yes. So next speaker is Dr. Ashok Chaudhary. He's a very renowned transplant hepatologist who has worked in liver transplantation for more than 10 years now, and presently heading the Department of Institute of Liver Sciences in Narayana Health, Gurugram. And previously, we worked together in ILBS New Delhi. He was the chief of transplant hepatology in ILBS, and he is also the honorary professor in KIMS Bhubaneswar. And he has published more than 50 papers specifically on liver transplantation. And he is a coordinator of SCLF, Apostle group of SCLF studies as well. So I believe he is the best person to give a lecture on perioperative, especially liver transplantation nutrition, because he has observed this pre and post transplant patients very closely for more than 10 years now. So I invite Dr. Ashok Chaudhary to give his lecture now.
Thank you. At the outset also, thanks IPN for giving this opportunity. So I think there is little partiality. For the kidney, they have given to 2 people, and for liver, there is 1. So I think we have to give a detailed cover for the pre as well as the post. So just to go, I will cover on these following outlines. You can see a patient for liver transplant nutritional issue, ALF, which is an emergency. Relatively, they are preserved as per the nutrition. ACLF, they are partly preserved, depends on the duration of illness, but still it is acute. Compensated cirrhosis, they have some malnutrition, but when we go to decompensated cirrhosis, they are having severe malnutrition. So we see the whole spectrum of these nutrition problems in a patient who is listed or referred for the transplant. And you can see the malnutrition increases gradually as the severity increases. You know, commonly the child spook score, you can see child C nearly all. And this malnutrition per se has a additional 20% mortality addition. And this increases the mortality. And now for the acute, there is SLF and ALF, it is coming up gradually. So why these peoples are special? Because in liver disease, there is a pathophysiological change in GI system. They have a metabolic system disturbances throughout. The gut in different phases has a leaky gut, sepsis influenced, and when they have landed in critical ill, they have a acute GI injury for the absorption also. So all these 4 are to a patient of a cirrhosis when is there. So this question comes to us: if a patient is critically ill and he is to be transplanted, is it something the same? No. Sepsis often is associated with stress. The requirement is increased. The insensible water loss is average 800 ml per day. That is around 12% of his body weight. And at the same time, developing a fever, it increases loss also around 200 ml per day by 1 degree if has a fever. So these things to be taken when you're planning a nutrition for a patient in ICU. And as we discussed, the nutritional assessment in critical cirrhosis, is it different? It is no, but is the patient and his comfortability, you can say anthropometry. We have already discussed the SGA and the Harris-Benedict's, which is simple, equation-based and easily can be doable. Colorimetry is ideal, but is only limited centers. And we know that the formulas can also help as a rough idea to calculate the nutrition, both in the ICU setting. And I think everyone aware of this Nutrix score. It is a very simple score, but it has taken complex parameters. You can say age is easy. Apache score is needs a huge work so far. number of comorbidities, and ICU admission days, and the IL-6 value. And this score is guide you for the nutrition plan. However, the feedback on that IL-6 is difficult to do. Hence, recently has come up with a M-Nutrix. That is, you can take all the parameters, but without IL-6, and also it is predicting the very well up to 80%, and it is better than the existing our liver failure patients for a prediction of the mortality. So this M-Nutrix score can be used when we are treating a patient at the ICU setup. So this is just a because I have to cover the pre-transplant as well critical ill. Just a suppose a algorithm I can say for the nutrition, but I think we are limited by time, so I'm just going briefly. I'll skip this. Then we'll come to assessment how we do before transplants. So these are the things we have to see, as rightly discussed: sarcopenia, body composition, sarcopenic obesity, muscle strength, and the frailty. So this is how you can see that go for sarcopenia. Commonly we do DEXA, and also we do the body composition analysis, CT, liver spine index. Then for the muscle strength, it is the hand grip, you can say, and physical ability by a 4-meter walk in front of you at the speed. And the frailty also take a part of this, that is your hand grip, time to do 5 chair stands, and you can take this formula also to calculate the frailty score. So this is in the reef. We need a assessment for a patient who is planned for elective transplants. Here, as our dietitian or nutritionist friends are there, these are the few clues. I think everyone aware of that. It is not the clinician only. A dietitian, a nutritionist can also see the patient, can take history and do a clinical examination also, because this will give a very clue to your diet modification. You can see that you see the skin changes, you take the dietary habits, other things. Suppose a patient is frankly, in fact, I have a dietitian who got a feedback about a patient of having heart failure. That, sir, why you're not adding thiamine? So these are the few things where you make your team robust. You get a good feedback when you are a clinical part of team and is a clinical nutritionist. So then I think everyone aware of this Royal Free Hospital score, and this has taken parameters I have mentioned here. Then you have been graded as low 0 to 1, moderate, and then high is 2 to 7. Similarly, another comma is the very, you can say it is very vague. Body is taken by the Aspen, that you ask only the 6 questions. And obviously this is in a busy OPD, you can take the 6, and is a very easy doable, can be done for. So this is what our European Society guideline has suggested, that if a patient comes to you for the cirrhosis, you just see that his child C, straight go for considering as a high risk for the nutritional assessment. If child A or B, the BMI matters most. So if he is below 18.5, he also a high risk from the nutritional point. Then you go for the, as the gradually obesity. Obesity itself is a high risk for the transplant and is considered as a need a good nutritional evaluation. So these are the 3 group of patients we need to evaluate for the nutrition. Then important is, now we'll come to the post-transplant. So post-transplant is, you consider as early, immediate, and you can say it is the late or the long term. So these 3 ways we have to assess. And in immediate period, it is a surgical stress, preoperative malnutrition is running through, immunosuppression you are giving, there is ischemia reperfusion injuries, and there is a persistent catabolic stress in the first 2 weeks. And if this patient is having problems or issues related to surgery or infections, they have a prolonged stay, this further gives rise to the problematic. Hence, the first week is very crucial for considering. And why so? You can see with the first 6 hours, the glucose utilization by the graft is less, it uses fatty acids. And over the time, it becomes normal and utilizes, shifts from the fat to the glucose. And that we need to consider. If a graft is failing, then it continues to use the fat. And because of this, this ketone body ratio is a predictor of your outcome as well as the graft. So in immediately first 24 hours, that is one we need to see. Then I think Dr. Neha is here. I have quoted her paper. She is excellent working on this liver transplant. So this shows the how a liver transplant patient day wise, his stress, his nutritional requirements we can give. So you can see from the day up to 4, it is a little bit difficult because of the surgical issues. Over the time comes up. And even we give the nutrition post-transplant acute time, we are able to achieve in few parameters up to the target. So there is a lot of gap we need to address. So in first week, I can say the first week is nutrition is clearly the liquids. You can say we can give free waters or ORS we are giving sometimes, but at the time we have to see for your inotrope, bowel sound, and lactate clearance. By day 3, these people are a little bit stable, where the NG feed and the oral feeds can be considered. But again, we to see for the residual gastric volume, your bowel sound, and the drains are there. And day 7, this patient should be mobilized. The bowels most have been returned, and they should be considered for the normal feed. And to top up, we can consider having the supplemental feeds. So nutrition earlier should be considering that you should prefer as the catabolic phase high protein. Then absence of bowel sound is not a absolute criteria. We can give him challenge to see his bowel is moving, and even the post surgery ILS is there, but the trial feed may be giving a help. So in this period of first week, enteral nutrition is to be considered. Even it is a trophic feed also, that is help in a major way. And those diets should be considered as soon as possible to be shifted. However, we need a combination of rice to feeding along with oral feeding overlap, so that we can be assured that at least 80% of the diet has been taken, so that we can remove the rice to feeding. So this is for the first week. Then important concern comes is the post-LD chylous ascites. This is, you see that the drain in the abdomen which comes like a milky colors. That is, we frequently see it is because of the pre-transplant issues of ascites, bile duct, lymphatic channel issues, and this is further aggravated because of surgical interventions, and it happens in around 4 to 5% of the cases. And if it is spontaneously before a patient having ascites, they have a little bit poor prognosis. However, it can be addressed by your dietary measures. That is, we made it high protein, low fat MCT based, fat free clear liquids, and elemental feeds in the first week. The new goal should be here to decrease the production of the chyle, replacement of the fluid and electrolytes as lost through the ascitic drain, and to maintain the nutrition. With this, sometimes we fail, then consider TPN to give a bowel rest to completely. Sometimes somatropin octreotide has been given, but we less see these situations. In fact, I have not seen a patient where we have to make a TPN. This is only in theory. So mostly the diet modifications has given a lot of results for the post-transplant management of the chylous ascites. Then important, what is, I think, little bit overlap with my previous speakers, is the nutrition, how they happens. So, but commonly I can say as a nutshell, the diets which interact with your immunosuppression, grapefruit, pomegranate. So these are the peoples we should try to avoid. Marijuana at any forms, and as rightly said by Madam before, that too much of this ginger, turmerics, they are to be avoided, and make them should be herbal products at no. Potassium rich foods, it should be completely curtailed as we are mentioning the TAC levels. And few foods we encourage to take with few medications, that is prednisolone, steroids. Posaconazole is an antifungal. Boceprevir, but however we are not using this antiviral now for the Hep C. Newer drugs has come up, and commonly we are using the valganciclovir. If prednisolone or posaconazole or valganciclovir is there, and you advise them to take with the meal, because their absorption is increased with food for a post-transplant patients. Then important is the dietary hygiene, which should be continued for a long term. That's raw, undercooked foods should be minimized. Unpasteurized milks, you know better than me, sprouts. So these are things just to prevent the unknown infections which may come up into a post-transplant immunocompromised persons. And because of the post-transplant surroundings, most common is the hypomagnesemia, and this increases the TAC toxicity. So try to give some foods that is magnesium rich. I have mentioned here, and I think you are more aware of that. Then calcium rich foods are needed, because you know a condition as hungry bone syndrome, where we need this in a robust way to supplement the bones. Then this is a busy slide. Just I want to highlight how the drug related side effects are happening and how we can cover this with your interventions. So I think you mostly going through this. So now we go to the long-term plans. You can see during first 12 months, the patients get gradually more rapid weight gain. The muscle mass is not gained. It is how to call the sarcopenic obesity come up, and mostly this weight gain is unregulated. I think we know the facts. Definitely one is the liver gut brain axis related to vagus innervations. They're getting more comfort of getting more love to get more intake, and also because of the drugs and the metabolic states. So these are the few things you can see commonly comes up: weight gain, hyperlipidemia, hypertension, diabetes, and osteoporosis. I have mentioned the risk factors for this. So what we can suggest as a dietary recommendation in short term and long term, you can see from this, the calories coming to the 1.2 to 1.3 times the basal expenditure. Protein from the initial is 1.2 to 1.3, then gradually come down to 1. Carbohydrate is nearly half to two-thirds. Fat should be below 30%. Calcium should be there in your diet. Sodium is modest, and magnesium and phosphorus needs to be added. So these are the things we need for a post-transplant patient in long-term follow-up. So with this, I think that if IPN can take forward immunonutrition, as we discussed, it is still now a failure. But what I can say, I have started one study that is gut modulation, where we are getting good results. Hopefully, immunonutrition need more research in a more robust way to address this. Post-LT metabolic syndrome is now coming a big way, and here we can collaborate, can think of that way. Now we are coming to immunotolerance and immunosuppression withdrawal, where the diet has a major roles. And I think I can request the whole community, because one of my friend, he's a nephrologist in Kolkata. They have started one production of low potassium genetically modified diets, particularly brinjal and 2 fruits and vegetables. 4 products they have made it low potassium diets. I think these are eye-opening thoughts. If we can make through this, it can help a lot to the transplant community. As a carry home message, I can say nutrition in peri-transplant is definitely multidisciplinary, not in the domain of clinicians or nutritionists. We need clinician, nutritionist, dietitian, and internists to be combined effort in first weeks. Pre-LT assessment and stratification is must before giving this patient to a transplant. And as rightly said by Dr. Manjunath, regular dietitian nutrition visit in routine OPD should be considered as a routine practice. Thank you.
Sir, it was a very nice presentation. Any questions? The presentation is open for discussion.
The problem with am I audible?
Yes, sir.
The problem with assessment, it's a BMI based or a basic nutrition assessment tool based nutrition assessment in cirrhotic disease will have problems. For example, mid-arm circumference, if you measure, or any physical measurement, it may be increased. We perceive it as improvement, but it may be due to edema, ascites and all. BMI front also, weight-based nutrition assessments in cirrhotic disease have problems, will have. So what we found in around 148 patients, we had conducted a trial with respect to immunonutrition which completed. These are some of the findings I just want to alert everybody. So we should not go ahead with probably we need alternate measurement tools, non-weight based, not BMI based measurement tool. Second problem is regarding the interleukins. Most of the studies we heard from yesterday morning also, interleukins, IL-6, TNF-alpha are pro-inflammatory, IL-10 are considered as anti-inflammatory. Yeah, the problem is we know that in chronic liver, these are very highly applicable for acute inflammatory condition, but chronic inflammatory disease, especially cirrhosis, pro-inflammatory factors, anti-inflammatory factors works together. Yeah. They work together. So in a given patient, we expect IL-6 more and IL-6 10, which may not happen in all patients. So as you know, you are very aware that degeneration, regeneration, both happens simultaneously. So highly depending on interleukins and TNF-alpha for improvement and deterioration, IL-10 for improvement may not hold. So that's what my interpret. So I want your input also from this.
Yeah, you rightly said. In fact, I have not presented BMI also, because BMI is a mild, moderate and severe, 5, 10, 15 kg to be directed, but that is not adequate. Particularly when BIA has come up, little bit problem with ascites, but you can get a good assessment for the diet, that is one. And also equally you are getting assessment by other methods which is not affected by this ascites part, like you are taking for the sarcopenia activities, you can see, or DEXA analysis. So this way you can replace this ascites part, that is one. Two, regarding IL-6 also. So I have shown that it is a criticism what you have told. They have come with Nutric to remove the IL-6. And in all cirrhosis, that is called a CAID, cirrhosis associated immunodysfunction syndrome. So any patient of cirrhosis has a balance of pro and anti-inflammatory things. So hence, this immunomarkers should not be part of the nutrition planning, or you can say decisions. You are rightly said. I am agreed with it that way. And importantly, that nutrition job should start with the, you can say, if a cirrhosis in clinics coming up from the very beginning, so that we can take the whole spectrum, that I can say.
So I think the immunosuppressant doses what they are giving is based on the adjusted body weight.
Yeah, immunosuppression, in fact, you can say the most common is the tacrolimus. The dose has mentioned 0.01 to 0.03, but mostly we go by the TAC level. So hence we maybe pediatric, but for adult it is, we are just going by the TAC level available achieve, then it is okay. So that does taking hold good for the weight, for the adult body weight. That is for the books, but for the practical is, if you are able to keep the TAC level around 8 to 10, first 3 months, then first 6 months is 6 to 8. After 2 years, it is at 5 year maintaining with whatever the dose, it is okay. That is one part. Second, you can say about the MMF group of drugs. In that case, we standard is 500 or 1000 BD, then you monitor for the cytopenia or GI symptoms. So by symptom you can calculate. Then everolimus also same. You have to adjust for the dyslipidemia or the cytopenias. So most of the time by side effects profiles we go for, and others is TAC level, and weight level, weight based. Not think it is good idea for the calculation.
In kidney transplantation, we go by adjusted body weight.
Yeah.
So one thing, Srimati from Bangalore, clinical dietitian, working with liver transplant also. So main thing which we do, then DEXA and BIA is not possible in many hospitals. So as you said, mild, moderate, severe ascites, we do the Mendenhall score. So where we minus the, depending on the fluid overload. And also then Nutric score, if we do the nutritional assessment, risk assessment in the critical care, it would be better to use the NRS 2002, which is a well-validated tool, or even an SDA, which most of them use. But then a Nutric score, NRS 2002 would be a better thing, is my opinion.
Yeah. Okay.
Thank you.
Thank you, sir. Dr. Brahmadatta, do you have any comments? Any?
It was an excellent and comprehensive presentation actually on post-transplant nutrition. I would also like to emphasize that this MELD sodium, which is the core score for predicting need of liver transplantation. So many studies have come up with MELD sodium sarcopenia score now, which Dr. Ashok is also very fond of using this score at times, because many patients having low MELD score but having sarcopenia. This is a very selected and high risk category of patients who should be prioritized, especially in DDLT group. But in DDLT setup, there is no priority points given to patients having sarcopenia. So how Dr. Ashok thinks about this MELD sodium sarcopenia score to be utilized properly in future, or it is a over prediction or over calculation?
No, Dr. Brahmadatta, it is very good. In fact, now sarcopenia frailty has taken over the MELD score. If in patient MELD score is 12, he's not get cadaveric. And in fact, now things are moving to take as MELD exception also. So definitely, and another valid, you are in AIMS Bhubaneswar, so we can think of a multi-center at all dietitian people are agreed. So we can think of a MELD sodium with sarcopenia. So we can make a large group data, because you can see the transplant in Western scenario and Indian is totally different. They come with just relatively preserved. They don't have any sarcopenia. And in India, 80% of the transplant going people are sarcopenic. They want that's our thoda khich lo. So because of these khich lo problems, we get all BMI of 20-21 like that, thus lemon on stick appearance. So that is why the most concept of Indian transplant is totally different, where sarcopenia is dominating for your outcome. So all patients who are sarcopenic, frail, have a post-LD outcome is very dismal. So we can consider MELD along with sarcopenia versus MELD only, so that we can think ahead. Thank you for your suggestion.
If I can just add, I, Dr. Neha Bakshi, I've worked majorly on liver transplant. That has also It is difficult to do nutrition assessment of these patients.
मेरा मोबाइल है ना, मैं बस चार्ज कर लूं, नहीं तो फिर नक्शा का कुछ नहीं करना।
Being there. Sorry, just give me a second. Now, our next chairperson is Lakshita ma'am. As Dr. Lakshita Sharma, she's here. I'd like to invite you, ma'am, to be on stage. She is an associate professor of head dietetics and applied nutrition with Amity University, Haryana. She has got an experience of 16 years and she's a gold medalist for her graduation and post-graduation. Welcome, ma'am. And she has received a Best Speaker Award in international webinar organized by UK. Welcome, ma'am. We have got Dr. Rajni Sharma. She's also joining us online. Dr. Rajni Sharma is alumni of AIMS, her graduation and post-graduation, and she's an additional professor with AIMS in Peds Endocrinology Department. She's awarded Royal College of Pediatric, a Child Health, and Ashok Natwani Visiting Fellowship in 2015. Ma'am has got 60 publication and 28 book chapters. Ma'am has done. Dr. Rajni Sharma. Are they there online? Then the fourth chairperson is an eminent Dr. Ashima Dabas. She's also joining us online. She's associate professor with Department of Pediatrics, Maulana Azad Medical College. She's editorial member of Cape News, associated director, editor with Indian Pediatric, and she has got the 6 awards associated with publication, 58 journal and 12 chapters. Even ma'am has written 1 book. So I'd like to invite all three of my chairperson online, as well as Lakshita ma'am is here. You've got the list now? Speakers, okay. So Anuja ma'am is here. Anuja ma'am is here online.
Yeah, I am here. Hi, can you hear me?
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. It's really honor to hear your sound. Even. So over to you, ma'am. Please, you can hand over the next session.
Okay, thank you so much. I'll just share my slides. I couldn't send my slides there because this file was very heavy. So I'll try to.
Yeah, no worry, ma'am.
Yeah. So can you see my slides?
Not yet, but it's about to start, I think. So ma'am is going to talk about, okay, now ma'am, we can see your slide. So with, yeah, overview of pediatric nutrition. Yes, ma'am, we can see your slide.
Yeah.
Shift to slide. Thank you. Done.
Right. Right. So, I mean, I'm chairing the session, and I've been given to make a presentation for 15 minutes, focusing on pediatric nutrition. Although it is a huge thing to, I will not be able to justify it in 15 minutes because pediatrics now is not a general pediatrics. It is a super specialty area with so many disciplines in it. And so the nutrition also has to, you know, as the medical discipline is progressing and advancing, our nutrition also has to keep pace with it. So it has become a very advanced nutrition, which we all have to learn. And being in the tertiary care hospital, of course, we are very fortunate to sort of see a spectrum of patients, you know, of different disciplines. So I will just give you a glimpse and maybe set the context for the next speakers to speak about some of these common things which like type 1 diabetes and somebody speaking of critical care and all that. So I will just set the context and just give you a glimpse of what pediatric nutrition is. And a special focus on malnutrition, as I told. So as we know, pediatric nutrition is actually dealing with children from infancy up to 18 years of age. And the adequacy of nutrition in all throughout infancy to 18 years is very important to ensure the adequacy of nutrients, calorie intake, and prevent malnutrition. Also promote physical growth and development, which is there, you know, whether the child is suffering from any disease condition, physical growth and development is something which goes hand in hand. We cannot ignore at times, you know, that the focus is on the disease, and we often forget that the physical growth and development, we have to make allowance for that also. So their requirements are much more than what the requirements we deal with the adult population. Also, immune system. They, from the beginning, from the infancy itself, they have to build up a very strong immune system. Not when the COVID happens and people start taking nutritious food and all the, you know, food which is healthy and your millets and your sattus and all that. It has to be done from the infancy, and we have to really work hard to give them a very strong immune system to prevent all the disease conditions, complex disease conditions and disorders. Also to sustain the physiological requirements in various stages of growth and development. And we know the lack of nutrition during critical periods of growth results in developmental delay and also illnesses and disorders. So what are these critical periods? That's also very important. First 1,000 days are very important. It includes maternal nutrition as well. Also, the nutrition from 2 to 5 years of age, and then the adolescent period. These are some of the very critical, crucial periods of growth. Then we have to focus a lot on these during nutrition, providing nutrition. So pediatrics is a multidisciplinary specialty, and we have, you know, as I'm not going to speak of all these specialties, we have all these specialties which are there, and each of these specialties is something like a department on its own, and because they are so super specialized now, where I was reading and collating data about pediatric nutrition, I understand that during World War II, pediatrics was just a general pediatrics. And over these years from World War II till now, it has really come a long way, and it has become a super specialty area with all these disciplines which have become a super specialty disciplines. So general pediatrics, we don't deal with anymore with general pediatrics and very superficial prescriptions or counseling. It is an era of super specialized pediatrics. So if the medicine has advanced, so it is no more a standard nutrition prescriptions. We can't have the standard diet charts and start prescribing to our patients. This is an era of personalized specific nutrition prescriptions. So medical nutrition guidelines and tools, as the previous speaker also spoke, that about sarcopenia, that doesn't work for India as in Western. So I must say for pediatrics also, it is the same scenario. Often we extrapolate a lot of our tools and our guidelines from Western countries, but it should not be done. In the absence of nutrition, a lot of nutrition literature from India, we at times have to sort of extrapolate from the Western countries, but we should have a consensus on this. We are very, very heterogeneous. So we are, India is a different, our body compositions are different, our BMR is different, and that's why our EARs and RDAs are also different from the Western world. So we have to understand that we have to have our own India-centric guidelines in nutrition, and they have to be disease-specific, India-specific, disease-specific guidelines, which are not there, which are not structured, and tools are not validated for India. So as in-depth medical training skills are required for detecting, preventing, managing, and treating various complex pediatric illnesses, similar way, specialized advanced nutrition training and skills are required for the delivery of disease-specific and personalized nutrition interventions, and for specific diet and meal tailored for that patient. Extensive nutrition sessions and education is required. Again, we need to link disease and diet when we are talking to the patient. So we need to have a good understanding of the disease, the prognosis of the disease, also when we are counseling to our patients. Otherwise, it is not very convincing. If you are just picking up a diet chart and telling the patients, is not convincing. And there's so much awareness about nutrition now that all parents, you're basically talking to the mothers, and if they're older children, also to their children. And in pediatrics, you're actually talking to the whole family at times, like obesity, diabetes. You're actually talking to the whole family. You involve them in your counselings and all sessions. So if they don't understand the prognosis of the disease, then at times the compliance is very bad. So we really need to spend a lot of time on our patients, and pediatrics especially, it also focuses a lot on emotional and social health of infants and children and young adults. Coming to the malnutrition scenario in India. India is home for about 47 million stunted children. That is 1/3 of the world's total, according to the Global Nutrition Report 2018. Nearly half of the under 5 mortality is because of undernutrition. Prevalence of SAM in India is 7.5%. 2% children below 5 years are overweight. That is weight for height above 2 st. And then there are other data, for overweight, obese adolescent, 22.3% and 29.8% as a WHO cutoff, which is being given. So what is malnutrition? Basically, malnutrition covers undernutrition, underweight, that is undernutrition, which is stunting, low height for age, low weight for age, low weight for height, which is wasting, micronutrient deficiencies, and also obesity related and other non-communicable disease or lifestyle disorders. So we are facing a triple burden of malnutrition in India, which is undernutrition, hidden hunger, that is micronutrient deficiency and overweight. So there is a threat to the survival and growth development. And this is all driven by the poor quality of children's diet. And also the fact is 2 in 3 children are not fed adequate food in our country. This is just to show the prevalence of stunting in our country. The dark red color shows extremely high prevalence of stunting, and the lighter color shows high prevalence of stunting. This actually covers nearly whole of our country, which is facing prevalence of severe stunting, across the whole country. Over the years, this shows data from 2000 to 2018. It shows that we have done very well in our, under nutrition. We have done very well in, we have done marginally well in our stunting. Stunting has come down actually over the years. Mortality rate has come down, but the wasting has actually increased, right? Wasting is weight for height. According to NFHS survey, that is 4th NFHS survey, obesity, the prevalence of obesity is 20%, anemia is 50%, and stunting and wasting. I'm not spending too much time on this because this is repetitive. And now NHFS 5 data is also coming, and which shows some good results, like stunting has come down, wasting has come down a bit. Severe wasting has not come down, it has actually gone up. And underweight has also come down marginally. So if you look at these indicators, we realize that, we've done well. If you look at the stunting, marginally well in wasting, severe wasting, everywhere we've done well. The breastfeeding rates have improved. The only thing we have not done well and which has increased is anemia across all genders and across all, ages. So now coming to the guidelines, there's some guidelines, national guidelines, which are present in the pediatric, for pediatrics. And before starting your career in pediatrics, all of us should know IMS Act 1992, which has been amended for 2003, which actually involves protect and promote exclusive breastfeeding till 6 months of age and continued breastfeeding after 6 months. So we all must be very, very much aware about IMS Act, before you start as a pediatric nutritionist. And the act is very clear. And, this is one of the documents which we must all know and we must have sessions on. Then young infant and young child feeding practices, which has been revised over the years and focuses on optimal infant and young child feeding. And it focuses also on adequate nutrition and anemia control for adolescent girls, pregnant and lactating women. So then treatment of diarrhea. We have a document which has not been revised for quite some time because we don't see diarrhea now in tertiary care hospitals. We don't see diarrhea in, actually everyone is so aware of ORS now. Everyone is so aware of zinc. And awareness in last 2 decades is so much about diarrhea. They're able to control diarrhea very well in the community. Only when it is a complicated diarrhea, it has been referred to the hospital. And it may turn out to be cosmic protein allergies and all. It may not be a simple diarrhea, a persistent diarrhea. So that is a scenario, and diarrhea is very well taken care of. Then we have protocol for guidelines for severe acute malnutrition. Again, there's been a revision of severe acute malnutrition in the community because over last 2 decades, even severe acute malnutrition referrals to the tertiary care hospitals and the state level hospitals have reduced to a great extent because they have been easily tackled at the community level by the healthcare workers. And there's so much awareness about F75 and F100 diets. Even a normal healthcare worker, can pick up the book and can implement the diets and whatever guidelines tell you. Then recently there have been guidelines for TB, tuberculosis in India, and there are low birth weight guidelines, AIMS guidelines. And we have guidelines from Indian Academy of Pediatrics for overweight and obesity. We have diabetes, type 1 diabetes guidelines from SP. So these are some of the guidelines which are present in pediatric space. But then all these things which you see are of public health importance. When you talk of clinical, hospital-based guidelines, we have a lot of heterogeneity, and there is a lot of ambiguity on the guidelines which one should follow. We also have growth charts and standards, and using growth charts and standards in pediatric age group, we have assessments made about the nutritional status, and from there on we decide how to ABCD. A lot of been talked about ABCD, anthropometry, biochemistry, clinical condition, and dietary history, and those things apply to the pediatric hospital patients as well. Then we use these growth charts to make our assessments, whether the patient is trajectory of growth is normal or overweight or underweight, and accordingly the diets, the targets, nutrition targets are planned. So nutrition care of the hospitalized patients are unique from the adult patients. I always say that pediatric patients are not miniature adult patients. So previously, when it was a general pediatrics, was thought that if you are qualified for the dealing with adult patients, so you can easily look after pediatric patients. So that is not so. Pediatric patients are very, very different. Their nutritional demands are very different. They have different percentage of muscle and fat, and that's why their energy requirements are higher than the adults. And there are diverse medical conditions and syndrome, and which need tailored nutritional assessment, the interpretation of the anthropometric and medical nutrition intervention, which is very different in pediatric age group. And also I would like to emphasize on primary SAM versus secondary SAM. Now, when the protocol or the guidelines of primary SAM, which is because of ignorance, which is because of scarcity of food, which is because of multiple host of problems in the community, that protocol cannot be applied to a secondary SAM where the patient is suffering from some chronic disorder, to name a few, cystic fibrosis, to name a few, some genetic disorder. You can't apply F75 and F100 everywhere. So I have seen people applying SAM protocols, SAM guidelines to everything, even hospitalized patients. The demands of these patients admitted in the hospitals could be very different because their pathophysiology is very different. So one need to understand the biochemistry of that child and do not apply primary SAM guidelines to each and everything. If the person is underweight or comes in the category of SAM, but he's suffering from some systemic disorder, which is chronic systemic disorder, you may not be able to apply that guidelines of primary SAM. Then malnutrition in hospitalized pediatric patients adverse have, nearly 80 to 90% of children are malnourished. Out of that, 50 are severely malnourished. You are saying?
Sorry to interrupt. If you can wind up in a couple of minutes.
Yeah, I'm winding up. It's just 1 or 2 slides left. So malnutrition is present. Obviously, these children are coming from the community, and malnutrition is there already in these children. So we have looking at that scenario, a lot of our protocols, we have changed our practice because if the already existing malnutrition is there and we apply a Western protocols or guidelines, we are making our children more malnourished at times. So we have to consider this while we are dealing with these children in the hospitalized patients. We have some standards of nutrition care, and we know all this chart that we screen the patients for who are at risk, who are not at risk, and then implement our nutrition care plan. Then we have nutritional assessment, whether somebody would need enteral nutrition or parental nutrition or oral nutrition. So we have a structured guidelines for that. And we should have nutrition screening questions, a simple question, nutrition assessment, nutrition intervention, and nutrition monitoring sheets. Monitoring is very, very important in the hospitalized patients. And then, of course, you make your decisions whether you want to give a supplement, whether you want to give a tube feed to a patient, depending on some criteria of nutritional assessment. Okay, I'll skip this. I just wanted to say that we have new requirements have come, which is called EAR, which is 50% of a median of the distribution of normal population graph. At times in the hospitalized patient and some disease conditions, we cannot apply ER, we have to use RDA, right? Or we use the activity factor and stress factor and increase, because the targets of these hospitalized patients suffering from chronic systemic diseases, complex diseases, would be very higher than what we consider for normal moderate children as EAR. Okay, so we have a carbohydrate dilemma. There's so many things which are unanswered, and you can see in our country a lot of diseases in children are related to carbohydrates. So there are quality and quantity issues, and we have to decide on the guidelines how to go about it. Then proteins also, should we use ideal body weight or actual body weight? That's also a dilemma. In which conditions we should use ideal body weight or actual body weight? Okay, I'll just finish it. How much fat and sugar should be fortified? There is a limit to that, and you need to understand. And this is just showing your aims. Till 2012, we had 4,500. Now it is increasing. We have nearly 6,000 children coming every year to us. Ongoing means of communication monitoring. This is just, thank you so much. I'm sorry I had to speed up because I've been given a,
Thank you, ma'am, for such a informative presentation, telling us the strong immune system is needed and physiological requirements. And also one point is that the validation of the tools is important in India, which is still not present. So any brief questions quickly from the audience? We can move to the next presentation. That is from Dr. Sunaina Arora. She is European Diploma in Nutrition and Metabolic Medicine, DNB Pediatrics, and MBBS. She is working with Pushpanjali Hospital Civil Lines, Gurugram from December 16, and she is certified in ESO and SCOPE, certification in childhood obesity from diagnostics to management, SCOPE. And we welcome you, Dr. Sunaina. Please start your presentation.
So, good morning, everyone. I'm Dr. Sunaina Arora, and my topic of today is role of diet in prevention and treatment of hyperlipidemia in children. So what is the background and rationale? Then it is non-communicable diseases and cardiovascular diseases. They are the leading cause of morbidity and mortality even in children. 2/3 of the 58 million deaths annually are caused by non-communicable diseases. Cardiovascular diseases, that is the leading cause of non-communicable disease. They are responsible for 17.5 million deaths per year, and it is the leading cause of deaths worldwide. So what are the risk factors for atherosclerosis in children? The underlying disease process in the blood vessel that cause CVDs, that is ischemic heart disease, peripheral vascular disease, or stroke, is atherosclerosis. So what are the risk factors? First is behavioral risk factors, unhealthy diet, sedentary lifestyle, metabolic risk factors like raised blood pressure, raised blood sugar, raised blood lipids, overweight and obesity. And other risk factors are male gender, inherited disposition, advancing age, psychological factors like stress, depression, and other risk factors like elevated homocysteine. So risk factors in childhood and determinants of CVD in adulthood. There are various studies which have been done, like Bogalusa study, Cardia study, PDAY study, FINDAY study, FIN study. They all have proved that cardiovascular risk factors in children and adolescents, they predict atherosclerosis in young adults with the help of IMP and FMD, that is flow-mediated dilatation. And there is another study like Danish longitudinal study, which says that BMI in childhood will predict the coronary heart disease in adulthood. So even in children. 2/3 of the 58 million deaths annually are caused by non-communicable diseases. Cardiovascular diseases, that is the leading cause of non-communicable disease, they are responsible for 17.5 million deaths per year, and it is a leading cause of deaths worldwide. So what are the risk factors for atherosclerosis in children? The underlying disease process in the blood vessel that cause CVDs, that is ischemic heart disease, peripheral vascular disease, or stroke, is atherosclerosis. So what are the risk factors? First is behavioral risk factors, unhealthy diet, sedentary lifestyle. Metabolic risk factors like raised blood pressure, raised blood sugar, raised blood lipids, overweight and obesity. And other risk factors are male gender, inherited disposition, advancing age, psychological factors like stress, depression, and other risk factors like elevated homocysteine. So risk factors in childhood and determinants of CVD in adulthood. There are various studies which have been done, like Bogalusa study, Cardia study, PDAY study, FinDay study, Fin study. They all have proved that cardiovascular risk factors in children and adolescents, they predict atherosclerosis in young adults with the help of IMP and FMD, that is flow-mediated dilatation. And there is another study like Danish longitudinal study, which says that BMI in childhood will predict the coronary heart disease in adulthood. So it is, according to these studies, it is very important that we predict, that we determine the risk factors of cardiovascular disease in childhood itself to prevent hyperlipidemias and obesity in adulthood. So what are the metabolic syndrome definition in children? The metabolic syndrome, it's a cluster of cardiometabolic risk factors associated with increased risk of developing cardiovascular disease and diabetes mellitus. Prevalence is 3 to 4% in children and 30 to 50% in overweight youth. There is no adopted definition in children, contrary to adults, because all the criteria in pediatric metabolic syndrome, like central obesity, which is determined by waist circumference or BMI, increased triglyceride levels, low HDL levels, increased elevated blood pressure, systolic, diastolic, and mean arterial pressure, and abnormal glucose metabolism, like impaired fasting glucose, impaired glucose tolerance. All of these are not age, gender, or pubertal status corrected. So, but few studies have been done, like Princeton follow-up study, which says that pediatric MET score will, it predicts adulthood METs. So it is important, like it's not very age and gender based. It is not corrected, but it is still predict the adulthood CVD. So what is the prevalence of hyperlipidemia in children and adolescents? According to National Health and Nutrition Examination Enhanced for 2011 and 14, it reported 21% of the children and adolescents in US, they have one lipid anomaly. And recent study in Indian children, it says that 25 to 30% in urban and 15 to 20% in rural India, they are having hyperlipidemias or any lipid anomaly. So it's a high prevalence overall. So what is screening for hyperlipidemia in children and what are pros and cons? Screening, according to AAP in 2007, they said the selective screening for children and adolescents should be done in high-risk groups. In high-risk groups means positive family history of dyslipidemia, positive family history of premature CHD, unknown family history, and children with other cardiovascular risk factors like overweight, obesity, hypertension, cigarette smoking, or disorders that affect the lipoprotein metabolism. So what are the cause and like universal screening and selective screening? So NLA in 2011 said that universal screening of all children should be done at 9 to 11 years of age, and selective screening for more than 2 years of age if they are in a high-risk group. While NHBLI, that is National Health Blood Lung Institute in 2011 says that all children should get universal screening in 2 age groups, like one in 9 to 11 and the other is 17 to 21. And there are various pros and cons of doing selective and universal screening. First is when you do selective screening, as I already told you that various studies have already said that childhood CVD, childhood risk factors predict the adulthood CVD. So if we get to know the earlier risk factors, or earlier we get to know the child is having the raised lipid levels, we can start on therapy early, like we can start off statins. And the good part is there are not much risk factors for, I mean, adverse effects of statins are absolutely like very less. So, but there are concerns about unjustified use of medication, and there is concerns of misinterpretation of screening results. While in universal screening, of course, when the atherosclerosis lesions begin in childhood, we can track lipid levels from the childhood to adulthood if we do screening for all the children. However, it is very expensive, and the harmful effects of restrictive diets are there, and it may sometimes improperly label children as having high cholesterol levels. So what is elevated in children in terms of lipoproteins? So when the total cholesterol is more than 200 and LDL is more than 130 and triglycerides are more than 125, it will be called as elevated or more than 95th percentile, and with this we have to intervene. So what are the types of hyperlipidemias in children? There are two types, primary and secondary. Primary, most common, is genetic in origin, and most common one is familial hypercholesterolemia. Others are familial combined hyperlipidemia, familial hyperchylomicronemia, familial hypertriglyceridemia, dysbeta-lipoproteinemia, mixed hyperlipidemias, Tanger's disease, and Woolman's disease. Secondaries, most common, the disease process is different, but there is secondary rise in the lipid levels. For example, diabetes mellitus, hypothyroidism, obesity, glycogen storage diseases, CRF, nephrotic, SLE, or it can be drug related also. So familial hypercholesterolemia, since it is the most common ones in primary, we can learn few things about it. It is an inherited autosomal dominant disorder, and 79% of the times it is LDLR gene which is affected. 5% defects are in the genes of ApoB and PCSK9. 15% it can be polygenic or monogenic mutations. And very rarely it can be a recessive form like LDL receptor adapter protein defect. And it can be homozygous or heterozygous. So diagnosis is by molecular DNA testing or by, it's a most reliable one. And clinically we can, there is a validated set of criteria which defines familial hypercholesterolemia, that is MedPed, Dutch Lipid Clinic, Simon-Broom criteria in UK. So most commonly the Simon-Broom criteria is followed, and according to that, definitive diagnosis of FH can be made when the total cholesterol level is more than 260 and LDL level more than 160 in children. Plus there is tendon xanthomas in patient or first or second degree relative, or there is DNA based evidence of an FH causing mutation. While the possible diagnosis is said when A, that is total cholesterol and LDL cholesterol rise, plus B or E, that means family history of MI before age 15 second degree relative or before 16 first degree relative, and FH of family history of hypercholesterolemia in first degree relative, or total cholesterol more than 290 in second degree relative. So this is a possible diagnosis of FH. This is a criteria that we should know. And what are the goals of hyperlipidemia treatment in children? So first before this, we should know that there are 8 pediatric medical conditions that is known to make the pediatric patient at high risk of both lipoprotein abnormalities and CVD. And that includes familial hypercholesterolemia, diabetes mellitus type 1 and 2, chronic kidney disease, heart transplantation, Kawasaki disease, congenital heart disease, chronic inflammatory disease, and childhood cancer. So tier 1, that is a high risk group, that is homozygous FH, diabetes type 1, CKD, post-heart transplantation, and Kawasaki with current coronary aneurysms. In this case, BMI should be less than 85%, BP should be less than 90% for age and gender, LDL should be less than 100, and fasting glucose should be less than 100. In type 2, it should be for heterozygous FH, Kawasaki with regressed aneurysms, diabetes type 2, chronic inflammatory disease. In this, the goals are BMI less than 90 for age and gender, blood pressure less than 95, LDL less than 130, and fasting glucose less than 100. For at-risk type 3, that is post-cancer treatment survivors, congenital heart disease, Kawasaki disease without coronary involvement. BMI should be less than 95% for age and gender. BP should be less than 95 plus 5 for age and gender. LDL less than 160 and fasting glucose less than 100.
Ma'am, you have paused the presentation.
So whenever the child comes to you with raised lipid levels, that more than 95th percentile that I already told you. So what should be done? What is the management plan? What you do is first you have to take the family pedigree as complete as possible. Like all CVD manifestations, MI, angina, cardiac arrhythmia, sudden cardiac death, cardiac failure, documented atherosclerosis, cerebrovascular disease, peripheral arterial disease, all the detailed history should be taken. Then personal medical history and lifestyle, what the child is eating and what is the physical activity. If the child is in adolescent age groups, habits like smoking, drinking. Lipoprotein profile of all immediate family members are important. In physical examination, look for xanthomas, arcus corneus, thickening of Achilles, tendon of Achilles. And measurement of blood pressure, very important. Evaluation of pubertal status, like staging is important. All blood investigation like thyroid and nutrition evaluation, 3-day food diary. We should take the complete anthropometry like weight, height, BMI and plot on the growth curve, sorry. Then baseline non-invasive assessment like carotid IMT and brachial flow mediated dilatation. And then based on this, plan on the treatment goals. So whenever the child comes with borderline LDL rise or high LDL, like more than 130 or 110 to 129, you have to do complete clinical evaluation that I have already told. Then counsel on healthy diet and TLS. What is TLS? It is therapeutic lifestyle changes. I'll tell you in the further slides. And repeat lipoprotein analysis in few months' time. So TLS is therapeutic lifestyle change, that is reduced intake of saturated fats less than 7% and cholesterol less than 200 mg per deciliter. And other options for enhancing LDL lowering, such as plant stenols, adding plant stenols or increase fiber diet, fiber in the diet, weight reduction and increased physical activity.
Dr. Sunena, you can wind up.
So there are various studies which have been done.
The time is up. You can wind up in 2 minutes. The conclusion of your study.
Okay. The crux of of my presentation, I can just tell in 2 minutes.
Any questions?
Can you hear me?
Any questions from the audience? I think there are no questions. We can move on to the next. Okay, fine. The next presentation is from Miss Lekha. She is MSc and PhD scholar, certified pediatric dietitian. She is holding the current position as HOD and Deputy General Manager, Clinical Dietetics, Apollo Children's Hospital and Apollo Women's Hospitals. She is Honorary National Secretary, IPN India, Chennai. She is keynote speaker for Infancy Conference, Atlanta, USA. She has given many oral presentations and also she has good publications at national and international journals. We welcome you, Ms. Lekha, and you can proceed with your presentation.
Namaste all. Thank you, IAP in India, Chennai chapter. Coming from Chennai, that name only comes to me. I'm sorry for that. I'm thanking you again, the Delhi chapter, for giving me this opportunity. So at the interest of time, I'll go as per the time limit what is given. I will not try to exceed that. I'll limit with that. So coming to the perioperative nutrition in pediatric population, first what we need to understand is the nutritional status prior to surgery and the nutrition rehabilitation after surgery can affect the morbidity and mortality of the pediatric patients. So the pre-operative malnutrition will be associated with increased complication and increase in mean hospital stays following the surgery. So this is just to give you a picture about the clinical evidence about the malnutrition prevalence in pediatric ICU. So a study conducting by 494 patients, in which we can detect around like 13.4 patients who are malnourished. Then there's another study also which supports the same, saying that like 18 to 40 patients of the pediatric surgical patients are malnourished. And one more thing is that despite this high prevalence of malnutrition, it remains largely unrecognized issue in the healthcare workers. So early detection, that is where we come into the picture of nutritional screening. Initial screening is very much essential. So early detection of malnutrition is very much essential. So it will help to maintain adequate nutrition in pediatric surgical patients, and is not only critical for healing purpose, but also for the continuous normal growth and development. So when they are admitted in that pediatric ward also, if they're going to be there for quite some time, like say for a short bowel syndrome or where they need to work up for them, so it's a period is long. So during that period, the growth also should not be affected. That need to be looked on. So the nutritional approach, how we have to go about this, it is a comprehensive approach. So where we will be talking about the pre-operative assessment. So you have the ABCD of nutritional assessment to be done first, and the perioperative nutrition care, and the post-operative recovery, how we will be planning out. So a detailed assessment will also help to assess who are under the risk of getting malnourished. So when we do the early screening and do the assessment properly, if there is an intervention to be needed, we can go ahead with that. The next coming to the dietary recall. So the recall here from whom we are getting, it's the parents or the caregiver who are there. So we need to understand from them exactly the portion size. What I see in most of my practice is like, the parents sometimes say that my child takes very less. The quantity for them, they don't know what is the exact requirement for that age group. Say for example, it's a 1 year or 2 year old kid. The mother might say that my baby takes only 1 roti, or like you say 1 idli. So that one giving you a total of the calorie of 1000 calorie would be okay. But for mothers, sometimes they think that, that is less. So we need to analyze the dietary requirement based on that age group requirement. So 1 to 3, what is the requirement? How much is the child intake? We should not be comparing it with the older child. So with the child's age group, we need to understand that. And then coming to the diet pattern, where they are lacking. So that lacking amount, if it cannot be adjusted by the diet, then we go about adding the oral nutrition supplements. And if that's not working out, then we think about the enteral or parenteral nutrition. So ERA's protocol is something which has been very much followed in adults population, and we are all in support of that. But however, what we see is in coming to the Indian scenario, the enhanced recovery after surgery in pediatrics protocols are lesser. I've just picked up few of the hospitals where they have this ERA's protocol being followed. So if you're interested, you can go to their website also. They have given in detail about what exactly they do in that. So for general surgery, elective adolescent surgery, total nephrectomy, then for intra-abdominal oncology procedures, pediatric laparoscopy, cholecystectomy, appendix, for all this, there are protocols which are available abroad. So when I say that it's not much being followed, especially even in our country, so this is one of the study which is supporting the reasons why it could be. Because some believe that it's not needed, as baseline physiologies of children are better than adults. So children less prone to morbidity and mortality concerns due to their development age, heterogeneity in age and development status, lack of high quality evidence of multiple elements of ERAS in children, and belief of children that ERAS is already implemented, because we are not keeping them nil by mouth for quite some time. Practically in a hospital scenario, you can understand that, you can't keep them for nil by mouth for a long time, they start crying. So it's really difficult to manage them. So the time of planning the surgery goes such that maximum we take it like less time is only there for them in the fasting. So this happens in most of the centers. So they believe that, no, this is like ERAS we are following also. So then other thing is like there are nutritional impairment and surgical outcome. So when there is prolonged fast, disease, stress or trauma, this could lead to depletion of body stores, mainly the protein reserves. So there are chances of increased morbidity and mortality. So the severity of nutritional impairment is strongly correlated with increased risk of subsequent morbid effects. So this in turn, what is actually happening? The risk is increased during the surgery. So NBM before, during, and after surgery, this matters a lot. So this post-operative metabolic response is exaggerated by the preoperative fasting. So when there is a prolonged fasting, the greater degree of post-operative insulin resistance taking place, there is limited fuel stores in children's fasting may have significant implication for the metabolic response to surgery, the type of interrupting fluid administration. This can also affect the metabolism. So there are special problems in the nutritional support of pediatric surgical patients. So like when how they respond to the stress differs. So metabolism of children are markedly affected by the operative stress also. So clinical examination is very much important. But apart from that, what we need to understand is estimation of the metabolic rate and also the energy rate. That is again very much important. So how do we do the analysis of the how much requirement the child has to go? The golden standards are going for indirect calorimetry, which is a reliable methods of measuring energy expenditure. So the problem is in all centers don't have the indirect calorimetry, right? So then when we are not having, if we take our country itself, maybe 2 or 3 centers only where they will be following the IC, but if not, how we can do in a practical scenario. So RQ is a way where you can understand if you have the indirect calorie, you can find out whether the child is underfed or if the child is adequately fed or having an indicates overfeeding. This can be calculated with the RQ ratio. So this would be what could be of a practical scenario. When we don't have indirect calorimetry, we can go for Schofield, Food Agriculture Organization, WHO, United Nations University equations can be used. So this can be, and what you need to remember is White and Harris-Benedict equation. That will not be validated for children. Okay, so we'll have to avoid that. Go for the other equations which are permitted. So once you do the analysis, how do you go with the nutrition intervention? This is like you have the enteral feeding as the first choice. And only when we are not able to go for, when the gut is not working, do we think about going for the parenteral nutrition. And in all cases, an individualized adequate diet is must. And based on how much there is, so it's not based on the specific age group alone. Like we classify it's a 5 years old, so they require 1,500. It needn't be that same for all the kids. So it will be an individualized base, which we will have to target it. And when should be initiate? If the child has to go for initiation on EN, we do suggest as early as possible. First, within 24 to 48 hours after the PICU admission. So you can start with the EN when it is applicable. And the sites which you can say where it has to be delivered, we prefer the gastric route. Gastric route is the preferred site. The post-pyloric or the small intestine site for EN may be used in patients who are unable to tolerate the gastric feeding or those who have the high risk of aspiration. So what are the challenges? So for nutritional support in there was this is ESPENIC is one of the people who they come up with various guidelines, conferences in which they talk about the challenges and other things, in which the last what they had said was there are greater challenges than the general surgical pediatric patients. Critically ill, they are under the most risk. So 1/3 of an infant's energy need is provided to support the growth. So 30 to 35 calories. So when they are very sick, right, you needn't give the target calorie the first day. You can go really slow. So say, for example, the child is requiring around 2000 calorie. The first few days, you can step up slowly. Look into the pre-diet analysis also, what was the intake, then target the calories. So go slow and catch up so that you will avoid going for refeeding syndrome. So the initial 50, 60, you can step up slowly, 30, 35, go up and reach the target calories. So based on the clinical condition, how they are doing. So how often is EN effective in meeting the calorie goal of critically ill children? Several studies have demonstrated that septic or critically ill patients, they meet only 25 to 50% of the nutrition goal. So unmet nutritional goal, what are the other reasons? This target goal, I'm not talking about the reaching of the target goal. Before that also, there are certain times that specific 40 or 50 we aim, we will not be able to meet that. That might be because they are kept, there will be interrupted feedings could be there, or related to NBO for any surgery or fluid restriction or feeding intolerance. What in our center we do when we have the gap, some procedure gone and not given, also we try to catch up the fluid in rest of the whole day and try to meet the requirements. So that adjustment and that regular follow-up need to be there to see to that the volume what is permitted, you use that. Not that because the procedure was there or some interruption was there, it didn't meet up. So we can target and work it out like that better. So this is generally an algorithm to give you a picturization of, like, how you can go about when it is enteral feedings, like you have the NG feed, whether it be the bolus or continuous, how you can reach the full calories. Or even one more thing, in certain cases when you are not able to feed directly, you can even go for trophic feeds, especially this is in terms of neonates also, that it do help them rather than to not use the gut at all. If the trophic feeds can be given, that can be only 10, 20 or 30 ml also, that really helps. And the volume also to start, you can start with half strength. Certain cases we will not be able to go with the full strength immediately. So go with half strength and then slowly it can be increased. And this is again the nasogeneral, which is almost the same as the previous. Coming to this, I would like to just add on. This is about the parenteral nutrition. Okay, so a biggest challenge, even myself, like around 20 years back, when I had to plan a TPN for a neonate, it was the most scaring thing. To enter NICU is something, you're like left out, like I don't know what to do. But as experience, even now I feel very scared when I'm dealing with neonates, because it's a very delicate place. And the child whom you have, the infants are like 1 kg or 1 point and 2 kg. So the exact amount what you give against matters a lot. So you have to really go slow. They do require the dextrose, protein and fat also, but how much you go for matters. Again, based on each consultants, they have the different viewpoints also. Some go, like we go from 1 and reach to 3 grams of protein, but some prefer like you can go from 2 to 3 immediately, and some says that you can go from 3 grams per kg protein also. So this formulation can be different, but this is just a general setup for you to understand, assess the fluid, then you can start the carbohydrate as 4 to 6 mg per kg, advance it slowly to 1 to 2 mg, then the goal can be to reach 12 mg, so that you can be sure the carbohydrate dextrose GIR rate is maintained. The same way as I said, protein, you can go slow and reach the target to 3 gram. Coming to lipid also, go slow, reach to 3 grams per kg. And along with this, you need to go for the multivitamin. One more challenge is in pediatric setup is you don't have multivitamin or trace element to the pediatric population strength. What we have are the adults based. So the volume what you use, that 5 ml 1 ampule might not be required for a 1 year or a 5 months old. So you need to calculate the calories, calculate the vitamin requirement, adjust with that 1 ml, see how much dose you need to give. In certain days, it might not be daily basis, you will have to give the multivitamin or trace element. So that scenario, you can plan it like the second day, alternative days, or weekly 3 or 4 times you can give, adjust the MVA. So the MVA and trace elements also you need to work out on that. So with that, I'd like to summarize that early detection and management of malnutrition is essential to help in healing and promoting the growth and development. So there are evidence of ERAs, but following is apt to be implemented. So slowly we will be taking up in further, and we'll try to come up with even pediatric guidelines as it has come in the cancer guidelines by IAP in India, to try to figure out all this can be sorted out. Thank you.
Thank you, Ms. Lika, for informative presentation, because less work is done on the pediatric, everything, the calories and everything is not, validated. I have some questions, like you have mentioned intraoperative fluid affects the BMR. So how it affects the metabolic rate?
No, the thing is like, when you're maybe in certain scenarios, say example for cardiac patients are there, right? So for cardiac, they might be having you will detect their cardiac problem even in the neonate times. So when you are going to start the feed and you're not adjusting the volume, that could give you a problem. So like certain cases, based on that individuality thing, it will differ. So you have to go for a fluid restriction right from the beginning. And nowadays, like, from the neonate period itself, you detect that during the 5th or the 7th month scan, and immediately after the procedure, the child can be taken for the surgery. So you understand that, and if you are doing it, fine. But the cases where it's not been planned, the volume restriction or not is not been done. So in such scenario, it could be a problem. So we just have to have that in mind.
Okay, thank you. And also for the malnourished children, that is India is, has a very large number of malnourished children. And if the surgery has to be planned, so what are the steps that we can take?
What we can do is, if it's a planned surgery in the prior, like when you're going for before going for the doctor sees, they should refer the patient to even a dietitian. How you go for an anesthesia and meet the anesthesia, that's the they'll check and note down what is the issue. The same way the dietitian should also be met, and dietitian should evaluate seeing the diet recall. And if needed, like what the measure is to be done, we need to do immediately. This can work out if it's a planned surgery. But if not planned, that wouldn't be possible. But otherwise, why do you think about the surgery? Before that itself, I think they all should start meeting if they are not meeting the requirements.
Okay, okay. Any questions from our audience? Yes, please.
TPN, we go about with soya based. What we have currently are what we have for the adult, the same only.
Ma'am, you said about micronutrient in TPN cases. What are the guidelines or which things we have to follow to find that?
Right now, we go with the estimated energy requirement. You have the NN requirement that you can take it based on your age group and then give accordingly. So in TPN also, with that MVI or trace elements, what you have, compare it with your requirement and adjust it and give it like that.
And another question is,
you can take the next question in the lunchtime due to the paucity of time.
Thank
you very much. So now we would be, presenting our next speaker. She is Dr. Rajni Sharma, and she is Additional Professor, Division of Pediatric Endocrinology, Department of Pediatrics, AIIMS, New Delhi. She is MBBS MD Pediatrics, former Senior Resident and Senior Research Associate, CSIR, Pediatric Endocrinology, AIIMS, former faculty in Pediatrics, former Joint Secretary of Indian Society of Pediatric and Adolescents Endocrinology. And she has also won Sir Dorabji Tata Prize for Best Undergraduate in Biochemistry. She has been awarded by Royal College of Pediatrics and Child Health. And she has also many 60 indexed publications and 28 book chapters. We welcome you, ma'am. Please start your presentation.
Thank you so much. And at the outset, I would like to thank the organizers of the conference of IAPN and Dr. Das for the kind invitation. So today I will be talking about nutrition in type 1 diabetes. I'll just like to share my screen. So just one second. I'm unable to see the slides, but I'll just try again. Okay. Yeah, can you see my slides?
Yes, they're visible.
Okay. So I'll be talking about type 1 diabetes, an overview and the nutritional management. So basically type 1 diabetes is one of the most common chronic conditions that you will see in children. It has a high prevalence. Almost there are 170,000 cases in India. And every year, almost 15,900 to 16,000 cases are added. And at any given point in our OPD, we would see around about 10 new patients per week. And it's an autoimmune disease. As you all know, it is caused by the destruction of the pancreatic beta cells that produce insulin. And presently, there is no cure for type 1 diabetes, and we have to rely on insulin. So before the discovery of insulin, type 1 diabetes, which was known as the juvenile onset diabetes, was uniformly fatal. So all the children who had type 1 diabetes, once they were diagnosed, they invariably died of starvation, unquenchable thirst, and there was absolutely no treatment till Banting and Best discovered insulin, and they isolated it from the pancreas of a dog. And they also went on to win the Nobel Prize in 1923. Since then, life of children has changed because of insulin. And there is this patient who was one of the first patients to get insulin, Teddy Ryder, and he went on to have a very healthy and long life. So it is possible to lead a healthy, long life with type 1 diabetes. So what are the pillars of treatment of type 1 diabetes? Basically, insulin is one pillar of treatment without which we cannot do without insulin. That is essential. And second is the nutrition. It is a very important pillar of diabetes management. And the third is the self-monitoring of blood glucose. A monitoring is required on a daily basis. So what are the goals of therapy for type 1 diabetes? First of all, our goal is that the child should have a normal growth and development. They should be normal glycemic control, and so as to avoid all short-term and long-term complications. What are the short-term complications? Diabetic ketoacidosis, hypoglycemia. And if the hyperglycemia is persistent, in the long term, it can lead to macrovascular complications like cardiovascular disease, or microvascular complications like it can affect the eye, retinopathy, nephropathy, and neuropathy. So we want to avoid all this by maintaining a good glycemic control. And our another goal is that the child should lead a happy, healthy life with good quality of life, with participation in all the curricular and extracurricular activities. So we must understand that there are certain blood glucose targets that we have to keep when we're dealing with diabetes. And the HbA1c, which shows the metabolic or the glycemic control over the last 3 months, also has to be monitored. So this is divided into the various age groups. Like in younger children, we tend to keep a higher target of blood glucose because we want to avoid hypoglycemia. As the child grows older, our glycemic targets, they become a little more tight. So for example, in the fasting or pre-meal glucose, for older children, we like to maintain the adult targets of 90 to 130 milligram per DL of blood sugar. At bedtime, we like to maintain around 90 to 150. And the HbA1c targets of less than almost 7. Whereas in younger children, we can keep slightly higher targets for the fasting, that is 100 to 180. At bedtime, up to 200 we can accept, and the HbA1c less than 7.5. So these are the various targets we have to keep in mind while we are planning the therapy. Now it's important to understand what is the normal physiological insulin secretion which we aim at. So basically in our body, whenever we have food, like our meals, the breakfast, lunch, dinner, we have the insulin is secreted in the body and the plasma insulin levels rise. Even when we are not eating anything, so at the basal level, we see that the little bit of insulin is always secreted. This is known as the basal insulin, just so that the liver doesn't start releasing glucose. And even in the fasting state, the glucose is maintained at a normal level. So this is the kind of insulin secretion that we try to mimic. So basically, we have to understand what are the types of insulin that we are giving to the child. There are certain basal insulins, that is, which provide the background cover of insulin without meals. These are the intermediate acting conventional insulins like NPH. Then we have the long acting or the analog insulins like glargine, detamir, or gledutec. These are formed by the chemical alteration of insulin, the normal insulin that is found in the body. Then we have the bolus insulins, which are the short acting conventional. They act for a few hours. These are given with the food, and like regular insulin is the most commonly used. And then we have the rapid acting analogs such as Aspart, Lispro, and Apidra. So whenever the patient comes to us, we must be aware what is the kind of insulin the child is taking and what is the onset of this insulin, when does it peak, and what is the duration of its action, so that we can prescribe the diet accordingly. So this is a table which I think you can take a screenshot of, because you should always remember when this patient, which insulin he is taking, when does it start its action, when does it peak, and till when the effect lasts. For example, regular insulin will start acting after half an hour. It will peak after almost 2 to 3 hours, and the effect will last for 6 to 8 hours. Whereas if we give the analog insulin, the effect starts within 15 minutes. So you just have to give it 10 to 15 minutes before food. The peak will happen in 1 to 2 hours, just when the child has been, when the postprandial glucose is rising, then it will peak. And the duration will be only 4 to 5 hours. So this child this has a very good blood sugar lowering effect, Lispro compared to regular. And this is another diagram just showing the effects of the insulin. So you can see that the Aspart, the yellow one, they peak immediately and they have a short duration of action. Regular would have a slightly longer duration of action, up to 6 hours, but the peak is not so much, peak action. NPH would last up to 12 hours, and glargine is a peakless insulin which lasts up to 24 hours. Now coming to the insulin regimens, we have the split mixed conventional regimen or the basal bolus, the analogs, based on analogs, which is the one which is preferred nowadays. So split mixed consists of basically 2 doses of insulin given at a fixed time of the day. Basically, it consists of a short acting regular insulin and an intermediate acting NPH insulin. And the total daily dose, we give it as 2 injections before breakfast and before dinner. So this is how this insulin would act. Like you can see that at breakfast, we give the regular insulin half an hour before, and it peaks after 3 hours. It covers the breakfast, but after 3 hours, it will have a peak. So we'll have to give a snack after 3 hours. And the NPH, which we have given along with the insulin, will peak at around lunchtime. So it will cover the lunch phase. Then in the night, again, we will give regular insulin, which will cover the dinner blood sugar rise, and the NPH insulin, which will cover the nighttime blood sugar rise. So again, in the night, we would have to give a snack after dinner, after 2 hours of dinner, so that the regular insulin, when it is peaking, it does not lead to hypoglycemia. Coming to the more physiological, that is the basal bolus therapy, it mimics the physiological insulin secretion. So we give a background insulin like glargine, which acts for 24 hours. And we give a bolus insulin, which is known as the rapid analog, which starts acting almost immediately. It covers the meal blood sugar rise, and the dose can also be adjusted depending on the meal size or the carbohydrate intake, which I'll come to. So this is a more preferred type of insulin. It is more physiological. It has less hypoglycemia because there are no delayed peaks, and it has a better flexibility of the eating. But the downside is that it is more costly. It involves more shots of insulin, and you also have to frequently monitor the blood sugar. So this is how the basal bolus therapy would look like. So the blue indicates that the basal insulin is maintained by a long-acting glargine insulin. And whenever the child eats the meals like breakfast, lunch, and dinner, he takes a rapid shot of insulin, which will cover the blood sugar rise. Now, the medical nutrition therapy. This is my talk is based on these 2 guidelines. One is the International Society of Pediatric and Adolescent Diabetes Clinical Practice Guidelines for Nutrition in Children and Adolescents. And the second is one Indian perspective, which is from our group only, Anuja ma'am and myself. This is medical nutrition therapy in pediatric type 1 diabetes patients in India. So you can go through these guidelines for more detailed review. Now, what are the goals of the medical nutrition therapy? So first of all, there is a myth of a diabetic diet. There is no such thing as a diabetic diet. It is basically a balanced diet consisting of all the macro and micronutrients in the RDA. And nowadays we say in the estimated average requirement, the EAR. And it should be targeted to maintain the optimal growth and body mass index. It has to be individualized to the social, cultural, and economic background of the patient. And our main aim is to maintain the blood sugar targets in order to avoid any complications. At the same time, we have to be careful to avoid too many restrictions because this is a lifelong diet which the child has to follow. And so too many restrictions will not work. So we have to give adequate amounts of both macro and micronutrients. As Anuja ma'am mentioned, the whole family has to be encouraged to follow a healthy meal plan. And it's not only the child who should be having a special diet. We encourage the intake of complex carbohydrates instead of refined because it lessens the post-meal spike of blood glucose, especially the low glycemic index food. And the dietary advice is tailored according to the child's daily schedule, family and culture practices, and the traditional eating habits. As I said, too many restrictions are not done. Even sweets are allowed sometimes. And these foods like high carbohydrates, simple carbohydrates, high carbohydrate intake is allowed when the child is taking some insulin before exercise, during hypoglycemia, or intercurrent illness when the child has a poor appetite. So the energy requirements are the ones which are mentioned in the expert group Indian Council ICMR guidelines. And these are carbohydrates consist of around about 45 to 55%. And the sucrose is allowed up to 5 to 10%, not more than that. Fat has to be 30 to 35%, less than 10% saturated, and protein 15 to 20%. So it's basically a healthy diet, which is based on, what is a healthy diet? It's a homemade diet based on fresh fruits and vegetables. Of course, fruits have to be in a limited amount so that too much of hyperglycemia does not occur. Whole grains should be used, pulses, legumes, milk products, lean meat and eggs, and avoidance of excessive sugar, fat, and refined carbohydrates, and avoidance of packaged food. So basically, these are all the components of a healthy diet. And we try to reduce the glycemic index of food by adding protein to the diet. If we prefer to use unpolished pulses, which limit the blood sugar rise, use more of complex carbohydrates and whole wheat, addition of fiber like salads to the diet. And if the child is having any snack, which he doesn't want to take insulin, then it should be only up to 5 to 10 grams of free carbs if the child is on analog insulin. So these free carbs are basically egg, paneer, cheese. So in the guidelines, the exact amount of how much can be taken is mentioned. Dry fruits or chana salads and soups. These are called free foods which can be eaten without the need for taking insulin. But at mealtime, the child would be taking insulin. Now, what are the approaches to meal planning? So first of all, when we educate the parents, we tell them about the plate method or the food pyramid. So as you all know, half the plate should be consisting of vegetables and green leafy vegetables, milk, and all these healthy food. And 1/4 of it should be the grains or the starchy vegetables, and 1/4 should be the protein. So this is how we educate them regarding a healthy meal plan. If the child is on a fixed insulin dose of conventional insulin, then we give a fixed meal plan that this is the amount you have to eat in each meal. And we give the traditional exchanges, like if you're not eating this, then you can exchange it for this other product. In a flexible regimen, we have to teach them how to count the carbohydrates in each meal and change the insulin dose according to the carbohydrate amount. So if the child is on a fixed dose of insulin, then we give fixed doses of insulin and we have a fixed meal plan. So the distribution is generally, if the child is on a conventional therapy, then we give 25% of carbohydrates in the breakfast, 25% in lunch, and 20% in dinner. And 10% carbohydrates would have to be given in mid-morning, evening, and bedtime snacks. This is because the regular insulin, as I told you, will have a peak after 3 to 4 hours. And at that time, the child must consume a snack consisting of carbohydrate, otherwise he will have hypoglycemia. And we give them traditional food exchanges for carbohydrates, protein, fat, and milk products. In this kind of diet, there is no flexibility in eating, and it's a little difficult to comply with, though we have seen that many children do comply with it and they have good glycemic control. So the most important thing is the compliance with the diet. Yeah, I'll just be winding up. The diet on basal bolus therapy is much more flexible. So even on basal bolus regimen, some patients prefer to have a fixed diet plan so that they don't have to think too much and they have a fixed meal. But we can also tell them a flexible regimen based on the carbohydrates. So they count how much carbohydrate they have and they change the dose of insulin accordingly. So what is carbohydrate counting? Basically, it is the carbohydrate amount which determines the blood sugar levels. Protein and fat do not contribute so much to the blood sugar rise unless they are in very large amounts.
Dr. Rajni, please wind up fast.
Yeah, I'm just doing that. And you identify the food items with the carbohydrates. You measure the food items with a standard measure, and you learn the quantification and give insulin accordingly. So I'll just give one example of how to do this. This is the resource on carbohydrate counting by Ms. Cheryl Salis, and you can go through this for more details on how to do carbohydrate counting. So the insulin that has to be given, this is known as the insulin to carbohydrate ratio. It is calculated by doing 500 divided by total dose of insulin. Suppose there is a 6-year-old boy who is taking 20 units of insulin. So how do you calculate the insulin to carb ratio, or the grams of carbohydrate which will be covered by 1 unit of insulin? So the formula is 500 divided by the total daily dose. And so in this child, he's taking 20 units. So 500 divided by 20 units. So it will come out to be 25. 1 unit of insulin will cover 25 grams of carbohydrate. So whenever he takes 25 grams of carbohydrate, he has to take 1 unit of insulin. So the method is, when the child comes to you or the parents come, you first take down the normal routine, the school timings, the activity, the exercise, and then you do a dietary recall. What are the meal
Show
timings?
the slides. Don't please read the whole slide.
Okay.
You can show the slides to
the and the anthropometry and BMI and the insulin regimen. And then you teach them how to do the carbohydrate counting based on 15-gram exchanges or portions. This can be done through books, handouts, PowerPoint, and some apps are also available. And the patient maintains a blood diary for this, and we calculate whether the insulin sensitivity factor and correction factors are correct or not. Okay, so the key messages are that medical nutrition therapy is an important component of diabetes care. It should be tailored according to the patient's daily routine, insulin requirements, and cultural practices and family values. It should be based on the principles of healthy eating, and we have to introduce some method of carbohydrate quantification. Thank you.
Okay, thank you, Dr. Rajni. And a quick question is from my side is, if we know that diabetes mellitus has many complications associated with it, so how you deal with the children who are losing weight or muscle mass due to diabetes mellitus?
First of all, the child is losing weight, then obviously the glycemic control would not be adequate. There must be something wrong going on either in the insulin requirement, or maybe he's having too much hyperglycemia and he's losing sugar in the urine. So you have to optimize the glycemic control first of all. And of course, if the child has some eating disorder, then also it can lead to poor control and all these complications. So more important than that would be to first control the glycemia by optimal insulin regimen. Okay. And of course, the RDA is calculated, or the requirement is calculated based on the current body mass index of the child.
Okay, thank you. Any questions from our audience?
I request Anuja ma'am and Ashima, Dr. Ashima is also here to please give their inputs. Hello, Ashima.
Hello, ma'am. Thank you for the very nice talk. I just would request you a comment for the audience on sugar-free products, especially for children with type 1 diabetes. If we can give one-line message for our audience for that.
You can go ahead and give, Ashima.
Okay. So as ma'am was talking about the need for balanced diet and nothing like a specific diabetic diet, it is important to educate all families that there are no sugar-free and fat-free and diet-free products that should be encouraged in childhood at least, and especially not in children with type 1 diabetes, because even if they are low on easy digestible sugars, they are going to contain more harmful fats and other products which we do not recommend. So another message would be that do not encourage sugar-free and diet-free products for children with type 1 diabetes or otherwise also. That's all I wanted to add, ma'am. Thank you.
Thank you, Ashmi.
Yeah, that's very beautifully said, Dr. Dabas. That normally, when somebody has diabetes, they start looking for the sugar-free stuff. So they should be taken care, encourage healthy eating. If really sugars are required, they can think about using jaggery or honey, but that too in a restricted amount. We can't go liberal on that. Excellent. Thank you so much.
Thank you so much.
Beautiful presentations. Thank you. Thank you so much. Another 10 minutes of yours I'll take. Lakshita ma'am, I want to request you to felicitate Lekha ma'am. So I think the PDA session was excellent presentation with more of online, but I think a lot of learning. Thank you so much, ma'am. Thank you. And Shilpa, I'd like to request you to felicitate Lakshita ma'am. Thank you so much, ma'am, for sharing this session. Thank you. Dr. Biju, I want to request you, sir, for general release.
Yeah, the journal.
Sir, over to you. Thank you.
I think it's a very small neonatal step by the association to just bring out the journal. So we are just from the journal team, we are handing over the first copy of the printed edition to our Honorable President, Dr. P.C. Vijay Kumar. Sir, please come to the stage, and I also request the available NAC members to come and receive the first preliminary copy of the journal.
Congratulations, sir.
There is a small announcement I would like to make. This is for the people who have submitted abstracts with us. So we have chosen top 10 abstracts, and I would like to thank jury, Dr. Biju, Ms. Shrimati, and Ms. Anshu Mehra for their efforts which they have done. Just announcing the names of the winners over here, so that if somebody is leaving early, they can connect us over here in the auditorium for this. The top 10 people who have been chosen are Ms. Nida Athar. She's from Lady Irwin College, University of Delhi. Second abstract is from Golo Mary. She is from Manav Rishna University. Third is Ms. Smita Singh. She is from Lucknow. Fourth is Ms. Megha Kapoor and Mr. Shiv Shankar and Purbi Mahajan. Okay. So fifth is Bhagyashri. Again, Mr. Shiv Shankar and Dr. Shaista Mehtas. Sixth is Priya Gala. And seventh is Ms. Tamil Larsi and Ms. Aljurumohi. They are from Puducherry. Eighth is Riya Dedia, and again Mr. Shiv Shankar, Tanmati and Purbi Mahajan. Ninth is Ms. Kalpana Gupta, and they are from Sharda University, Noida. 10th is Fidlia Khoronkar, she are from Pune. So if all of you are been present over here, please be here. And if somebody is leaving early, do inform us, because the validity function will be happening after the session, post-lunch session of trauma. So it will be around 3:30, 4 o'clock. So please connect us if you are leaving early. We are waiting for the lunch over here, and by 2 o'clock, we'll be back here in the hall. Thank you.
अब आया Hello everybody. Kindly please call your friends if they are outside. We are about to start the session.
abstracts वाले जिनके हैं उनको हम पहले अवॉइड करना चाहते हैं ना सेशन स्टार्ट करने से पहले हाउ शुड वी अनाउंस इट हमारे लोग को भी जाए क्योंकि स्मिता सिंह की भी 3 बजे फ्लाइट है 3 नहीं स्मिता को जानती हूँ मैं स्मिता का फोन नंबर फोन ही करे टेल नेहा टू कॉल देम अप नेहा इज द कमिटी मेंबर ना आपने तो बुलाया मैंने उसी टाइम आ गई थी नेहा को बोलेंगे कि वो बुला ली रतिका को बोलूं मंजू को बोलती हूँ ना सर्टिफिकेट तो आएगी उसके पास सर्टिफिकेट भी है सबको बुला ले पूछ ले कौन कौन है अंदर नहीं बाहर है बाहर ही बाहर ही अंदर नहीं है बाहर के पास सर्टिफिकेट भी है ना बिना उसके तो काम ही नहीं चलेगा मैंने नाम लिख दिया नेहा को लगाया नेहा वी नीड सर्टिफिकेट्स एंड वी वांट दैट यू आप कहाँ हो नेहा एक बार अंदर आ जाओ आप अंदर आ जाओ नहीं नहीं और वहाँ अनाउंस करके आ जाओ कि हम एब्स्ट्रैक्ट का अवार्ड अभी दे रहे हैं प्लीज स्टूडेंट्स इफ दे आर बीइंग आउटसाइड सेशन इज आल्सो स्टार्टिंग सेशन इज स्टार्टिंग तो आप बोलो उनको हम अवार्ड दे रहे हैं एब्स्ट्रैक्ट वालों को तो लंच में भी अनाउंस कर दो स्टॉल के सामने भी अनाउंस करके ऐसी आवाज में कि मतलब जस्ट बट प्लीज कम इनसाइड फास्ट टेल एवरीबॉडी टू हमें पहले देना है आप जितने लिखे गए हैं आप उतना ही ले आओ मेल बैठ के लिख लेंगे
I'm announcing the names of the people who have won for abstracts. If they are present over here, I would like them to be seated in front row. Miss Nita Adarsh, is she here? Nida. Okay, please come forward and be seated into this front row. Miss Golo Mary, is she here? Okay, Golo is not here. Miss Smita Singh. Smita Singh. Miss Megha Kapoor. Miss Bhagyashri Parab. Miss Priya Gala. Miss Tamila Rasi. Miss Ria Dedia. Miss Ria Dedia. Okay. Miss Kalpana Gupta. Miss Fidelia. Okay. So now I would request the jury, Dr. Biju, Miss Srimati and Miss Anshu Mehra, to please kindly facilitate all the abstract winners. So let me have Miss Nida over on the stage. Her paper was on effect of perceived stress on nutritional status and nutrient adequacy of antenatal women of urban Delhi. Congratulations. This is also meant for fire. Miss Smita Singh is here. Okay, please come. So Smita has submitted on self-management in diabetes care and evaluatory study among outpatients in Lucknow city. Congratulations. Miss Megha Kapoor. Megha Kapoor has done on papillary renal cell carcinoma and management of adult onset nephrotic syndrome with hyperalbuminemia and renal amyloidosis. Please come forward. Welcome. Ms. Bhagyashri. Bhagyashri has done on effect of predictive factors and rate of bilirubin regression post Simpson cancer patient. Congratulations. Priyal is here. Please come. Priyal has done on baseline characteristics and prognostic nutrition index of cancers in females. Congratulations. You're Priyal, na? Okay. Ms. Tamila Rasi. She's done a role of probiotics in the management of Helicobacter pylori infected patients. Come forward, Ms. Tamila Rasi. Just So next is Miss Ria Dedia. Is she here? Please come. So Ria has done plant and sodium restricted alkaline diet for a polycystic kidney disease and renal and seminal duct calculi, a case report. Miss Kalpana Gupta. Kalpana has done on current nutritional practices and weight trends in pediatrics oncology patients. Please give a big hand of. Miss Fidelia is here. Miss Golo is here. Okay. Please come. So she's done a CAP study on nutritional attributes at indigenous vegetables and its consumption pattern among adolescents of Perioperative district.
This was a unique paper. She has taken so much effort to go for the indigenous vegetables. It was very interesting. If you can, you see, I think she deserves a good round of applause.
So I think we have finished with. Thank you, Judy, for this, because I think most of the students are not present. Rest of them. So we move on to our next session and the last one, burns and trauma nutrition. Our chairpersons are waiting for us to start on with. We have our first chairperson as Dr. Mohit Joshi. He is Additional Professor, Department of Surgical Disciplines in JPN Apex Trauma Center, All India Institute of Medical Sciences. His MBBS, MS and DNB. We welcome you, sir. Okay. Our second chairperson is Dr. Biplav Mishra. He specializes in thoracic surgery, torso trauma surgery, and general surgery. He's MS General Surgery, AIMS, New Delhi. We welcome you, sir.
Thank you.
Our next chairperson is Dr. Kajal Pandya. We all know Kajal. She's the secretary for IPEN Delhi, and she's the chief dietitian with Apollo Hospital with over more than 25 years of experience into clinical nutrition. We welcome you, Kajal. And we have Ritika Samadar, our NEC member from IPEN India. And Ritika is chief dietitian with Max Healthcare. And she's the joint secretary for Delhi IDA also. She's integrated health member for IFSO and life member OSI with an extensive experience of more than 26 years in the field of nutrition. We welcome you, Ritika.
Thank you.
Over to the chairpersons.
Thank you so much, Shilpa. We start with today's session, which is on sepsis and trauma and burns. The first speaker for the session is Professor Dr. Manish Singhal. Dr. Manish Singhal is the founder and head department of plastic and reconstructive and burn surgery, All India Institute of Medical Sciences. He has authored more than 80 papers and has a lot of and also is part of several funded research projects. He's an expert for several committees in the Ministry of Health and Family Welfare. I welcome you, sir, and he would be talking on the practical approaches to for nutrition in burn patients.
Thank you.
Thank you, madam. Thank you for the introduction. So I'll be talking today on practical approach to nutrition in burns patient, and I'm going to touch upon things which are very specific for burn patients, because we have an august audience of all nutrition specialists, so I'll not go into details of particular nutrition. So when I talk about nutrition support in burn patients, we have to understand that skin is the largest organ of body. Once there's a moderate to severe burn injury, once we say moderate to severe, we talk about something more than 20%. When there is more than 20% burns, unlike little less, let's say 10% burns, there's a lot of catecholamine release, a lot of cortisol release. There is a lot of fluid shift in the body. The vessels become very permeable. When the vessels become very permeable, they start pouring out the proteins and the major molecules from the blood vessels. And this permeability decreases with time, say 24 to 48 hours. So we have to understand that unlike minor burns or 10 to 15% burns, the moderate to severe burn injuries are a severe threat to nutrition. And I'll say, as a surgical management, we have a lot of things in our armamentarium, that is the burn wound management, the skin grafting, the burn excision. But in the medical aspect of the burn patient, apart from critical care, that is ventilatory management, I feel nutrition is one of the most important management which has to be taken care of to improve burn patients. So sometimes it becomes very life-threatening, because on one hand, we have to make that the skin heals, infection doesn't occur, and we have to simultaneously prepare the patient for further surgeries, which are many in number. And again, once there is a loss of skin, the patient is prone to infection. So how do we approach it? So as I told, that hypermetabolic response, I think this is the key to understand that how things work in burns. So once we tell about hypermetabolic response, it means that everything is increasing. The plasma catecholamines, the corticosteroid levels are increasing, which leads to a lot of catabolism. The liver, there is hepatic dysfunction, there is wasting of adipose tissue, there is wasting of muscle, muscle wasting in atrophy, and of course the impaired wound healing. So when we say hypermetabolic response, it means that there's a lot of nutrition is going into blood and it is moving out of tissue. So how do we respond to that? So as this graph says, if you see the major burns, now the burn patient versus other critically ill patient. So leave aside all critical illness, burns is the most important. Major burns has maximum catabolism. You leave all patient, major surgical, if you see this graph. So burns lies here. Major trauma comes just below. So initially it was almost 3 times. But once we have very good resuscitation, very good initial management of burns, now it has come down to 1.5 to 2 times. So in burn, the catabolism is the maximum. So unlike other surgically critical patients, the nutrition support in burns is extremely difficult and very challenging. So the energy requirements of severe burn patients are much greater. So on the one hand, we have insufficient intake of calories. There is decrease in lean body mass, immune dysfunction, impaired wound healing, and increased mortality. On the other hand, now the overfeeding is again a challenge. Once we do a lot of overfeeding, once we do overfeeding, it causes hyperglycemia, which decreases. Suppose we give a lot of carbohydrates, it will lead to hyperglycemia. It will also lead to hypercapnia, metabolic acidosis, and it is extremely difficult to wean the patients back if they are on ventilator, if we give too much carbohydrates. If we give too much fats, then again it leads to fatty liver infiltration. If we give a lot of protein, it leads to azotemia. So overfeeding also has to be very carefully addressed. We have to actually balance that how much feed has to be given, how we have to calculate it. So it has to be a perfect balance. So which are the candidates for burn nutrition support? So more than 20% burn area, this is roughly 12 to 70 years. More than 20%, I hope that everybody knows what is TBSA. It is total burn surface area is calculated by rule of 9 and many other methods. So a 20% burn in 12 to 70 years is a candidate for nutrition support. More than 10% in children and in elderly, again, they are candidates for nutritional support. Any suspected inhalation injury and any significant burns to the face. So these four candidates, these four patients we consider as candidate for specific nutritional support. We'll just take an example of a 45-year-old male, 65 kg with 30% TBSA, deep flame burns. Now, when to start, how much to give, which route to choose, dosing, mode of feeding, how to monitor whether we are giving adequate or not. This is a rough, I'll just take it through various parameters, how do we do it. So the goal is to ensure enteral nutrition, preferably through a nasojejunal tube by 48 hours. Now, why not immediate? Why not in first, say, 6 hours or 8 hours? As I told, it is extremely difficult because there is gastroparesis. If you give too much feed orally, it is sometimes difficult. If you give too much IV feed, it is difficult because there is a lot of capillary permeability. So practically we keep around 48 hours for the fluid shifts to occur before we start proper nutrition. Now, why enteral? Because as the skin is burnt, if we rely too much on parenteral nutrition, it may lead to thrombophlebitis, it may lead to repeated central line infections because of the skin burns, and we usually avoid any other parenteral route. And again, it causes a lot of metabolic dysfunctions. So the timing is to start around 48 hours. Enteral route is the choice, but again, the gut integrity is very important. And direct oral intake, up to 40%, the target, up to 40% burn, we target that we should try to give a direct oral intake rather than relying upon anything else. So if the patient can even take 75% or 80% of the prescribed diet, we try to manage the patient on oral intake. So this is how we think. So when to start? So you can think about starting in 4 to 6 hours of period if patient is absolutely stable, and this usually occurs with little less burns, say around 20% burns. Nutrition should be started when the perfusion of the intestine is adequate. Now, why I say this? Because, you know, when the fluid shift occurs, the intestine are the organs which are going to be affected most. There is mesenteric decreased blood flow because body is trying to maintain the blood pressure. And if you try to give feed at that time, sometimes it is problematic, and patient may lead to stasis and nausea, vomiting, and all these things. So we usually try to start as early as possible whenever the intestines are settled. I think this is a chart where everybody knows that we do a screening, diagnosis, intervention, and then follow up. This is the key of all the nutrition care. So how do we do assessment? We rely upon height and pre-burn weight. Sometimes it is not available. So we try to take a weight immediately in the post-burn period, because if you give fluid, then sometimes it is very difficult to understand that how much is the requirement. So we usually take as early as possible, because later on, a lot of edema occurs. And details of previous nutrition status, percentage of burn, site of injury, the gastrointestinal function as I told, and the pain. Now the pain again increases the catabolism. There is a lot of catecholamine release, lot of stress hormone release. So pain again increases the nutrition requirement. So we do a good pain control, pre-existing medical conditions. Now, if you just see the acute part, basically the initial part, that is the how do we monitor it? So we do a bi-weekly weight in acute burns. We calculate the calorie and protein daily. We do pre-albumin bi-weekly, C-reactive protein bi-weekly, BUN weekly, and indirect telemetry we don't believe on that. But we usually follow the clinical parameters. If you see the wound size, pain, fever, these three things increase the metabolic requirements. So we usually try to control pain, fever, and try to heal the wounds as early as possible to decrease the requirement of energy expenditure in patients. Now, there are a lot of formulas which you see, Harris, Benedict, Toronto, Cureri, and all those. So what we practice is the Cureri formula in the burns patient. And it is nothing but it's basically 25 into body weight in kilogram plus 40 into percentage of total body surface area. And this is usually standard which we use. Now, I have written a line here, if you see carefully, use for a maximum 50%. So if there is a 55% burn, my ceiling will be 50%. So the nutrition requirement in a 50% or a 70% burn is same, because we have to avoid overfeeding. Once we exceed the feed, once we exceed a particular limit, the complications start coming. So we usually calculate with a ceiling of 50% burn. So in 80% and 50%, the input energy what we give is same. As I told, the overfeeding of carbohydrate can give increased carbon dioxide production, hyperglycemia, protein can lead uremia, and fat can lead hypertriglyceridemia. So there is no rationale of increasing the feeds very much. So we usually balance it. So this is the general protein requirement. That is basically, I think everybody knows it, and it is 1.5 to 2 gram per kilogram per day. Same carbohydrates, fat. As I told, oral is the best. So we usually rely upon oral route, but we can go to enteral. We can go to mixed route, that is oral plus enteral, and enteral is the last thing which we usually prefer. We usually try to manage with enteral route. I think this is something which is common with every patient in whom we give enteral feed, and it is not different. For any ICU patient, we follow the same thing. So we basically believe in continuous infusion. We don't believe in intermittent bolus because it has its own complications. So the continuous infusion is what we usually prefer with burns patient. Now, how to monitor the adequacy and tolerance of the enteral nutrition? Again, it is almost the same thing. The only thing is that there's a lot of dressings, pain control, and a lot of surgeries are done. So between the surgeries, for example, a patient has to undergo surgery next morning. So between the surgeries, we try to reduce to the maximum. Weight gain is common during the resuscitation phase. Now, again, we have to understand very carefully that the resuscitation phase of burns means that we are giving lot of fluids. There's a lot of fluid shift occurs. Lot of fluid goes into the body tissues. Lot of burn edema occurs. So weight gain is there, but it is not equivalent to the betterment of nutrition status. So weight gain is something which is very deceptive sometimes. So we usually check the weight and make sure that the weight does not fall more than 10% below the baseline. So this is what we follow. So weight gain has to be seen, but we have to keep in mind that during the resuscitation phase, we give a lot of fluids. So fluids are mobilized slowly over next 2 weeks to 1 month period till the patient recovers. And then we again keep on reassessing the calories and protein requirement. Can I have 2 minutes? Okay, I can carry on with this also. Okay. So again, basically we try to we gradually go to the oral feed, and then we do a transition to the nocturnal enteral feed, and the daytime we do a oral feed. This is something I think of course, everybody practices mixed feed nowadays. Mixed feed, again, it is not one size fits all, and we usually mix the kitchen feeds along with the ready-made, what is available. I'm sorry to exceed this. This is just that protein requirements. It is something which children require more protein to support growth. I think Dr. Biplav, I can stop here with this slide. So just to summarize, that burn patients, unlike other critical patients, have lot of chance of infection. They need multiple surgeries, and they are they are in nothing but actually a polytrauma. Why polytrauma? Because the skin is involved, the cardiovascular system is involved, the urinary system is involved. A lot of patients go on dialysis. So unlike other critical care conditions, the burn patients require very careful nutrition monitoring. With this, I will thank you very much. Thank you. Thank you, Biplav.
Okay. Thank you, Dr. Manish. Questions?
Thank you, sir. Thank you for this crisp presentation. Just wanted to I'll take a question first. I'll ask a question first before I open it up for the house. Harita, you want to ask? You can go ahead.
Yes, I can.
I'm Harita from Apollo Hospitals, Hyderabad. The question that I have is, we understand that initially they are very hypercatabolic and we need to give higher calories. But at what point do you think the catabolism reduces and then we need to retailor the nutritional requirements or lower the nutritional requirements? Is there a
So I think this was coming later in my slides, but I'll just answer that. So usually the nutritional requirement doesn't decrease up till few months because patient goes to surgery, then the graft settles, then the physiotherapy starts, then the contractions have to be released. So usually this nutritional support keeps on carrying till the rehabilitative phase. It doesn't decrease in the beginning, just the route changes. Initially we try to give enteral, then oral, then the diet changes. But usually there is a lot of, I'm talking about the major burns.
Yeah, I'm agreeing with that part, that
Yes.
broadly the nutritional requirements continue for a long period of time. But would you even then differentiate between the first 4 weeks, like in the sense that the first 2 weeks you would give very high requirements, and then in the later on the requirements remain high, but not as high as in the first two weeks? Would you look at it that way or no?
Yes, yeah, I think you are perfect. You are very perfect in saying that. Usually all the formulas are they only take place for 2 to 3 weeks, and then according to the patient requirements, we decrease the nutrition. So it is not as high till the rehabilitative phase. Usually 2 to 4 weeks is the time, and we are very careful because the wounds start healing, say from 3 weeks onwards.
Doctor, one more question is the role of glutamine. How would you specifically look at it, especially as an oral requirement?
So I think whatever the routine supplements contain glutamine, we believe only in that. We don't give extra glutamine supplement. We don't practice that.
I mean, generally all the research specifically says that glutamine, being a conditionally essential amino acid, requirements are more established. I mean, the research is more established in burns, trauma, and not sure what is the other one.
So the research is there, but usually in our practice, we are not translating into the practice. We usually don't believe too much in glutamine, but then we know that it is being established, but we don't practice at this point of time.
All right. Thank you so much.
So we'll not take further questions because of the time limit. Whoever has a question can always get back to us. We can just.
Can I request Ritika to please felicitate sir?
Thank you, sir. So I would like to invite the next speaker, Dr. Mansha. Can I have her slide? Dr. Mansha, she's an MD and practicing in Mumbai. She's a pulmonologist and a critical care doctor. Dr. Mansha, please. Thank you. And her topic is nutrition in sepsis. Again, it's a very interesting topic for all of us.
I guess I'm not too loud. Okay. So good afternoon, everyone. I guess post-lunch, everybody is drowsy, but still I'll be as short as possible. So firstly, thank you so much for making me part of this conference and giving me this interesting topic. And yesterday I was talking to some of the senior dietitians that as a pulmonologist, what do you want from me in this topic? So this is what they told me, that they would like to hear more of the pathophysiology part. And as we all know that nutrition can be taken better care by you. So my topic for today is nutrition in sepsis. Sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. There is bacteremia, septicemia, and toxemia. These are the terminologies which are quite used as synonyms, but they are a little bit different from each other. Bacteremia, there is presence of non-harmful bacteria in the blood. Septicemia is presence of harmful bacteria in the blood, and toxicemia is presence of toxins secreted by harmful bacteria in the blood. There are a lot of sources of sepsis, amongst which pneumonia is the most common cause of sepsis. Then there are second most common is abdominal infections, and then others are like meningitis, catheter related, skin tissue related, bloodstream infections, and obviously the COVID. Risk factors involved are older age, infancy, diabetes, chronic kidney or liver disease, immunosuppressed states, and invasive devices. This is a simple pictorial view of what is the pathology. Like there is a local infection first caused by the bacteria entering into the bloodstream, damaging the endothelial lining of the blood vessel, then causing an immune system, immune response, then dissemination of the bacteria in the immune cells all over the body and leading to organ damage. And the second picture, which is I have put up, is a little elaborated view of pathophysiology. Like there is endothelial dysfunction leading to capillary leakage, leading to multi-organ failure, then the coagulopathy leading to DIC, and then again reduced tissue perfusion, cellular dysfunction leading to catabolic state, cardiovascular dysfunction leading to hypotension, and all of these altogether leading to multi-organ failure. The symptoms which you can remember by a mnemonic itself, sepsis: slurred speech, extreme shivering or fever, passing no urine, severe breathlessness, a patient feels like dying, and skin discoloration, amongst which slurred speech and severe breathlessness are the first signs to be seen. These are the steps seen in sepsis. The first one being systemic inflammatory response syndrome. There is either temperature being more than 100 or less than 96, respiratory rate more than 20, heart rate more than 90, increased blood WBCs, and patient is in acidosis, that PCO2 levels less than 32. And sepsis, amongst these serves two of the criteria with confirmed or suspected infection. And in severe sepsis, there is sepsis with signs of end organ damage. And in septic shock, there is severe sepsis with hypotension. This is the criteria which we usually use in the ICU. This is known as SOFA score, sepsis organ failure assessment. This is a little complicated, only used in ICU setup. We rely upon certain blood parameters, and it takes little time. So I recommend using QSOFA, which is very useful in actually seeing patients who are outside the ICU and actually are in sepsis, and we don't know it. So there are three variables which can be used, which is used in this, that is hypertension being less than 100 millimeter mercury, patient is in altered mental status, is tachypneic, and score more than 2 suggests a greater risk of poor outcome. This is a small summary approach to sepsis patients. First and most important is early recognition of these patients, and then classifying these patients, whether they are actually meeting the sepsis criteria, the earlier scores, then the resuscitation part, and hourly there is management in these patients in first hour, in 3 hours, and then our patient is transferred to ICU and then taken care of. And in management, we see the fluids, where we give fluids, we give vasopressors, antimicrobials, corticosteroids. There is glucose management, venous thromboembolism, and stress ulcer prophylaxis. The reason why I have put this slide is that you saw everything in this. One thing which was missing in this was nutrition. Nutrition therapy, which is important, was actually missing. In this slide, it shows the relation between the infection and malnutrition. Infection leading to decreased nutrient intake, there is malabsorption, increased catabolic state leading to malnutrition, then malnutrition leading to impaired immune function and impaired barrier protection, and again infection, and the cycle is going on. This is nutritional recommendation in sepsis, wherein caloric needs, proteins, lipids, glucose, glutamine. Glutamine is actually being tried some, but not much is known about the usefulness of this in sepsis. And fluid, 1 ml per kg per hour, which is most important in this. The calories which we actually measure by indirect calorimetry. It's the gold standard and it's the ideal thing, but is not usually available in our ICUs. This is the metabolic monitor, and in this there is oxygen consumed, and in this process oxygen is consumed and carbon dioxide is released, which is measured in the indirect calorimetry, and the heat which is produced is then measured in direct calorimetry. But we are actually using the standard formulas for calculating the calories. The take-home message for this calories thing is that a slow but a steady increase of calorie load to reach target values when shock is resolved. The major nutrients, glucose, the optimal target blood glucose levels are not known, but we have to check for hyperglycemia and hypoglycemia because both of them are itself dangerous. Fatty acids are important for source of energy, maintain cell membrane integrity, and there are different sources, but there are different sources of intravenous nutrition that provide lipids and should be delivered daily to critical ill patients. Proteins, the aim is to enhance muscle protein synthesis to avoid or treat muscle wasting and to boost the neuromuscular revalidation process. This is why the proteins are needed. And there was a very good study, a retrospective study of 455 ventilatory patients. They were ventilated at least for a month, and they were given low, intermediate, and high levels of protein. And it was seen that the intermediate group was, the intermediate group performed better, that is, and these patients had less 6-month mortality and decreased length of stay. The result of the study was to start with 0.8 gram during sepsis and a gradual increase up to 1.3 gram when shock resolves. There are various prospective trials, randomized control trials are also being done, and the results will be available mostly by December 2022, one of them being a effort trial. And mainly in the studies are for low or high protein diet. Pharmaconutrition, addition of nutrients with specific beneficial actions. They have antioxidant effect and especially aims to strengthen gut mucosal barrier and systemic immune defense mechanisms. These are some of the pharmaconutrients like glutamine. It's a semi-essential amino acid. The role is gut barrier function, antioxidant, and cytoprotective effects. There were various trials, but they suggested no benefit. Arginine, it's supposed to improve immunity, but studies, they also say that the reports are quite varied, therefore cannot be recommended. Omega-3 fatty acids, they have a very weak evidence of use in sepsis and may improve gas exchange in ARDS. Selenium, it has antioxidant role, and there are trials like redox trial, and it said that failure of any role of enteral selenium in clinical outcome. Vitamin C, it inhibits oxidative stress, endogenous production of norepinephrine, epinephrine, and vasopressin. And at present, Insufficient evidence supports routine vitamin C in sepsis. Lastly, I would conclude that nutritional screening at different stages of sepsis is likely more appropriate. Preliminary evidence suggests avoidance of high-dose proteins. Early enteral nutrition increase severe digestive complications in shock. Early non-individualized parenteral nutrition, they have worse ICU outcomes. Therapeutic pharmaconutrition has weak evidences. Just like antibiotic stewardship, there's a nutritional stewardship with 6 Ds. Diagnosis, that is adequate assessment of patient nutritional status. Drugs, consider nutrition as drug with indication and contraindication. Dose, nutritional prescription should be given. Duration, parenteral nutrition should be tapered when shock is resolved and GIT is normally functioning. De-escalating, withholding artificial enteral nutrition and parenteral nutrition when they are no longer required, and discharge, prescription post-discharge from ICU and hospital should be given. Thank you.
Thank you, Dr. Mansa. That was very crisp, short, and practical. One question from the audience? No? Okay, I'll ask one question, Dr. Mansa. There was in one of your slides, we talked about nutrition recommendations, and that was directly with TPN. So we presume that we start with TPN only in sepsis and no enteral nutrition?
Yes.
We start with the total parenteral nutrition. Thank you. Any questions? Okay, there's one.
Am I audible?
Yeah.
Yeah, ma'am, for patients having severe sepsis and having severe anemia, what are the guidelines regarding giving iron? Iron is an acute phase reactant, so giving iron further adds to the sepsis.
As of now, in acute phase, it's not being given. And not much studies or trials actually favor it.
Okay, so we should abstain from it.
Yeah.
Actually, in after trauma or in patient in sepsis, patients usually have hemolytic anemia. It's not iron deficiency anemia, and because of hemolysis, patient can have actually more iron than he needs. So we do not supplement iron in those acute phases of sepsis or in trauma.
I'm referring to our GI surgery patients who are having GI bleeds and sepsis.
Okay,
like
then
pancreatitis
if
with
patient
GI
has hemorrhagic issues, then
Yeah.
that's another issue. But after you manage hemorrhage by resuscitation by blood and blood products,
Yeah, that's
even
there.
that
but
will
chronic
hemolyze
anemia.
after some time, and that will give actually more iron than you
Yeah.
need. So you are thinking most probably iron is needed, but it is not iron deficiency anemia as such. It is blood loss
It's
anemia,
blood loss.
and it is hemolytic anemia because of sepsis secondary to
No, I'm
thrombosis.
asking for those having chronic blood loss like CA stomach, CA colon, those who have been bleeding for a long
Okay,
time and
you
are
asking
having
about
iron
the
deficiency
patient in
anemia.
the convalescence area, or when is this a protracted case?
Yeah.
Okay, then iron can be considered depending on the profiling of the blood.
Okay.
Basically, the profile has to be seen first. Then accordingly, it has to be given.
Thank you, Dr. Mansa. Thank you.
So can I request Kajal, please felicitate Dr. Mansa?
हम लोग जाते हैं.
So over to Dr. Biplab Mishra for the panel discussion.
Good afternoon, everyone. So we'll proceed with the other part of this session, that is case presentation and panel discussion on trauma nutrition. Our panelists, there are 4 panelists. I invite Dr. Sanghamitra Chakrabarti. She is head of the Department of Nutrition and Dietetics in Medica Super Speciality Hospital, Kolkata. She is a clinical dietitian with 27 years of expertise in the healthcare sector. And she worked in different leading hospitals of Kolkata, presently with Medica Super Speciality Hospital since its inception in 2010. And she has set up the Department of Dietetics there. So welcome, Dr. Sanghamitra. Our next panelist is Miss Dipti Khatuja. I invite her. She is the head clinical nutritionist in Fortis Memorial Research Institute, Gurgaon. And she has created and planned MCT-based diet for the patient with Kyle there. Kyle leak in post-op surgeries. She has experience of more than 13 years in the area of critical care. Welcome, Dr. Dipti. Our next panelist is Dr. Bhavna Gandhi. She is a PhD, certified diabetics educator, and she is a trained bariatric dietitian. She is also a naturopath, yoga master, and pranic healer. She is director of Omnibus Healthcare. She is also a chief dietitian at Lokpriya Hospital and consultant at Meerut Cancer Hospital. So welcome, Dr. Bhavna. And our last panelist is Dr. Divya Chaudhary. She has 18 years of diversified progressive experience since healthcare industry. She is currently working as chief dietitian, Rajiv Gandhi Cancer Institute and Research Center in New Delhi. She is a PhD in nutrition. Welcome, Dr. Divya. So this for the next half an hour. So we'll take probably 2 cases and we'll have a discussion on that. I'll take the first case. This is regarding polytrauma. There is a 28-year male biker presented with history of road traffic incident in the emergency, and patient had hemorrhagic shock with crushed right lower limb. Patient was resuscitated with IV blood fluids, blood and blood products. After that, after resuscitation, patient undergone CT head and CT torso, that is contrast CT scan of the torso. And ultimately the diagnosis made in the ED was hemorrhagic shock, and he was a responder because this patient responded with IV fluids and blood products. Patient also had crushed right lower limb with perineal injuries. Patient had sacral fracture. Patient had blunt trauma abdomen with grade 3 left renal injury and grade 2 splenic injury on CT scan. Patient was taken to the operation theater and the right hip disarticulation was done because patient had crushed right lower limb, which was unsalvageable. And a sigmoid colostomy was also created in this patient because to protect, it was a kind of diversion colostomy and to protect the perineal injuries. Patient post-operatively was taken to the ICU, but patient's hemodynamicity was unstable. It was kind of fluctuating with requirements drops were there. So patient was kept nil parole for the next 5 days in the ICU itself. Till then, patient was managed with IV fluids and blood transfusion. Okay, Dr. Diba, should we carry on the questions? Would you like to take? Dr. Divya, okay. When and how would you like to assess the nutritional status of this patient?
Good afternoon. In this case, since it's clearly mentioned, the patient was initially kept NPO for at least 5 days. So generally, we try to do a nutritional screening and followed by a nutritional assessment at the earliest, so that intervention for nutrients can be made and the process of nutritional betterment can be started. But here we see that at least 5 days are already gone. So we are already delayed by a span of 5 days.
So once the patient is hemodynamically stable, then as soon as possible, we start with the nutritional assessment, chalking out a caloric and a protein goal, and then the plan of feeding can be started. In this case, I believe enteral nutrition should be a suitable mode of feeding for the patient to begin with.
Okay. So it seems this case is a polytrauma case. It's a complex case. So what challenges can you face in this particular patient, which are practical based challenges?
Basically, the goal to optimize the calorie and the protein intake is a challenge, specifically in this patient, because the requirements are on the higher side, and immediately we cannot, build up the patient to meet the 100% calorie and the protein requirement. So in itself, this is the first practical challenge which I see. Gradually, over a period of time, we can optimize the calorie and the protein intake so that whatever 5 days were lost earlier, and to manage the patient in the future also, the calorie and the protein goals are met.
Okay, thank you, Dr. Ditya. I would like to ask Dr. Bhavna the next question. Dr. Bhavna, what is the nutritional intervention in this particular case? How would you proceed with the nutritional intervention?
Good afternoon, one and all. Thank you, sir, for the question. Sir, it's mentioned they're hemodynamically unstable. So any particular blood parameter to be taken?
Patient had a hemoglobin of 11.1, platelet counts of 1.2 lakhs. And patient has TLC has 14,000 per cubic millimeter.
Okay. As being mentioned, it's always better to start up with adequate optimum nutrition and early nutrition. As we have already lost the 5 days, we cannot start with immediate and we cannot expect to fulfill all the requirements at one go. So it has to be always done seeing the tolerance as well as the food allergies of the patient. And we need to start up with the slow and gradual intake. Like in our nutritional diagnosis, nowadays we work upon PES. That is the problem. The problem is the inadequate intake because of the trauma, etiology. Those are the medical diagnosis. It has been mentioned that sigmoid colostomy, right hip amputation, and then is the sign and symptom, as you are saying, low HP, low platelet. So these are the conditions which need to be taken upon. And once we diagnose, do the PES, then we go for the nutritional management. We keep the goals. So the short-term goals are to go for the energy and protein, and then wound healing. Long-term goals is to reach the ideal body weight. So to start up, if I say for energy, we can start up from 20 kilocalories till 30-35 is the recommendation, but it will be a slow and gradual. Protein, we'll start from 0.8 going to 1.2, 1.5, 1.8. Fat will be 20 to 30%. Carbs will be 50 to 55% of the total diet. And obviously we can and we will go for immunomodulators, but not for a longer span, as it has been already mentioned. We do have a weak evidences, not the very strong evidences. So this is a MNT what we will go for, seeing the tolerance of the patient. And then we need to see if we are going for enteral nutrition and then shifting the patient from enteral to oral and then to the semi-solid, solid diet. Slowly and gradually with the time span, seeing the response of the patient, we can decide. And as you are saying, the iron hemoglobin is low. So a few nutrients what we can take care of is vitamin C, zinc for wound healing, iron and folic acid for iron, HP, and high protein diet is obviously there.
Actually, this patient, I think, had an amputation. So we also have to keep in mind the rhabdomyolysis.
You can take this.
Okay, so it has to be kept in mind whether the complications take place. He might go into rhabdomyolysis. So obviously the renal parameters, they have to be checked from time and again. A lot of blood transfusion was done. So we have to keep in mind the hyperkalemia part. Because of the colostomy, we also have to keep in mind that he cannot tolerate all food. Like she has started the patient on a soft diet, but there are certain foods which he will probably not be able to tolerate. So accordingly, some oral nutrition supplement has to be given. And these parameters have to be taken care of in addition to the fact that he's a trauma case and he requires high calorie protein and so on.
For cholesterol.
So there are many aspects.
Yeah. Hyperkalemia and all those things we have already taken care of, but colostomy, for that, obviously the fat intake has to be regulated. I missed that point. Thank you.
Okay.
Also, I think in fat, if tolerance can be an issue because of the colostomy and other factors, then MCT would be preferred over a normal fat, which can be better digested. And then as per tolerance, we can gradually wean the patient.
Okay, thank you. Thank you for educating me. Actually, we surgeons are not much expert in nutrition. I'm not asking you a question. I'm just learning from you people. So if this patient is transferred to the ward after the ICU management, and patient goes into a convalescence period when patient is recuperating. So is there any particular intervention or like to change or do intervention in this patient, nutritionally speaking?
As we
in the
have
convalescence period.
Yeah, thank you. As we have already mentioned that we'll be shifting gradually from enteral to oral and then semi-solid and solid diets, taking care of and fulfilling of all the macronutrients as well as the micronutrients. Over here, yes, as the patient is in the ward, so we do train the attendants also to take care and to note down all the dietary intake what he or she is taking, so that we can count upon the calories, what calorie, protein and intake is. We really tell the patient and counsel the attendants not to feed, because generally we see as the patient is from the rural side, the attendants become their doctors and they feed the patient with roti and all those things also, which is not being permitted. We do counsel them for the iron rich food, like generally iron is being taken with the tea and iron is not to be taken with the calcium. And then we do tell them to have the fermented. Basically the counseling part is very important, especially at the time of the discharge. And we keep on evaluating the physical strength of the patient also by finger grip. And we do the counseling for the fermented products, liquids, input, output, everything has to be taken care of. And while at the time of the discharge, we do tell them to maintain a food diary also, so that when they come back, we can have a good review of the intake. Because generally they say in the blank statement, ye khaya, wo khaya, which becomes difficult for us also to calculate. And it's, as ma'am have said, it's not a small thing. We really need to take long span. So we really need to counsel and observe the patient for the longer run. And as the amputation is there, so obviously it'll take some time, more time. So basically it's high protein, energy, fat, essential fatty acids and amino acids. We can suggest them the food products like flax seeds, lentils, and we really need to teach them regarding the nose, which is very important, especially in our Indian scenario. Chai, coffee, cold drink, fatty food, thoda sa pyar dikha deta hai attendant, so which becomes problem for us, especially in this sigmoid colostomy.
Dr. Dipti?
Yeah, I just want to add to what Dr. Bhavna has said. I would take one step back. When the patient was in the ICU, see, planning the patient's diet is half the battle won. We plan according to the surgeon or the intensivist that this is the requirement of calorie and protein, but it is equally important to daily monitor, has the actual feed gone into the patient or not. So this includes the effort of the nursing as well. We have to ask them to note down what all feeds were given to the patient, because sometimes the patient has to be kept nil per oral because of some investigation, or by chance there is a risk of aspiration, and the intensivist would say that just withhold one feed. So even withholding one feed, the patient will be losing onto the required calories and protein. So if that can be, for compensation, if extra feed, like generally in hospitals, we follow a pattern of 9 to 10 feeds in a day over a gap of 2 hours. So if we are seeing with the help of nursing that 2 feeds were missed, and if that was documented, so we can actually, ask the nurse who is taking care of the patient in the night hours that those 2 missed feeds can be additionally given. because the requirements are actually on the higher side for a trauma patient.
Okay.
So documentation post-discharge is also important, but I believe that in ICU also, documentation helps us to actually gauge that what were the requirements which are actually met or not.
Can I add something, please?
Yeah, sure.
Trauma, the first thing is the electrolytes, because hypo and hypernatremia is very common. So fluid management, depending on dehydration and hydration, so the intake output has to be monitored. Based on that, you have to see the sodium levels and then hydration and rehydration. So hypo and hypernatremia in ICU for an RTA is very, very common. Thank you.
Yeah, thank you for the input. Actually, this hyponatremia and fluid challenges are actually taken care of by the critical specialists. So we are here actually to focus on the nutritional aspect of the patient, how to address those nutritional area. So thank you for pointing that out. So we'll proceed with the next case, and it is a case of traumatic brain injury. There is a 35-year-old male presented with history of road traffic incident and brought to the emergency department. CT had revealed a large right-sided subdural hemorrhage. Patient was taken to the operation theater for emergency decompressive craniotomy. Post-operatively, the patient was shifted to neuro ICU. Patient was intubated due to low Glasgow Coma scale, but was hemodynamically stable. These are the anthropometric measurement. Weight couldn't be assessed in this patient, but height was mentioned as 175 centimeter. Patient looked well nourished. History given by the family suggested no pre-existing disease. There is no history of food allergy, and adequate dietary intake was there, and there was no loss of appetite. So I'd like to have the inputs of Dr. Sangamitra. How would you assess the nutritional status of this patient, and when you are going to intervene in this case?
Okay, so this is a very typical case, or a typical accident case, where you find a rather well-nourished individual coming with a road traffic accident. The usual tendency is to overlook the nutrition because the patient is absolutely well-nourished. Even the doctors, sometimes they have told me, I've had this experience in the past, hatta khatta aadmi hai, why are you so hyper about the nutrition? We can wait. So, since there is no history of weight loss and he's been eating properly, so we assume that the person is doing well nutritionally. But the idea is that in any traumatic brain injury, we start early enteral nutrition. We don't wait for the catabolism to take place. And ideally, if the person is even having a good muscle mass, instead of allowing him to use his own body reserves, it's better to give the proteins from outside. So the idea is, the moment you see the patient in the ICU, obviously we do not get to see the weight and all in a person who's had a head injury. So we can calculate the ideal body weight. We can do an NRS. Later on, we can do an SGA. So the score is not going to be high because he's well nourished, but we have to initiate early enteral feeds. Initially, we cannot give a large volume because these people, they are given sedatives, propofol and all, for which the gut is not always very functional. So we have to start slow. We have to start in small volumes, keeping in mind the protein requirement. So typically what we do in our ICU is we start with, say, 50 ml per hour, and we take a formula feed. We do not use kitchen feeds. We use a formula feed which has got a high protein and calorie density. So it's more on protein and a little less on calorie to start with. So that is how the screening is done.
What about the calories? How do you calculate the calories? From
calories
what part? Carbohydrate versus fat, lipid?
Calories, initially, we do not concentrate so much on the carbohydrate. It's more on the protein. So we can start with some, say, 20, 25 kilocalories per kg ideal body weight, but the protein should be high, say 1.5. And then once the person stabilizes a bit, we go into full fluid diet. We are allowed more liberal fluids. Then we go for the target, say 35 kilocalorie per kg ideal body weight, and the protein can generally, we usually increase it to 1.8 if required, up to 2, usually 1.5 to 1.8.
Okay, thank you, Dr. Sangamitra. I'd like to take this case a little further. After 3 days in the ICU, that is post-op-day 3, biochemical parameters of the patient revealed an increase in sodium level, which was 160. There was increase in intracranial pressure and sensorium was decreasing. So the neurosurgeon took the patient to the OT for re-exploration of the craniotomy. After that, patient was shifted to ICU again in the late evening and was hemodynamically stable otherwise. Patient sensorium and biochemical parameters improved overnight. Nutritionist opinion was sought for initiation of enteral feeding in this case. And physiotherapy was also initiated in this case. So I'd like to ask Dr. Dipti, after re-exploration of such cases in traumatic injuries, traumatic brain injury, how would you like to plan the nutritional management?
Thank you so much for this question. As we could see that the intracranial pressures were increasing and the patient went into the hypernatremia, because this can be again because of increased pressure, and because of which lot of diuretics and loss of water loss happens from the body, because of which the sodium increases. So start with post re-exploration, we can go with the low gradual increase in the feed. We can start with the continuous feeding in the ICU, which is recommended as per the guidelines also. Total commercial based, and also we can go for low sodium formulas for wherein you have actually a low concentration of the sodium, and then just for a day or so, just looking at the tolerance. If the patient is doing fine, then next day onwards you can, from 60% to start with, you can gradually increase to 80%, and then on third or fourth day probably you can try to achieve the targets. Once you see that the sodium levels have improved and being into the normal range, gradually we can wean the patient from low sodium specialized formulas to a normal polymeric formulas for those patients.
Okay, thank you very much. I've seen in my experience that many of such patients are discharged, but when they are discharged, that post-trauma head, they are unable to accept the oral feed. They are unable to, so something has to be given, but patients are being discharged. So in such cases, how would you, how the patient's relatives are supposed to manage such cases? Nutritional aspect.
So as Sanghmitra has said that the need of calories, proteins are high, and definitely these are the patients who cannot be started with the oral feeding so early. But as per guidelines, nasogastric is not to be recommended for longer durations of more than 6 to 8 weeks. So in such cases where there is a long-term tube feeding is required, PEG, that is percutaneous endoscopic gastrostomy, is a good way, and wherein there's a benefit that once we get the patient discharged on the PEG, we can, once the patient is out from the ICU to the wards, we can gradually move to the bolus feeding from continuous feeding, where patient, as per the requirements, have some duration of time between the two feeding, and wherein we can give a combination of commercial as well as the kitchen-based feed. But yes, keeping the micronutrient deficiencies into consideration, we should go for 60% commercialized feeding and 40% kitchen-based homemade formulas with proper counseling to the family can be taken care of. The most common challenge that we feel in all the enteral feeding is the diarrhea part. Now, looking into the different hospitals of the ICU settings or the ward scenarios, most common that as a nutritionist we hear, this is one challenge which I would want to, take up in this forum, because diarrhea is one thing which, doctors says that patient has started on the diarrhea, please feeds ban kar do, decrease the feeds. So it is not always the feeding which is causing. So we need to understand what is the cause of that diarrhea. And rather than changing the supplementation, soluble fibers have played a very important role in controlling the diarrhea. And once that is not controlled, even after that, then we can probably switch from polymeric to semi-elemental. But I would always want to advise, don't switch immediately or don't stop the feeding for such patients. Even if the patient is in ICU, these will really, give a long gap for the patient's nutritional requirements to be met unnecessary.
Thank you.
Actually, the protocol which is followed in our ICU, what we do, we start early enteral nutrition, preferably with some immune modulators. Immunonutrition is given. We start with, say, 50 ml, and we gradually increase and we bring up the calories and the protein. And we also have to take into account the micronutrients, which are very often overlooked, vitamin C, zinc, and so on. And once the person's sensorium improves, we don't take out the rice tube immediately. We can try some pureed diet because the person, sometimes they have dysphagia. So usually it is tested. We have a speech and the speech therapist who comes and they test the patient for the feeds test is done, the swallowing ability is assessed. We don't take out the rice tube. We slowly try feeding the patient partially on pureed diet, maintaining the rice tube so the calorie is met. And in case of sensorium doesn't improve, in that case, the patient has to be discharged either via a PEG, or if they want to leave earlier, then we have to keep the rice tube because we can't take the risk of removing it and, trying orally at home.
Okay, thank you very
As
much.
Dr. Dash has already taken up, she has already taken up that nocturnal feeding or the catch-up feeding is a good way when we are trying the daytime, the pureed or the semi-solid after consulting with the speech specialist, and followed by, going with to meet up that requirements, the gap of the requirements, nocturnal feeding and the catch-up feedings are a good way to go ahead with those.
Thank you. I would like to thank all the panelists and like to conclude the session here. If there is any question from the house, please let me know.
Good afternoon, everyone. It's not a question, just an addition. For the very first case where you
can
asked,
introduce yourself first.
Yeah, I am Research as well. I look after the AIMS Trauma Center ICUs also. Yeah. So I just want to add one thing. In the first case, like you have asked, what special challenge or nutritionists face first once they visit the ICU patient who are already NPO for 5 days. So the first challenge, because nutritional assessment depends on the anthropometry measurement, biochemical parameters, and the other clinical history. Considering the clinical history and the biochemical parameters, we can get it easily from the file. But anthropometry measurements are really a challenging part. To overcome those challenges, although that is not a gold standard, to overcome the challenges, there are certain nomograms which we can use to assess the ideal height and weight of the patient, and based on that we can decide how much calorie and fluid should be given to the patient. In the initial days, since the patient was already on the inotropes, so as a nutritionist, the first thing would be how much volume can be given through the RT or through oral route to the patient. This patient had a sigmoid colostomy, so definitely the rest of the GI tract is absolutely normal. So enteral along with the oral can be initiated after discussion with the medical team. If they all are on the same page, and it can be initiated with a small volume or a small amount, it should be initiated. It won't make major difference unless or until the patient is on a higher dose of inotropes and a multiple inotropes. So that was the addition I wanted to make here. Thank you.
Thank you, Richa. And we conclude the session here. Thank you very much.
Can I request the chairpersons, Dr. Kajal and Ritika, to... Okay. Meanwhile, I will request Dr. Biplab to felicitate our panelists. Dr. Bhavna Gandhi. Ms. Deepti. Ms. Sangamitra. And Dr. Divya. Sir, please. We have one more session. Meanwhile, a small announcement. The candidates for quality awards can be seated a little forward, please. because post this event session will be having quality awards. Please be seated forward in the front seats. Thank you. Over to Dr. Pipla, please.
Yes, yes. So we'll carry on the session, and this is the last lecture of the conference, I suppose. And I invite Dr. Narendra Chaudhary, who is the next and last speaker. Dr. Narendra Chaudhary is Associate Professor of Surgery in AIMS Trauma Surgery and Critical Care Division. And he'll be speaking on the topic overview of nutritional management in trauma patients. Welcome, Dr. Narendra Chaudhary.
Thank you, sir, for a generous introduction. So when I got the invitation for this lecture, it will be happening to be the last one on the last day. So from the initiation, it will be the challenging one. And moreover, when our own dietitian from the trauma center are presenting here to scrutinize the things, so it will be more challenging. Anyways, trust me, I will not let you disappoint during this lecture. So overview of nutritional management in trauma patient. So trauma patients, why these trauma patients are more important? What happens to these patients? This is the patient population who requires repeated multiple operations. Usually, unlike in the surgical procedures where the patient underwent a particular operation and then his catabolic phase started and ultimately the anabolic phase. But here, once the patient underwent one operations in 2 or 3 days, or sometimes within 12 hours, he requires another operation. So actually his catabolic phase keeps on going on, it lingers on. So anabolic phase will take a lot of time because multiple procedures are going on. At the same time, whenever we keep the patients for repeated operative procedures, we keep them NPO also. So we cannot continue the feed. So here the protein energy deficiency will be there. So the good thing with these patients are that these patients are usually young patients. They are usually healthy patients and usually within their normal body weight with normal BMI. So usually comorbidities are less in these patients because trauma is affected mostly the young patient populations. Those are the patients who are actually outside the home. They are usually the working and they are usually get affected by the trauma. So for the next couple of minutes, I will take you through the intricacies of nutrients and nutritional therapy. I will also discuss the calculations of protein energy requirement in a normal healthy person. And then I will take you through the process of conversion of energy requirement into nutrient requirement, because the energy we will calculate in the kilocalories, but what we are giving to the patient is in the liquid form and is in the form of macronutrients. So how much ml, how much grams we should give, that we have to convert it. Then finally, I will discuss something about the trauma effect on the body homeostasis and the different strategies in trauma patients for the feeding. So I starts with the Hippocrates quote that our food should be the medicine and our medicine should be our food. Whatever we eat leads to certain types of diseases, and certain type of diseases again affects our nutrition. So they are interconnected, they are vice versa. So defining this topic, there is a standard therapy. Standard therapy is something that we usually give during the initial 24 hours or 48 hours in the form of intravenous fluids or advancement of oral diet as tolerated. Whereas the nutritional therapy is something that refers specifically to the provision of either enteral nutrition or enteral access device or parenteral nutrition by central or peripheral access. So nutritional therapy is something different from the standard therapy. Here we supplement the patient's calories with macronutrients. So in the coming slides, there will be a different term. So I am just touching these terms like TEE. This is the patient's total daily energy requirement. TEE is the addition product of resting energy, activity induced energy expenditure, and the diet induced energy expenditure. So diet induced, whenever we eat something, there will be the metabolic reactions and some of the energy will be consumed in that particular thing. So that is needed as diet induced energy expenditure. So TEE is the addition product of all these three types of expenditures. BMR is something that is the ideal thing that we calculate in an ideal environment, in a thermoneutral environment when patient is lying, and usually after 10 to 14 hours of the last meal, when we can actually remove out the diet induced metabolism there. So whatever patient is there, this BMR in our clinical setting is not possible. BMR is something that can be calculated in the laboratory setting or in ideal setting. So BEE is more practical form of BMR, which calculates the 24-hour kilocalorie requirement, and BEE plus thermoregulations plus energy expended
in depositing the new tissue is the REE. So in the clinical settings, in our trauma patients, we usually use the resting energy expenditure. And as per the activity level, we will add activity induced energy expenditure and diet induced energy expenditure to calculate the TEE. So the practical things are REE, AE, and DEE. So many factors are there that determines the energy requirement: the age, gender, body habitus, that includes height as well as weight, and the activity level. So whenever we calculate the things, these factors are there directly or indirectly that influence the total energy expenditure. So there are different methods of calculating the energy requirement in 24 hours. Some direct measurements are there. Again, they are laboratory measurements and used in experimental studies, not in regular clinical practice. These are like whole body calorimetry, indirect calorimetry, or double labeled water techniques. Few of the more practical, useful things that can be used in clinical scenario are the measurements through the predictive equations. They are like ideal body weight TE equation, which is most practical, easy, quick, and can be done in on bedside. So this is the most applicable thing that we usually use in our trauma center to calculate 24 hours calorie requirement. This is TE equals to ideal body weight in kg into 30 kilocalorie per kg. This is total, mind it, this is a total energy expenditure. Harris-Benedict equation, it's almost 100-year-old equation, which is given by Harris-Benedict. It is not much used nowadays in trauma patients because it will over-calculate the calories, because it has the fitment factor of activity level or the trauma level. So according, if we use that, then it will be over-calculate. I will take in the next slides how it will over-calculate. Then recently, one more practical equation is Institute of Medicine IOM TEE equation, on which basis the US FDA right now are calculating RDAs. So this is something Harris-Benedict equation. This is different for gender as well as also depends on weight, height, and age along with the fitment factor. This is IOM TEE, which is again calculated on the basis of male and female gender as well as the activity level, weight, and age. Then conversion of energy requirement into macromolecule nutrients. As I told you, we calculate in the kilocalories, but we give in the forms of milliliters or milligrams. So 24-hour carbohydrate requirement is equals to the 24 hours kilocalorie need into 0.6 divided by 4 kilocalorie. This 0.6 is something that constitute almost, the carbohydrate should constitute about 50 to 70% or around 60% of the total feed. So on this basis, it's a 0.6 or a 24-hour protein requirement. This is whatever I am taking is talking about the healthy persons. I will take about the unhealthy person in the next slide. It will be around 24 kilocalories, 0.1 divided by 4 kilocalories. And the fat is like 24 hours energy need multiplied by 0.3 and divided by 9. So effects of trauma on body homeostasis, there are two terms: adaptation, accommodation. Adaptation is something that is not detrimental to the health, and it is a short-term mechanism that will protect the body from the harmful induced things. Like one of the example is decrease in resting energy expenditure during starvation. So when we don't eat something, our resting energy expenditure decrease, but it will not take toll on any deleterious toll on the body. So homeostasis, adaptation is something that without any taking toll, it's a new state of body that achieved without loss of any function. But accommodation is something that has the loss of function. It's a short-term adjustment and it's detrimental to the health. This like hypermetabolic response induced by the major trauma. So whenever the patient received a trauma, the patient has to pass through two different phases. That is ebb phase. It's the initial phase lasting from 4 hours to 24 hours, depending on the severity of the trauma, and then followed by the flow phase. Flow phase has two subphases. First is catabolic flow phase, and then finally patient land up in the anabolic flow phase before he achieves his normal body level before he received the trauma. So he has to pass through these two phases, in which the second phase has two different phases. So stress response, in the first ebb phase or stress phase, the hypovolumic shock, hypotension, and tissue hypoxemia will be there. The patient tries to conserve the body conserves the energy, at the level, at the cost of certain non-essential activities to preserve the more essential activities of the life. So nutritional goal here is to metabolic support for low REE. This is usually the resuscitative phase where we usually refrain from giving any of the enteral nutrition or parenteral nutrition during this 24 hours. This is a resuscitative phase or shock phase where we have to actively resuscitate the patient before starting the nutrition. Once the patient land up in catabolic phase or the flow catabolic phase, here the hypermetabolism started, and this is the phase where we actually start giving the nutritional support in the form of enteral and parenteral depending on the patient's condition. And finally, patients land up in the anabolic phase. This anabolic phase usually arises after 3 to 4 weeks of the injury depending on the severity of the injury and again the number of procedures we are actually carrying out. If we carry out more and more procedures, then this phase will be increased more and more. This is something that happens to our body. Then why nutritional support is important? It is essential to meet the patient's increased nutritional requirement, thus preserving lean body mass, to facilitate the recovery and healing, and to restore the body's capacity for optimal immune function. So who needs the nutritional support? All trauma patients use the nutritional support, and especially the patients who has injury severity score more than 16%. So this hypermetabolic stage is something that is all or none phenomena. If the patients has a injury level of ISS 16 or more, they all have the same response of hypermetabolic syndrome, and all these patients are benefited with the early enhancement of the nutrition. Then when to supplement the nutritional support? The end point of traumatic shock resuscitation should be achieved and the patient should be stabilized. So that should be started as early as possible, but within 48 hours of the patient trauma. So this leads to decreased infection rate, decreased hospital length of stay, decreased cost, and it improves the outcome. So for during initial resuscitation phase, 24 hours you can avoid, but after that you have to start as early as possible. Then feeding route, enteral tube route is preferred because it has the fewer complications and all complications that are associated with the PN. Then feeding routes can be of different type, and benefits I am not touching up because already I think has been discussed. Then feeding routes which enteral or parenteral. The enteral route is always preferred because it is not associated with all the complications they are associated with the parenteral route depending on the central line as well as the bloodstream infections. And whenever you start with the gastric tube feed and then see if the patient is tolerating that feed, it's all right, you can increase the feed. If patient is not tolerating the gastric tube feed, then you can think of the post pyloric feeds also, but putting the gastric tube is easier, it will be earlier, and you can actually start the tube feeding as early as possible rather than waiting for the gastroenterologist or the radiologist to place the post pyloric feed. Then indications of exclusive PN. So exclusive PN is something that we only gives the parenteral nutrition. It is only given when the enteral feed contraindicated, failure of the enteral feed, or anticipated delay in enteral feed for 3 days or more. Then complementary PN, it is slightly controversial issue. Here the complementary PN is the PN plus EN. So it is recommended that if enteral feed will be inadequate for first 10 days and it will not achieve at least 60% of the daily requirement, then you can start the parenteral nut or you can complement with the parenteral nutrition. How much energy is required? Energy during acute catabolic phase, we should keep it to 20 to 25 kilocalorie, because what happens, the patient is lying down, so his physical activity is nil, his other requirement is increasing, but that is nullified by the physical activities. So actually he is requiring only 20 to 25 kilocalories. If you give over nutrition, it has a detrimental effect as well as akin to the undernutrition. So if goal values cannot be achieved, trophic feed, enteral feed at a lower rates had huge benefit over starvation and have outcome that are as good as EN at goal. So how much energy is required? So ESPN guideline 1.3 to 1.5 kg per kg of ideal body weight per day is the protein. Carbohydrate 50 to 70% of non-protein calories, and fat 20 to 30% of non-protein calories. What should be used for what should be used for as a nutritional support? For enteral nutrition, I am taking 2 minutes extra. So for enteral nutrition support, it's either a standard formula or polymeric diet, elemental diet, or a specialized formula depending on the disease or immunomodulations in the form of glutamine, L-arginine, or omega-3 fatty acids. Although they don't have any survival advantage on the meta-analysis, reports doesn't show any survival advantage, but it has been shown that the glutamine reduces the inflammatory phase duration, so without affecting the survival benefit, but cost will be increased. For PN, it's a 3:1 regime or 2:1 regime. How to deliver the nutritional support? Ian, there are temporary access in the form of pre-pyloric like Ryle's tube, or in the post-pyloric phase like nasojejunal tubes in the form of Fracas tube or endoscopically guided nasojejunal tubes. In the permanent access, pre-pyloric like PEG or laparoscopic guided gastrostomies, or post-pyloric like feeding jejunostomies. Then PN, central venous access, is the only choice that we have. How to deliver? Ian, we have the top-down approach as well as ramp-up approach. Top-down approach, we calculate whole of the energy, whatever required in the 24 hours. We feed since the first day, and as per the acceptance of the patients, we can keep on continue or we can decrease. Ramp-up, we will start with 15 to 20 ml per hour of the feed, and then we will ramp up. In parenteral nutrition, there should be the permissive underfeeding, and we should give only 80% of the daily non-protein energy requirement to the patients, because these patients are in the catabolic phase. They are hyperglycemic, and they have the detrimental effect if you give whole of the feed at the initiation. Then take home message, nutrition is very important aspect of the patient management. Ideal body weight is a simple and quick mean to calculate. IOMTE is the most promising predictive equation for energy calculations. EN must be started at the earliest, if not specifically contraindicated. Avoid unnecessary withholding of the EN. Even trophic amount of EN is beneficial for critically ill trauma patients. So whenever you are not able to give the full feed, at least give trophic amount in the form of 10 to 15 ml per hour. Then PN should be initiated whenever anticipated delay in the enteral feed for 3 days or more, and different enteral and parenteral formulas are available to make the tailor-made approach to the patients. Thank you. Here I am concluding my sessions. Thank you.
Thank you, Dr. Narendra Chaudhary. That was actually very energetic and nutritious presentation from your side. Now, we would like to take question from the house for Dr. Narendra Chaudhary. Any questions?
I thought a lot of questions will arise.
It's okay. Okay, so we conclude the session here and the conference here. Thank you, Dr. Narendra Chaudhary. Dr. Kajal will felicitate Dr. Narendra Chaudhary by giving the comment.
I would also request Dr. Shilpa Verma to felicitate our chairpersons.
At the last of the talk, I also want to acknowledge our dietitians, Ms. Richa and Shelly, who are continuously with us while giving all the nutrition to these patients. Thank you.
Dr. Kajal. And Ms. Ritika. Thank you, Dr. Shilpa. So we are starting with our quality awards, and I hand over mic to Ms. Lekha. Dr. Shilpa. Okay. So Ms. Datta will be taking over for the quality awards session.
Good afternoon, everyone. Respected NAC and all the audience and colleagues and faculties. I think you all must be awaiting for this moment from, I think 2 years when we have started the quality awards, and we are awaiting for the physical function, and felicitate all of you. So can you please stop the slides so it's changing automatically? It's on auto mode. It's changing on its own. I don't want you to change, like
Let me have a control. Go to the first slide.
Okay, so by the time the technical things are set up, you all know what awards about. It was a vision of our Vice President Shiv Shankar sir, and who has made it possible. So I would like to invite our Chairman for Quality Awards, Shiv Shankar sir, to have an official formal address before we start.
Normally, I'm known to take more time than allotted. So this time also, I won't disappoint you. The awards, the most controversial things. No one will ever agree to take a part of that in organizing the thing. But I'm really happy that the way it has went on. And when we talk about the awards, I can hear some sounds. These are the heartbeats, even mine. So I can see almost the maximum presence of this conference at this time. So I know you all are excited, and I'm just filling the gap. I'm just not pulling out the time. The moment they say, "Ki, sir, it's ready," I'm going to stop my talk over here. The one thing is, I always had this kind of an feeling that dietitians are never recognized. Their efforts were never, it goes like, even whatever the effort you put, there is neither your HOD, neither your colleagues, nor the nursing staff, nor the administration, the medical superintendent, you call anyone, they won't recognize your efforts. So this is one thing, always I wanted to say that someone needs to recognize their efforts. And when we put so much of energy, time, and you all know you're not only the dietitians, you multiply yourself like a physical counselor, the family counselor, you become their friend, you become their parents, you become their sisters. So many roles you play once you get used to talking to a patient continuously over time. So this multifaceted, role, even though that is what we call it, beyond your designated role, still you extend yourself in a different form. Again, when you are employed and paid for the role, that is itself is not recognized. Whatever the extra role you are doing, no one is going to recognize even that also. Please let me know when we are ready. Yeah. Okay. The one thing what went wrong with these awards is like, I'm very much disappointed because I couldn't participate. And when I knew I will not be allowed to participate, or I am not going to participate, I made sure NEC will not participate. That would have been really wrong. If yes, of course, after seeing the awards, I feel that I'll be resigning now today evening, so that next year I'll be participating in that. And I request NEC to hand over or take over someone from me, and let me also be proud enough to receive some award over here, because on behalf of my department, I know how much effort they put, and they cannot be here to take the award. So that's only a drawback what I can talk about. So that's it. Thank you for participating and making it a great success. And if at all any improvements can be done, I'm really very much open to accept your advices and suggestions, and have a great movement over here. Thank you.
So again, welcoming you all for Quality Awards 2021. Vision and mission is shared by Shiva sir to recognize and present award to members who have contributed to the field by showcasing exceptional expertise in clinical practice, education, and advocacy. The accomplishment of those selected for an award improve the quality and efficacy of the profession, and their actions provide a positive example for healthcare professionals. The IAPN awards are a mean to honor excellence in nutrition science in various areas to practice. And by this, we have various categories. So the categories are excellence in nutrition practice, medical nutrition therapy, outpatient management, therapeutic food service management, public nutrition category, entrepreneurship, dietetic informatics and digitization, clinical nutrition innovations, outstanding accomplishments, and nutrition research. So we have a active participation in all these categories, and I would like to congratulate all the participants who have not won for showcasing a very good work and the efforts taken by all of them. Now we will start with before we start the awards, I would like to thank all of the judges who has taken out the time from the busy schedule and given the marks and to the students. So we have international judges and we have national judges across the India. I would like to name a few: Dr. Tono, President of Indonesia Pen Society, Ms. Fiji Anthony from Dubai, Dr. Muhijabin from Bangladesh, Dr. Miniset, Dr. Vanita Reddy, Dr. Subhadra Mandalika, Dr. Rebecca, Dr. Santi, Ms. Shaini, Dr. Noshin from Kashmir, Dr. Vandana Mishra. So we had more than 12 judges to judge all these categories. Now, much delay. First, we will start with the winners of national category, and I would like to invite our respective presidents, sir, PC Vijay Kumar, sir, to felicitate the national winners. I will request all of you to come fast so that you can have enough time to take the photos and felicitation. So the first winner in the national category of main award in excellence in nutrition practice, Harita Shyam, Apollo Hospitals, Hyderabad. Congratulations, Harita Shyam. Please come on the stage.
The screen gets blocked, no? If you can come this side, the screen will also come in the background. Yeah, I think this is the right position. Yeah. Your name will be seen.
Next category for excellence in medical nutrition therapy, our very own Dr. Eileen Kende, Saracen Reliance Hospital, Mumbai. Next, excellence in outpatient management, Cuddles Foundation, Mumbai, Maharashtra. Any representative from Cuddles Foundation? I think they are not here. Next is excellence in therapeutic and food service management, Ms. Suzanne Itti from Aster Medicity, Kochi. Next is excellence in public nutrition, Dr. V. Bhavani from ESIC Medical College and Hospital, Chennai. Chennai, make some noise. Moving to the next, excellence in entrepreneurship, Jyoti Deshmukh from Jyoti's Nutrialign Nutrition Center, Navi Mumbai. Next, excellence in dietetics, informatics, and digitization. Manju P. George, Lakeshore Hospital Research Center, Cochin. Excellence in clinical nutrition innovations. Michelle Brito, Nirmala Niketan College, Home Science, Mumbai. Next category is excellence in nutrition research. Dr. Archana Prabhat, Alwas College, Mudbidri. Excellence in outstanding accomplishments. Aparna Nagendra from Sagar Chandrama Hospitals, Bengaluru. Thank you so much, President Sir. Now, after national, we are moving to the state winners. I will request our Vice President Shiv Shankar Sir, Pen Communication Shilpa Ma'am, and Dr. Dash. Please come and honor the felicitation process. So main awards for excellence in nutrition practice, state levels, Dr. Sheetal Chaya, Dheeraj Hospital, Wagodia. Anyone?
We can collect that a little bit later, isn't it? We can just announce.
Dr. Sheetal Sai. Shifali Mehra, MGM Hospital, Vashi, Navi Mumbai. Gunjan Singh, Subham Hospital, Shifali. Gunjan Singh. Gunjan Singh. Mahendri NV, CMC Vellore Hospital. You have to go. Mahendri NV. Okay. Shashikala. Shashikala from Avitis Institute Medical Science, Palakkad. Moving to the next category for state awards, Excellence in Medical Nutrition Therapy. Anshu Chaturvedi from EICC Hospital, Jaipur. Gargi Rai, National Cancer Institute. Rajeshwari, Apollo Cancer Center, Chennai. Congratulations. Shruti Bharadwaj, Narayan Hospital, Ahmedabad. Okay, she's not there. Babita Hazarika, Apollo Multispecialty Hospitals, Kolkata. She's not there. So moving to the next. Excellence in Outpatient Management, Safala Madik, KM Hospitals, Mumbai. We have a representative of Safala. Yes. Excellence in Therapeutic and Food Service Management, State Level, Dr. Meenakshi Bajaj, Tamil Nadu Government General Hospital, Chennai. Ma'am is not here. We'll move to next. Excellence in Public Nutrition, Sunita Sahu, Apollo Hospital, Bhubaneswar. Excellence in Entrepreneurship, Dr. Nidhi Agarwal, Pune. She's not here. Our very own Excellence in Dietetics, Informatics and Digitization, Ms. Ritika Samadar, Max Super Specialty Hospital, New Delhi. Delhi and NEC, make some noise. Excellence in Clinical Nutrition Innovations, Marina Elizabeth Alex, Madras Medical Mission, Chennai. Ma'am is not here. Move to next. Lekha ma'am, come. She is there after next. She'll take two. Excellence in Nutrition Research, Lekha Sridharan, Apollo Pediatrics Hospital, Chennai. Excellence in Outstanding Accomplishments, Dr. Lukshita Sharma, Amity University, Haryana. So after state, we'll start with the district category winners. Thank you so much, Shiva sir, Dr. Dash, PC sir, Shilpa ma'am. Now I'll request our NEC members to come up for honoring the district winners. Excellence in Nutrition Practice, Zamrud Patel, Global Hospital, Mumbai. Lahar Minakshi, Unique Hospital, Surat. Okay, next is Excellence in Medical Nutrition Therapy. As you read the names, please come fast quickly on the stage. Dr. Divya Chaudhary, RGCIRC Hospital, Delhi. Dr. Sarika Sattav, Noble Hospital, Pune. S. Ramya, Apollo Hospitals, Chennai. You all can come by this and you can walk down from that stairs. S. Ramya, Miss Vijayalakshmi, PSG Hospital, Coimbatore. Nishita Kundu, Medanta Hospital, Gurgaon. Princey Thomas, Rajagiri Hospital, Ernakulam. Suganya and Jayanti, Apollo Hospitals, Madurai. Go. Suganya and Jayanti. Excellence in Outpatient Management, Nikita Patil, Noble Hospital, Pune. Kanak Gupta, Matruchaya Hospital, Kanpur. Jigna Patel and Dr. Monica Gupta, Shri Krishna Hospital, Karamsad, Gujarat. Nikita Patil. Jigna is coming. Bhakti is here.
Announce karo.
Excellence in Therapeutic and Food Service Management, Ms. Bhakti Saman, Kokilaben Dhirubhai Ambani Hospital, Mumbai.
Excellence in Public Health Nutrition, Ms. Sheetal Joshi, Divakar Specialty Hospital, Bangalore. Dr. Ankita Sharma, Krishi Vigyan Kendra Agricultural University, Jodhpur. Listen, give one to Datta to give. Give one to Datta to give. Yes, Datta. Dr. Ankita Sharma, please. Excellence in Entrepreneurship, Shraddha Joshi, Shashiganga, Dehradun.
Shraddha Joshi? Not here. Excellence in Dietetics, Informatics and Digitization, Varsha Gore, Apollo Hospitals, Navi Mumbai. Apollo dietitians, make some noise. Excellence in Clinical Nutrition Innovations, Bijoya Mukherjee, RB Diet Clinic, Kolkata. Can we have Bijoya Mukherjee? Yeah. Excellence in Nutrition Research, Dr. Shipra Saklani, PGIMR, Chandigarh. Dr. Shipra? Yeah, please go. Congratulations. Excellence in Outstanding Accomplishments, Upashna Sharma, Max Healthcare, Gurgaon. Thank you, everyone. Herewith we have completed with the awards. Felicitations. Thank you so much, everyone, for being here. May I request Dr. Shilpa to do?
I would request all the Delhi chapter members, organizing team of ICNC, Dr. Dash, to please be on stage. And I would request all the participants here to please give them a standing ovation. So on behalf of the NEC, it is my pleasure to thank and welcome on stage the organizing team of
all state winners. Please do not leave. We are going to give you your trophies. So collect it and then go.
The entire Delhi team, welcome you on stage. Yes, and post this, all the award winners kindly come up on stage for a group photograph. Dr. Dash, Shilpa Chadha, Thakur, you all have been, Kajal Yepto, and our very own NEC, Ritika Samadar, you've done fabulous job. Thank you so much. We welcome all of you on stage. Welcoming all the award winners on the stage, please.
All the award winners for the group
Silver,
No, 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 no. सबका हो बैठ जाए. All. With your awards, please come. Let us have a celebratory moment. Please come.
We'll have the photograph. Please be seated. We'll have the photograph a little later. I'm very sorry for the inconvenience. Please be seated for a small while. Just a small request. Be seated. You'll get off it. Yeah.
Announce करते.
The award.
Good evening, everyone. We are at the end of the two-day conference. So I, the organizing secretary, IAP in India, Delhi chapter, thank each one present physically as well as virtually. Let me start with thanking our chief guest, Honorable Director AIMS, Professor Dr. Guleria, for inaugurating the session and also giving us the permission to hold this particular conference on this premises of the Premier Institute AIMS. Professor Saraya, our patron for the conference, for being available and present for any time and any advice we needed. My heartfelt thanks to the National President, Dr. P.C. Vijaya Kumar, Vice President, Dr. Biju, and Mr. Shiva, the Secretary, Ms. Lekha, Treasurer, Ms. Datta, and all the Executive Committee members of the National Committee for their valuable inputs at each stage and being present physically for their support. Special thanks to the Delhi EC committee members for their prompt help and support. We are sorry as the agenda and the logistics were getting finalized till the end. So we actually could not ask for more of help, but thanks for helping us at the last moment. Thank you once again very much. Sir, Professor NR Dash, President Delhi chapter, and Ms. Shilpa Thakur, Vice President Delhi chapter. Personally, I have no words to mention that how thankful I am, but I still thank them for, without them, this conference would not have been possible as well as a success. So thank you very much, sir, as well as Shilpa. Okay. I also want to thank all the faculties and delegates. Again, without their contribution and participation, this conference would not be a success. As we all know, that no conference is complete without people working and helping behind the curtains at all times and at all odd hours. I thank RX Events, who's our event partner, and his team. Mr. Manjit, our audiovisual help, and his team. Mr. Manjit, who has helped us with all the indoor and outdoor arrangements, and his team. Our caterer, I know food is always there. Without it, it's impossible. Mr. Gupta and his team. The auditorium management, Mr. Veer, and other staff members of AIMS who has helped us in old ways. And a special thanks to Mr. Sandeep Massey also. He also pitched in at the last moment. I would like to felicitate the industry. Yeah, I would like to felicitate and thank the industry partners again, without whom it could not have been possible. So I would like to read out the names of the industry partners and would invite a representative from them to take a small memento from our side. Thank you. Otsuka, Fresenius, Azura, Pfizer, Sun Pharma, Torrent, Mankind, BioLife Science, NutriCulture, and Borges. Please, if the representatives can come on the stage to take to receive a small memento from Dr. Dash, please. Vinay. Otsuka. Otsuka, please. Fresenius. Anybody from Fresenius, please? Next is Azura. Fresenius. Okay. Azura. Either way, it's okay. Yeah, sorry. Pfizer. Anybody from Pfizer, please? Sun Pharma. Sun Pharma. Okay, I go to the next one. Torrent. Anybody from Torrent? Okay. Mankind. Anybody from Mankind? Mankind. BioLife Sciences. NutriCulture. NutriCulture. And Borges. Lastly, but not the least. Lastly, but not the least, sir, wait. I would like to call upon Mr. Vinay. Is he around? Mr. Vinay. I would really like to give him a big round of applause because he's Dr. Dash's second hand, right hand, left hand, whichever hand you would like to say. We have been disturbing at all odd hours to him. Thank you. Thank you. A photograph. So thank you very much for everybody for being here once again. And I officially close this conference here today. Thank you once again. Hope to see you again physically. And we are going to have a closing song also. So kindly please wait for that. And again, another announcement, those who have not received the trophies, please collect it from the backstage. Thank you very much once again.
So can we have Isha Das?
Good afternoon, everyone. My name is Isha Das. मेरा नाम गुम जाएगा, मेरा चेहरा बदल जाएगा. आज से मेरी आवाज ही मेरी पहचान है आप सबके लिए. आज जाने की जिद ना करो, आज जाने की जिद ना करो, आज जाने की जिद ना करो, यूं ही पहलू में बैठे रहो, यूं ही पहलू में बैठे रहो, आज जाने की जिद ना करो, हाय मर जाएंगे हम तो लुट जाएंगे, ऐसी बातें किया ना करो, आज जाने की जिद ना करो, तुम ही सोचो जरा क्यों न रोके, तुम्हें जान जाती है जब उठ के जाते हो, तुम जान जाती है जब उठ के जाते हो, तुमको अपनी कसम जाने जा, बात इतनी मेरी मान लो, आज जाने की जिद ना करो, वक्त की कैद में जिंदगी है मगर चंद घड़ियाँ यही है जो आजाद है, चंद घड़ियाँ यही है जो आजाद है, इनको खो कर मेरी जाने जा, उम्र भर ना तरसते रहो, आज जाने की जिद ना करो, यूं ही पहलू में बैठे रहो, आज जाने की जिद ना करो, आज जाने की जिद ना करो. Thank you so much. Thank you.
So before we conclude, I would like to thank Isha. Such a mesmerizing voice. I think we are all being stopped after listening to her voice. And there is a very small and a very important announcement. Today is birthday for Dr. Kajal Pandya. Okay. So I would again request Isha to, can she sing a song for wishing her? And we'll have a cake cutting ceremony over here, but no distribution we'll have outside. Okay.
Happy birthday, Kajal ma'am. Happy birthday to you. Happy birthday to you. Happy birthday, dear Kajal ma'am. Happy birthday to you. Many wishes to you. Many wishes to you. Happy birthday, dear Kajal ma'am. Happy birthday to you.
All the award winners, first district winners, please come on the stage quickly for the group photograph. District winners.
And we have a high tea arrangement also, please.
District winners. सबको सेट करते हैं, नहीं तो सब लोग मिक्स हो जाएंगे. District winners, please come on the stage fast. इनको गाइड करो. डिस्ट्रिक्ट वालों को कैसे बैठना है. Only district winners, please. All district winners. State winners. State winners. State winners, please. State winners, please come on the dais quickly. State winners, please quickly on the stage.
National goes के पर.
I think some female.
But what is the issue?
I know that
सर हो गया.
National winners. National winners. National winners quickly on the stage. National winners, please come quickly on the stage. सर जगह ही नहीं, आप जाओ. Say cheese. No cheese, say peas. Congratulations to all the winners.
I'll click your photo. No, you come
So reached home?
Yeah, just half an hour back.
Okay. Good, you celebrated Kajal ma'am's birthday. I missed that. That was.
Okay.
I just saw the pictures. I said Kajal ma'am's birthday celebrated.
Did you left before?
Yeah, I left before.
Acha, okay. I know you stay far off Noida.
Yeah, I was so exhausted. So I just want to, I'm having severe headache. So I said, let me leave.
Well, actually, congratulations for your daughter's birthday also, which
Thank you. Thank you so much. Thank you.
Sorry
Very
to
happy
interrupt you,
because
ma'am. We are live.
We were live. Can I please see Dr. Anurag's introduction, please, and his PPT? Well, actually, congratulations for your daughter's birthday also, which
Thank you. Thank you so much. Thank you.
Sorry
Very
to
happy
interrupt you,
because
ma'am. We are live.
We were live. Can I please see Dr. Anurag's introduction, please, and his PPT? Well, actually, congratulations for your daughter's birthday also, which
Thank you. Thank you so much. Thank you.
Sorry
Very
to
happy
interrupt you,
because
ma'am. We are live.
We were live. Can I please see Dr. Anurag's introduction, please, and his PPT? Well, actually, congratulations for your daughter's birthday also, which
Thank you. Thank you so much. Thank you.
Sorry
Very
to
happy
interrupt you,
because
ma'am. We are live.
We were live. Can I please see Dr. Anurag's introduction, please, and his PPT?
Just a minute. We don't have a ma'am Anurag's CV, sir.
Dr. Rahul, would you like to take your questions immediately after the presentation, or you can wait till the session gets over?
It will be better if it's after the session only.
Okay, fine. Speaker for 20 minutes, which will be followed by the question and answer round towards the end of the session. And I would request the audience to please write down their questions in the chat box, which can be taken towards the end of the session. So without further delay, we begin with today's session and would like to invite our first speaker of the evening on virtual platform, Dr. Rahul Gupta, who will talk about overview of management in diabetes. So Dr. Rahul Gupta is an assistant professor at the Department of Endocrinology and Metabolism at All India Institute of Medical Sciences, New Delhi. He has almost 16 publications to his name, and his key interest areas are diabetes, obesity, and pituitary. Over to you, sir.
Thank you, Ms. Soumya, for your kind introduction. So first of all, I am very grateful to the organizing committee to give me an opportunity to be a part of this esteemed conference. And as we all know that nutrition plays an important role in maintaining optimal health, and this was highlighted in the recent COVID-19 pandemic, where we have seen that those individuals with diabetes-related comorbidities, those with nutrition-related comorbidities like obesity, hypertension, and diabetes were disproportionately affected in terms of requiring hospitalization, invasive ventilations, and even mortality. So I will be sharing my slides now. Okay. Just to check, are my slides visible?
Yes, sir, it's visible. Please go ahead.
So my current presentation today will be dealing with the overview of the nutritional management in uncomplicated type 2 diabetes. And when I say uncomplicated type 2 diabetes, I mean a diabetic individuals who have been having diabetes of recent onset or shorter duration, let's say less than 5 to 10 years, is on minimal amount of drugs not exceeding 3 to 4, and is devoid of any complications related to long-standing diabetes like diabetic nephropathy, neuropathy, or cardiovascular disease. Before I begin my presentation, I declare no conflict of interest, and I will be discussing this topic under following subheadings: the evolution of dietary patterns, the role of diet in the pathogenesis of diabetes, how do we define metabolic health and its targets, the component of management in type 2 diabetes mellitus, and finally, the medical nutritional therapy in management of type 2 diabetes mellitus, beginning from a simply dietary regimens and moving onwards to the complex dietary regimens. So to understand the importance of diet in the pathogenesis of diabetes, we have to see how has we evolved from how our dietary pattern has evolved over the last few decades and centuries. So in the past, we used to have a feast and famine cycles primarily driven by the limited availability of the nutritions. So in the periods when nutrition was in abundance, there will be feast, there is an excess calorie consumptions, and these excess calories will be stored within the body as fats in energy depots. These energy depots primarily consist of your glutafemoral fat as well as the intra-abdominal and visceral fats. And what happens when the nutritional supply was limited, there used to occur famines. And at that time, this fat from these energy depots was mobilized for the purpose of energy generation. And this mobilization lead to restoration of the body composition to the baseline. Coming to the 21st century with the globalization and industrialization, the nutrition is in abundance. It's no more limited by the supply, and what we have is a continuous feast cycles where we are in a phase of continuous calorie intake with less of expenditure. So what is the consequence of these excess calorie intake is a transition from a metabolic healthy phenotype to a metabolic unhealthy phenotypes. So there are two differences between these healthy and unhealthy phenotypes. First is in relation to the total amount of fat, which is higher in the metabolic unhealthy phenotypes. And second is the distribution of the fat. In metabolic unhealthy individuals, the fat is distributed predominantly in the visceral adipose tissues, as well as the organ including heart, the livers, and the muscles. So the consequence of this fat deposition into the organs is twofold. In the organs like liver, heart, muscles, and kidneys, this deposition of fat leads to a state what we call as insulin resistance, whereby you require a higher amount of insulin to produce the same amount of glucose reductions. And on the other hand, in the pancreas, this deposition of fat leads to a decrease in insulin secretion. So what we have here is a double whammy where the demands are increased, but the supply is reduced, leading to a state of a hyperglycemia, what we collectively called as type 2 diabetes mellitus. So again, understanding this basic role of diet in the evolution of the pathogenesis of type 2 diabetes, it's not difficult to understand what we want to achieve with our dietary interventions. Basically, a transition from a metabolic unhealthy phenotype to a metabolic healthy phenotype by causing two things. First, a reduction in the total amount of fat, and second, its redistribution from the visceral organs to the glutafemoral region. So from a conceptual point of view, while it is easy to say that fat plays an important role, but in day-to-day clinical practice, it's not easy to measure fat. And second is that there are no clinically validated cutoffs for both total fat as well as distribution of fat that can help us distinguish between metabolic unhealthy and healthy phenotype. So instead of the cutoffs of fat, what we have is the targets for optimal medical health, which is based on easily measurable, reproducible, and well-validated parameters that are made by the glucose measurements, fasting plasma glucose, the 2 hours post-meal glucose, and HbA1c, the blood pressure, the body mass index, which is a marker of a total fat, waist circumference, which is a marker of fat distributions, and lipid levels, which is a marker of underlying insulin resistance. So here on the left, we can see what are the ideal targets we should we aiming to achieve an optimal medical health. And the cut on the right, you can see the cutoffs which are used to define metabolically unhealthy states. So as far as diabetes is concerned, as far as diabetes are concerned, we are almost using the same targets for achieving an optimal medical health. Within the fasting plasma glucose in the range of 80 to 110, a postprandial value of less than 140, and HbA1c of less than 7%. Similarly, other than the glucose targets, all these other parameters have an equal role in reducing the cardiovascular morbidities, where we try to target a blood pressure of less than 130 by 80, a body mass index of at least less than 23, a waist circumference of less than 80 centimeter in women and less than 90 centimeter in men. These cutoffs are primarily for Asian Indians and not applicable for Caucasians. And similarly, with the lipid profile, a TG of less than 150, an HDL level of more than 40 in men and more than 50 in women. So how do we achieve these targets in the patients with type 2 diabetes? The management of type 2 diabetes is three prongs based on lifestyle modifications, the medical nutritional therapy, and pharmacological agents, which could be either oral or injectables. The medical nutritional therapy forms an important pillar of management. And more often than not, if medical nutrition therapy is either not prescribed or is not followed, it's difficult to attain all the targets of metabolic health, especially those pertaining to the lipids and the body weight. So just like for any other interventions, for medical nutrition therapies, we have goals, we have the targets that we want to achieve, and the strategy that we utilize it. So what are the goals for MNTS? To achieve and maintain ideal body weight, attain individualized glycemic, blood pressure, and lipid targets, and lastly, delay and prevent the onset of diabetes complications, both microvascular as well as macrovascular. The targets we have discussed earlier. So what strategy should we apply while prescribing someone a medical nutrition therapy? This consists of first, nutritional assessment, second, setting the goals, third would be nutritional interventions, and lastly, the evaluations. So coming to the nutritional assessment, there are certain questions that every nutritional assessment of a type 2 diabetes individual should answer. The first and foremost is how much calories are being consumed per day. This set a benchmark for further calorie deficit that will be prescribed. The next question that needs to be answered is for what are the food sources from where these calories are coming. Thirdly, the timing of food consumption, the relevance of which I will be discussing later. And lastly, the patient preferences pertaining to the type of food they like, their willingness to change, and the overview of their lifestyle. So coming to once the nutritional assessment is complete, what we do is set the goals for an individual patient. And here these goals consist of a target weight loss that needs to be achieved. Most of the time, its bare minimum, it is 5%, can vary from as low as 5 to as high as 15%. The next thing is that over how much time we want to achieve this weight loss. And thirdly, the goals that have to be set in relation to the glycemic control, the blood pressure controls, and the lipid levels. Again, as far as setting goals is concerned, there is no one size that fits all. You have to relax the targets or become more stricter depending upon these multitude of factors which constitute the potential risk of hypoglycemia with the drugs that are being used, the disease durations. The longer the disease, less stringent will be the targets, the life expectancy, the important comorbidities, established complications, patient preference, resource, and support system. So just to give an example, there is no fun having a 15% weight loss in an 80 years old individuals with a limited life expectancy and long-standing diabetes-related complications. Once we have set the goals, the next step is what sort of nutritional intervention should we use in these individuals. So the interventions could be simple in nature, which is simple dietary regimens, or could be complex dietary regimens. These complex dietary regimens are upcoming and is being used left and right by various social platforms. And these include very low calorie diet and low calorie diet, the intermittent energy restrictions, or also called as intermittent fasting, and lastly, the famous ketogenic diet. So first, coming to the simple regimen, simple dietary regimen that can be prescribed to any individual with type 2 diabetes. These are easy to implement approach which deals with two basic aspects of diet, a quantitative aspect and a qualitative aspect. The quantitative aspects pertains to the calorie deficit that you want to introduce, and the qualitative aspect pertains to the food sources from which these calories are procured. So how do you instruct someone to have a portion control? The first step in this is to calculate their basal energy requirement. This can be calculated simply by using this formula: ideal body weight height minus 100 into 0.9, and multiplying this by factor of 25 to 30 will give you an idea of the 24-hour calorie requirement of that individuals. Now, once the calorie requirements have been calculated, and the weight loss goals have been established, using this assumption that you require to create a 7,000 kilocalorie deficit for loss of 1 kgs, a calorie deficit can be prescribed. So the usual calorie deficit that is prescribed to an uncomplicated type 2 diabetes is somewhere between 350 to 500 kilocalories per day. And using this regimen, we can easily calculate that the anticipated weight loss will be the tune of 1 kg over a period of 2 weeks to 4 weeks. So another simple methods of ensuring this portion control or introducing this calorie deficit. This is the calorie content of the commonly used food in Indian settings that I have procured from National Institute of Nutrition. So the thing I want to highlight here is that if we restrict chapatis by 3, and the number of cups of teas and coffees by not more than 1, we can easily introduce a calorie deficit of 350 to 500. What it means is it's not really difficult to introduce calorie deficit in our day-to-day life. Simple measures like by curtailing your chapati intake by 3 and reducing your tea intake to 1 without sugars can easily achieve this. The second aspect pertains to the qualitative aspect of the calories that are being consumed. It relates to the percentage of carbohydrate, proteins, and fat of which the diet should be constituted, and from where these carbohydrate, proteins, and fat should be procured from. So the usual recommendation by the National Institute of Nutrition for Indians is a carbohydrate source constituting 50 to 60% of the total calorie intakes, protein intakes of 12 to 15%, and a fat intake of 20 to 30%, and a fiber intake of 40 grams per day. As far as carbohydrate is concerned, the majority source should be from complex carbohydrates high in fibers, and refined sugars like beverages, juices, cold drinks should be avoided at all costs. The source of the protein should be preferentially from the vegetable sources, and if non-vegetarian sources are being used, it should be lean meats or low-fat milks. As far as fats is concerned, ghees like vanaspatis, ghees, and oils like desi ghees and palm oils are preferentially avoided. And majority of the cooking should be done in oils enriched in mufa and pufas, which include peanut, mustard, olive, and sunflower oils. So this is what constitutes the basic qualitative aspect of diet that was believed to be, say, a decade earlier. There is another upcoming qualitative aspect of diet, that is the meal timings. Does it matter or not? So now we have evidence that yes, it matters. And the study by Medit et al., what they have done is randomized 82 obese females to an early evening meal to be taken between 7 to 7:30 p.m. versus that of a late evening meals to be taken between 10 to 10:30 p.m. And what they found was that early evening meals were associated with a substantially higher weight gain by almost 2 kgs, and this translated into a decrease in insulin resistance and improvement in glycemic profile. So, coming to the complex dietary regimen, as we discussed earlier, there are 3 major complex dietary regimens that are in use right now. Very low and low calorie diets. This basically means restricting your calories intake to between 800 to 1200 kilocalories for LCDs and less than 800 for very low calorie diets. Then we have intermittent energy restrictions or fastings. And lastly, the ketogenic diet. So coming to the low calorie diet and very low calorie diet, it's primarily in current scenario has been talked in terms of diabetes cure, reversal, or remission. Again, before I move forward, I think it's very important that I clarify these terms. Diabetes can only be remitted. It cannot be cured or reversed. Once a diabetes, always at a risk of diabetes. The terms cures and reversals gives a false assurance that diabetes cannot occur. And just like any other chronic disease we have other than diabetes, the same term remission has to be used for diabetes as well. And it is defined as a glycosylated hemoglobin of less than 6.5%, occurring spontaneously or after intervention, maybe metabolic surgeries as well, and which is maintained off glucose lowering therapy for at least 3 months. So the usage of LCD and very low calorie diet and very low calorie diet in terms of diabetes remission involves 3 stages. The first is the low energy liquid diet that is given for almost 3 to 5 months and consists of around 800 to 900 kilocalories, followed by a food reintroduction state lasting for around 2 months, where the caloric intake is increased to 1400 and solid diet is reintroduced. And lastly, a weight loss maintenance phase, where an individualized prescription based on the ideal body weight caloric requirement is given to the individuals along with a 500 to 600 kilocalorie deficits. So can LCD and VLCD cause a diabetic remission? So here we have an open label cluster randomized trial conducted by Lean Me et al., where almost 306 individuals with an early onset diabetes and obesity were prescribed to a very low kilocalorie diet versus that of standard of care. And what they found was that in the interventions, almost 24% of the individual lost more than 15 kgs of body weight over a period of 3 to 5 months. And this translated into almost 46% of them having a remission of diabetes. Interestingly, here we can see that the percentage of individuals going into diabetes remission was directly proportional to that of the weight loss, with 86% going into diabetes remission when weight loss was more than 50 kgs and only 7% going into remission when weight loss was less than 5 kgs. Like with any other complex dietary regimen, the question with these very low calorie and low calorie diet is the sustainability, that how many of the individuals can actually sustain this diet and can continue to maintain that weight that they have reached during the intensive phase of the interventions. So from the same study where we can see that despite maintaining the same weight loss, the percentage of individuals staying in diabetes remission substantially declined at 2 years as compared to 1 year. So at 2 years, it was 35%, while at 1 year, it was 45.6%. This gives an importance of using the term of remission instead of cure and reversal, suggesting that even with an intensive weight loss, you still may have a relapse of the diabetes. And it is primarily because in natural course of diabetes, there is a progressive decrease in insulin secretion, and this decline can only be retarded and not completely reverted. And this phenomena of having a progressive relapse of diabetes is uniform across the all weight loss category, both more than 15 kgs as well as less than 5 kgs weight loss. Okay, so most of these studies actually have been conducted in Caucasians, and there are certain issues that have to be dealt with when we apply it into Asian Indians. The first and the foremost is high prevalence of insulin deficiency at disease onsets in Asian Indians, which could be to the tune of as high as 50%. So when we say a diabetes remission, the prerequisite is that the endogenous insulin secretion has to be there. And if this is absent because of insulin deficiency, the proportion of individuals which will be going into remission after an extensive weight loss is going to be less than 46% of what we have been seeing in the Caucasians. The next thing pertains to the target weight loss that we need to set. In our setting, because of the differences in the body size amongst the two ethnicities, Caucasian versus Asians, it is better to use percentage rather than an absolute weight loss of 15 kgs over a period of 3 to 5 months. The third thing is that for a given calorie intake, Asian Indians tend to deposit more fat within the abdomen as compared to the gluteofemoral regions. So we may require a prolonged duration of low-calorie diet as long as 3 months to attain that same benefit. And lastly, this is very, very important that these dietary regimens, if tried in individuals who are on insulin or secretagogues like sulfonylureas, like limiprid or SGLT2 inhibitors, it requires frequent monitoring and coordinated team efforts, because if these individuals are put on these complex dietary regimen, wide fluctuations in the blood glucose levels as well as the risk of ketoacidosis persists. Lastly, the issue of long-term safety in terms of the muscle loss that will occur in these individuals when prescribed a very low calorie diet is not been ascertained yet. So coming to the next complex dietary regimen, that is the intermittent fastings, the principle is recapitulate the feast-famine cycles that we have discussed earlier. So during you induce the phase of fasting, which will lead to an activation of counter-regulatory hormones, which will lead to a lipolysis and mobilization of the fat from visceral depots. So this is what we have discussed in the first few slides, where we have said our overall goal is to convert an individual from metabolic unhealthy to a metabolic healthy phenotypes. And this transition from glucose as an energy source to fat as an energy source is what we call as metabolic switch. And again, it can be seen easily here that what we aim by doing an intermittent fasting is reducing this visceral fat and transitioning it to a gluteofemoral regions where it is considered to be a good fat. Then there are various methods of producing an intermittent fasting. It could be a time restricted eating, where within a day, there is a certain amount of time in which you have to consume all your calories, let's say varying from 6 hours to 12 hours in the day, and the rest of the day you spend in fasting. A 5-2 method, where in a week you fast on 2 days, while in the remaining days you are on your usual calorie intake. A modified alternate day fasting, where on one day you have your usual calorie intake and the other day you have a restricted calorie intakes. And 0 calories alternate day fasting, where on alternating days we have a normal intake that versus that of no intakes. So does intermittent fasting really works? The answer to this is available from this randomized control by Carter et al., where they randomized 137 individuals to a continuous energy restriction of 1200 to 1500 kilocalorie per day to that of an intermittent energy restrictions in a 5:2 methods. So what here it can be seen is at the end of the trial, at the end of the 12 months, those subjected to the intermittent energy restrictions has had a much higher weight loss by almost 2 kgs, which returned to baseline after the trial was stopped. And this weight loss actually translated into a non-significant reduction in the glycosylated hemoglobin levels. So yes, we do have a level 4 evidence that intermittent fasting does work in terms of achieving weight loss and some additional glycemic benefits. So like we have with very low calorie diets, there are certain issues for applying these intermittent fasting into individuals with type 2 diabetes. First, the representation of type 2 diabetes in most of these randomized controlled trials is limited. Most of these studies do not have glycemia-related measures, be it fasting, postprandial, or HbA1c as their primary outcomes. And thirdly, just like with VLCD and CIL-CD, individuals on insulin, secretagogues like sulfonylureas or SGLT2 inhibitors should be prescribed this diet only as a part of coordinated team efforts because of the wide fluctuations in blood glucose levels and risk of ketoacidosis that will increase once they are put on these diets. Coming to the last complex dietary regimen, that is the ketogenic diet. Here again, the principle is also the same, a metabolic switch, where we want to shift the metabolism from carbohydrates to fatty acids and fatty acid derived ketone bodies. Again, the purpose here is same, to cause a redistribution of fat from the visceral depots to the gluteofemoral regions, thereby decreasing the insulin resistance and increasing the insulin secretions. So what are the methods of prescribing a ketogenic diet? It's generally amount to restricting the carbohydrate constituting no more than 10% of the total caloric requirement, which amounts somewhere to 50 to 150 grams of carbohydrate per day. Of the remaining energy is met through requirements are met through fat sources or protein sources. And then there are again variations of ketogenic diets, which could be cyclical ketogenic diet in a 5:2 method, where on 2 days in a week you put an individual on ketogenic diet, while the remaining 5 days they have their usual calorie intake. A targeted ketogenic diet where the carbohydrates are timed with the exercise, and high protein ketogenic diet where this proportion of proteins can be increased to 30 to 40%. So again, what evidence there is to say that ketogenic diet works? In this systematic review and meta-analysis by Ivan et al., where we can see that the use of ketogenic diet was associated with a reduction in glucose levels by almost 30 milligram per deciliter or 1.28 millimole per liter, and a reduction in the glycosylated hemoglobin by almost 1%. Now, this 1% reduction is almost equivalent to what we can actually achieve with most of the oral anti-diabetes drugs. And another thing of interest is that this response is almost consistent across all the studies.
Rahul, if you can please summarize in a couple of minutes.
Yeah, just 2 slides more. So lastly, the applicability in Asian Indians. In Indians, the carbohydrates are an important constitution of diets, and that's why it's very challenging to put them on ketogenic diets. Those on multimodality treatment for diabetes requires a coordinated team efforts, and the long-term safety of these ketogenic diets in terms of DKA, low BMD, renal stones is still not clear. Coming to the last step of medical nutrition therapy, which is evaluation, and is of utmost importance in achieving sustainability. For all the diets, long-term compliance does not exceed more than 20% in best of the centers and in the best of the studies. And it still remains the biggest challenge, and the evaluation and repeated evaluation, monthly or 3 monthly, are required to achieve sustainability. So overall, to conclude, we could say that medical nutrition therapy is indispensable in management of diabetes. There is no one-size-fits-all approach. The important components of any dietary intervention in a declining importance are first calorie restrictions, followed by dietary constituents, and lastly meal timings. The complex dietary regimens require supervision and a coordinated team effort. And lastly, sustainability of dietary interventions required frequent evaluations, modification of interventions, and revisions of target. Thank you.
Thank you, Dr. Rahul, for beautifully explaining us the medical nutrition therapy for a diabetic patient. Now, if you allow me, I have a couple of questions to ask you. Yeah. So you talked about in detail about the VLCD diets. So do you recommend it for a patient who is on insulin therapy also?
Okay. So if somebody is on insulin therapy, the first thing that needs to be answered is can somebody on insulin be prescribed a VLCD or not? Yes, they can be prescribed a VLCD. Okay. And type 2 diabetes individuals who are on, let's say, basal insulin or a basal plus regimen, they can be prescribed VLCD. But the important thing here is that it requires a coordinated team efforts where we have an endocrinologist, an expert nutritionist, and a counselor who can provide a 24/7 support with weekly or at least a bi-weekly evaluations.
Okay, and even an insulin-dependent patient can undergo a 12 weeks program for VLCD.
Oh, so somebody who is having a type 1 diabetes or is on, let's say, more than 3 injections of insulin, it's really very challenging to put them on VLCD.
Okay. And same like for intermittent fasting again. So a diabetic can follow an intermittent fasting regime?
Again, at the opening of my presentation, my first statement was that whatever I will say, what I will be saying, will be applicable to an uncomplicated type 2 diabetes mellitus. A diabetes of a shorter duration, somebody who's on minimal OHAs, not exceeding more than 2 to 3.
Or maybe a recently diagnosed diabetic.
Yes, exactly.
Okay, fine. Thank you so much, sir. Thank you for your detailed and beautiful presentation. We now move on to our next speaker of the evening, who is Ms. Manju Panda. And she will talk in length about the nutritional care in complicated diabetes mellitus, followed by the case studies towards the end of our talk. So over to you, Manju ma'am.
Yeah, hi, good evening. Thank you so much. Thank you, Dr. Rahul. I think half a job is done with your presentation. So I am glad to hear that. And, you know, that's what my presentation is, that nutritional care in complicated diabetes mellitus. Slide. So we are aware that, you know, worldwide we are multiplying in diabetes quite high in number. And we are standing on a second number in diabetes. Change course. Yeah. So 425 million people in world is suffering with diabetes, and 82 million people in Southeast Asian region. This number is multiplying, the percentage is going up day by day. Obesity is going up day by day. So that's why.
But your slides are not moving.
My slides are not visible?
It's visible, but it's not moving.
I haven't changed.
Okay.
I'm on a prevalence of diabetes.
So it has not changed. It's still showing your first slide.
Okay.
Your introduction slide.
Okay, just give me a second. Is that okay now? Are they moving now?
No.
I think you need to put it on the slideshow mode.
It's on slideshow. Do it again. Just give me a second. Sorry.
From beginning, I think.
Is it okay now?
Ma'am, it's still showing your first slide only, the introduction slide. It's moving now, ma'am. It's fine. Please go ahead, ma'am.
Yeah. No, it's not moving with me. Okay. So I was saying that number of diabetes is increasing, and we are all aware that worldwide we are standing in number 2 after China. Our country is progressing. It's expected to be much more, a bigger number by 2045, it's expected to be 151 million, which is 82 million till now. And post-COVID also, it has been observed that the number of diabetes has really gone up. One of the reasons is that our ethnicity, our age, BMI, and our increased serum insulin level, insulin resistance, level of adiponectin, characteristic dyslipidemia, like Dr. Gupta was highlighting, increased abdominal and obesity and visceral fat, which he has shown in a very good picture. So these are the basic, reasons that we are multiplying in this number. Yes, it is very correct that if we want to prevent diabetes complication, we have to have a good sugar control. Like Dr. Gupta was showing that HbA1c targeting less than 7% can delay the complications, acute complications, which occurs immediately need an action, relief from the symptoms of diabetes, and improvement in quality of life. Identification and management of comorbid conditions like obesity, hypertension, and dyslipidemia. Prevention of microvascular complications like retinopathy, neuropathy, and nephropathy, and prevention of macrovascular complications like cardiac, cerebrovascular, and peripheral vascular diseases. So prevention of infection is very, very important. Therefore, the complete treatment of people with diabetes require educating a healthy lifestyle with focus of increased physical activity and proper balanced diet in addition to prescribing medication. So medicational nutrition therapy for diabetes mellitus require application of the nutrition behavioral science. That's the reason we have to talk about, and that's the reason fat diet don't work very well, because intermittent fasting or these keto diet, they are for a short duration. Diabetes, like Dr. Gupta said, that's a very common saying as well, that once you are diabetic for lifelong. So it is very, very important that we need to make a behavioral change that we can continue for a longer duration, not for a month or two, because diabetes will live with it. Nutritional assessment, which include metabolic, nutritional, and lifestyle parameters, setting goals, like we were showing, beautiful slide, that what should be the small frequent meals, and reducing the portion size, and also should be there, which should be, so goals should be practical, achievable, and acceptable to the patient and individualized. Nutritional intervention include nutritional education, so that according to their taste, according to their availability of the food, that they can make it for a longer duration. Because a lot of time when we are counseling the patient, they says, Abhi, I'm traveling, or we have got a wedding, or we have got, some festival, that's why things has went haywire. But it is very important, if we teach them the portion, if we teach them how to modify or balance the things, I'm sure we can make them enjoy festival, enjoy weddings, or enjoy vacation without hampering their sugars. Evaluation to assess if the goal has been achieved and to make necessary changes. So evaluation is always baseline for motivation. If we evaluate, if we give them a target, if them assess or praise them, I'm sure the things will become much more easier and better. So component of diabetes management is balancing macronutrients like your carbohydrate, protein, and fat, reducing carbohydrate load, but it should be, again, the percentage mentioned with Dr. Gupta's slide. I will be also showing that. Lowering the glycemic index. So glycemic index, we know, is the speed with which the glucose formation is occurring, and with it is not necessary that we look forward for something, which is out of their schedule, but we can reduce glycemic index by increasing the fiber content in their diet. Then implementing an overall health dietary pattern as emerging as better approaches for medical nutrition therapy in diabetes. So all researchers, like Dr. Gupta also given a very beautiful data, which shows that they're improving glycemic control, reducing weight, and improving, it will help to improve on cardiovascular disease. And these approaches are providing by registered dietitian or healthcare provider. So energy distribution, like he was already explained, so I'll just quickly go through with it, that 55 to 60% of energy from carbohydrate. Look forward for the sources which are complex. Different carbohydrate produces different glycemic index. Even combining two carbohydrate also changes the index. So managing total carbohydrate is important. Carbohydrate from food which is high in fiber. That means more of a whole stuff, if they're using wheat, so it should be without a covering and all. And bran should not be removed, rather adding on bran if, nuclear family and buying a packets, etc. All patients with diabetes should encourage to have a small frequent meal, because whatever we are eating is going to convert into glucose. If we have a small supply of it, pancreas can respond to it better and take care of, picking up the stuff. Food exchange system, so that we can have more variety and it can have an individual plan. Protein, as advised, at 12 to 15% with total energy. But in India, the protein intake is pretty poor in our diet. So we have to encourage more on pulses, soyas, grams, peas, milk, dairy products, or fish or lean meats has to be incorporated to fulfill the protein requirement. I think we all are aware that 0.8 gram per kg ideal body weight is recommendation. If there's a supplementation or mutual kind of thing, then there has to be a combination of cereal protein ratio 4:1. Improper ratio will not absorb it well. And, during this conference, even we were seeing that fermenting food is making a good mood food. So idli, dosa, which is made of, or dokla, khandvi, they all are the fermented stuff which are good mood elevators as well as easy to digest. Then fiber recommendation in general population is 40 grams per kg 40 grams per day for 2000 calories. So fulfill the to fulfill the fiber requirement, we have to encourage more on fruits and vegetables, and we have to encourage more of fruit rather than juices. Fat percentage, always mixed combination is advised, that there has to be some percentage of saturated fat, polyunsaturated and monounsaturated fat. As per the recommendation is 1:1:2 is the ratio which has been advised. But yes, MUFA-rich cooking food and nuts in moderation may benefit in glycemic control as well as cardiovascular diseases. Again, this is a very common practice, because once the patients are told that you are diabetic, they shift sugar to salt. So sodium intake recommendation for diabetic patients is also being considered and taken care, that it should be less than 5 grams per day. We know that diabetes and hypertension go hand in hand. The risk of cardiovascular diseases, the risk of kidney diseases are much higher with diabetes. So we have to, sensitize patient about sodium restriction, about on a processed food should be reduced. Alcohol is another form of juice or a refined calories or an empty calories. So we have to sensitize them that if they're consuming alcohol, they should not be empty stomach, or they should not be with the fried or non-vegetarian, because being in quick sugar or because in empty calories, if we increase the fiber content over it along with it, so eating salads or sprouts or fruits with alcohol will take care of the peak formation with alcohol. So diabetes, if not managed well, can complicate the life. Morbidity and mortality due to diabetes arises because of these complications. Complications are basically divided into two: acute, which include hypo and hyperglycemia and decay, etc. Chronic is gradually occurring, and chronic complications, once occur, the person has to live with it. There is no way to come out of it. But yes, these situations are, we have to teach patient to how to handle acute complication, that they can prevent landing up into the critical condition. So if anybody, a diabetic patient who is on insulin or sulfonyl or SGLT2, if their sugar level goes below 70, the risk, they may have a symptoms like hunger, sweating, tremor, palpitation, etc. And formula 15 has been advised, which means 15 grams of glucose should be given to the patient immediately, which can bring down their blood sugar level more than 60 mg. Ideally, it should. But if it is not coming up, then we always advise patient to repeat glucose till their sugar levels are more than 100. And once they have recovered out of it, then they are supposed to eat high fiber snack to retain that level, and then assess that why this hypoglycemia has occurred. Maybe your food was lesser, or some diarrhea, vomiting after food, or a long gap between a medication and food. So there are many reasons to work it out. And if there's a kidney problem, then the risk of hypoglycemia with amputation, the risk of hypoglycemia increases. So we have to make sure that the patients who are on insulin or on sulfonyl or on any medication which can create hypoglycemia, sometimes even alcohol also react with the medication and give you hypoglycemia. So we have to sensitize patient, and we have to just tell them that carry some extra glucose or a candy with them so that they can prevent or save life rather. Decay is an emergency condition in which normally it is more common with type 1 diabetic. That means this occurs with lack or the deficiency of insulin with very high blood sugars. So if a person is type 1 diabetes, we have to inform that what is ketoacidosis, what is diabetes, ketones, and how to come out of it. Ideally, as I said, that's because of the deficiency of insulin. So giving insulin is the best way to overcome it, and giving a patient bed rest, advising patient to have a bed rest so that they can come out, that they can stop ketone formation, and they can come out by going before, they will not land up into the ketoacidosis and comatic condition. HHS, which is hyperosmolarity, hyperglycemic state, which is commonly seen with type 2 diabetes, elderly patients, where they miss on medication, or they are, but the ketones are not there, but yes, they can have osmosis kind of condition, which can be more, drain out. So they also need to balance the fluid and prevent that they don't land up into the critical condition. So as Dr. Gupta has already highlighted, that when diabetes is diagnosed, our beta cells are already more than 50% has been destructed. So if we are not controlling diabetes well, the risk of these organs getting affected, the chronic complication like eyes, heart, kidney, nerves, and the limbs, that may ultimately reach to even blindness, heart diseases, kidney failure, and limb amputation. So if diagnosed earlier, if we are treated in time, we can prevent the damage. Most complication causes clinical symptoms only if they're diagnosed at very late stage, then definitely the prevention is in a problem. So kidney disease, as if somebody has got the creatinine D range, definitely the dietary modification goes priority goes to potassium, sodium, and protein. And then definitely mostly the kidney disease patient or the nephropathy suffering people are having insulin therapy, so which is easy to handle. So priority goes to completely to kidney problem rather than talking about the general diabetes diet. So in extreme cases, diabetes can lead to kidney failure, frequent expensive dialysis, and risky and expensive and difficult to obtain kidney for transplant. But yes, if we tell the patient to keep an eye on microalbumin urine, annually keep in check on kidney function test, we can save their kidney. Nerve damages when sugar levels are pretty high, the blood flow become poor in the nerves and their function start getting affected. So for nerve damage, definitely we have to think about the food which are opening our arteries and making blood circulation better. So fruits and vegetables are the sources, and B12 required to prevent the nerve damage. And if somebody has then definitely B12 is required. So adding on nuts to their diet or giving eggs or fish or non-veg stuff will help them, the nerves to become better. Diabetes retinopathy. So if diabetes, this is always required that as an educator or a counselor, we should tell diabetic patient to keep their keep a check on their retina at least once in a year. If they do that, I'm sure they can prevent the vision loss. So for that, again, vitamin A in our diet is very important. Along with that, HbA1c to be taken care, keeping an eye on your kidney function, because it has been observed that person having kidney disease are having very high risk to have eye issues. So that should be taken care. And people with diabetes can prevent eye problem by keeping their blood sugar and blood pressure control and cholesterol in levels within a range, like Dr. Gupta has highlighted. So HbA1c should be less than 7%, blood pressure should be less than or within a range of 120/80, and LDL level should be less than 100, total cholesterol less than 150, and HDL more than 40 for male and more than 50 for females. Amputation figures are also pretty high because of diabetes. So we have to educate patients that how they can save their feet. So foot inspection of skin, nail, and structure of deformation, examination of footwear. If any of the problem occurring, color changing, high arc foot or charcoal, should be informed and it should be taken care. Even for the foot problems prevention, cigarette smoking, good blood pressure control, good diabetes control is very, very important. So this is about the foot care, that you don't walk barefoot, don't smoke alcohol, exposed to the extreme temperature, using hot fermentation, using chemical agents, wearing new footwear for a longer duration, and neglecting any minor foot lesion should be taken care. So as I've highlighted, just summarizing it, nephropathy, protein should be taken care, and we look forward for high biological value protein so that we have less burden on kidney, but the protein restriction is not major, 0.6 gram per kg body weight. Sodium is very, very important. Potassium is very, very important to be considered and monitored very, very closely. So cutting down on a preserved canned food, cutting down on an extra salt will help to improve on your sodium. Potassium, so if potassium is deranged, because potassium is an important mineral, but if there's a potassium is deranged, definitely in such scenario, the fruits and vegetables, which is high in potassium, should be taken care. But yes, we should not miss on them, but they are the good sources of fiber. Maintaining optimal body weight and restricting salt is very important to prevention of any kind of complication. So adding on more fruits and vegetables to your diet and good quality of fat, omega-3 fatty acid, dyslipidemia, so cholesterol should be within a range, and vegetarians can add flax seeds to boost up the B12, omega-3 fatty acid, and both fish and flax seeds are the rich sources of it. Dietary management should be accompanied with regular physical activity, so that will help you to maintain your weight. Saturated and trans fat sources should be restricted. So if somebody is non-vegetarian, definitely we want them to restrict on butter, ghee, margarine, and coconut oil. But if a vegetarian person, then definitely we can add on these. But total saturated fat consuming from oil, from a ghee or butter, along with using from a dairy product or any of the non-vegetarian sources, should be considered. Alcohol restriction will bring down on triglycerides and bring down on your sugar levels also. Tobacco, smoking and chewing tobacco should be totally prohibited. But yes, because they shrink your arteries and make the neuropathic problem much higher. Kidney disease, heart disease, and even eye disease with smoking is pretty high. Stress management is very important because it is essential, which could take a form of meditation, yoga, or long outdoor walk or exercise, or trying out your hobbies like reading, gardening, painting, etc. Practicing of yoga is our traditional Indian system, which has a therapeutic value in controlling our physical and mental health. So it should be done under the guidance of an expert. Sorry. So regular physical activity along with the dietary management is an essential key for preventing complication and complicating your diabetes. Complete evaluation of patient with diabetes should be performed before recommending an exercise. Exercise program has an individualized according to one's ability. Benefit of exercise, definitely it improves on your insulin sensitivity. It reduces the risk of heart disease, controls your blood pressure, improve on your bone health, and improve on your weight as well. Keep one flexible and agile, help relieve stress, anxiety, and prevent depression, increases strength and stamina, promote sound sleep, and increase metabolic rate and digestion, which delays the process of aging. So recommendation is 150 minutes of aerobic exercise or its equivalent along with some resistance training at least twice a week with the flexible exercise will keep you going with your diabetes and staying healthy without landing up with any complications. Thank you. So Soumya, should I shift to questions, to case studies?
Yeah, ma'am, please.
Okay. So I have prepared 4 cases from my daily OPD. This was a very interesting case. This girl was 29-year-old with BMI.
Go next slide, please.
Sorry?
We cannot see your case study slide.
Just give me a sec. Is that okay now?
Yeah.
Yeah. Okay. So this was very interesting case. 29-year-old girl with BMI 17.8. Her height was 143 and weight was 36. She diagnosed diabetes at the age of 9 years. And unfortunately, in 2016, she has got renal transplant done. She had diabetes ketoacidosis several times. That was very unfortunate and was on insulin pump when I've met her. She was on Visalon because of her transplant, and she was admitted with DK again with us with decreased urination and multiple episodes of vomiting. Her serum creatinine was very good, 0.78. Her GFR was 87. Hemoglobin was low, 10.6. Sodium was 133. Potassium was also within a range. Even diabetes was not that bad, 7.8. But she was giving a history that her previous HbA1c was 5. That was a very strange figure. And we have got expert Dr. Rahul. I need your help for this. So, and her dosage of insulin also, she was using 1 unit, 2 unit kind of thing, boluses from pump. And even her basal was, I think, 27 or something. So, I was shocked when I came to know that she has multiple of DK, and even she was not aware about that what is diabetes ketoacidosis. So here, what the education lack, because type 1 diabetic, I think we all need to, first thing they should know about that, what is diabetes ketoacidosis, what is the role of insulin to prevent it. She was using pump, but she was ignoring to test her sugars. And she was having lot of hypoglycemias also, but then she was just working on by eating it, eating a lot of stuff and not monitoring on sugar, cutting down on insulin. So she was a little unusual case. Looking at her body structure, even I was suspecting that she's having celiac as well. So, we have discharged her on insulin 10 units of Lantus, not on pump for a shorter duration. And Novorapid dosage is given 10, 8, and 6. But now she has to come for a follow-up. We have given her a diet as, in the morning, there was a session on type 1 diabetic, that for type 1 diabetic, we don't do too much of dietary restriction. She has got renal transplant, but definitely her protein and other things has to be taken care. After transplant, there's not so much of restrictions required, but yes, monitoring required. So Dr. Gupta, you like to add on something over here?
Yes, ma'am. There's a few things regarding type 1 diabetes. So
yes, sir.
Whatever I have discussed earlier, type 1 diabetes is an entirely different ballgame. And the principles that we use to manage type 2 diabetes are probably not applicable to type 1 diabetes. Here in this case, the challenges were multifold. First, she was on an insulin pump. Second, she was taking steroids that are likely to produce the high fluctuations in blood glucose levels. What happens after Visalon intake is that your glucose values peaks, and by evening, what you will have is a rapid decline in your glucose values, and that was probably contributing to her hypoglycemia. And in type 1 diabetes, nothing can replace a frequent glucose monitoring. Doesn't matter.
Always required.
Yes, doesn't matter if you are on a multiple subcutaneous injections or on insulin. They have to check their sugars at least thrice a day before breakfast, lunch, and dinner.
Exactly.
And now, actually, even now we have a facility for continuous glucose monitoring sensors as well that have actually relieved the burden of frequent pricks that is bothersome to bothersome to many type 1 diabetes cases. And probably that might help us in this case in identifying the glycemic profile and where actually we are lacking in terms of matching the timing of insulin with that of the.
Exactly. Even the peak of Visalone elevating sugar post lunch and even early evening.
Yes.
Yeah.
And coming to Visalone, I think it was a biggest challenge during COVID-19, where almost 70 to 80% with diabetes admitted in hospitals were on steroids as a part of treatment of COVID-19. And the same issues were there. During day, the blood glucose were like in 400 and 500, and by the night, they will settle down to say less than 150.
Exactly. So I just want to summarize that type 1 diabetes, we all must know that they are insulin dependent kind of diabetes, youngsters, lean patient, and they have to live on insulin. And like Dr. Gupta added, that they must monitor sugars, that to understand what is the insulin requirement. When we are taking insulin externally, we have to understand the requirement, that how much is required. We cannot stick to the regime given by the doctor. The titration, the adjustment is very, very important. And that's the role of educator, to make them understand and aware about that what food need how much. And DK is very important. Diabetes ketoacidosis. When sugars are very high, insulin is not sufficiently there. There is a fat metabolism which has a byproduct called ketones. But diabetic patient, I was very strange, Dr. Gupta, when I came to know that she's not knowing what is DK is. I was because it's 20 years of her diabetes. So we must tell diabetic patient that what is ketoacidosis and how we can prevent. And if it is serious, patient is throwing out, cannot tolerate anything, then definitely hospitalization required. But there are urine ketone sticks are available in the market. So they should do closure monitoring on ketones if sugars are 300 plus. Yes, sir?
Yes, ma'am. Correctly said that they have to check their ketones levels when their blood glucose exceeds more than 300. So we have a commercial urine ketone strips that are all available. Exactly. And certain glucometers that can also measure blood ketones levels are also available.
Exactly. So blood ketones, they can check with glucometers. Dietary advice, there's not much difference, but yes, in her case, that we have to keep an eye on sodium and potassium because she is being a transplant patient. Protein, we have to give at least 0.6 to 0.7 grams per kg body weight. In fact, she's underweight. If you look at the BMI, she is underweight. So we have to increase her protein intake. But I was having a doubt that she may have a celiac also. So ADA guidelines say, sir, that every 3 year type 1 diabetic should keep a check on for celiac.
Yes. I think probably she must have been screened in the last 20 years. And if she has gone into renal transplant, the pre-transplant evaluation is extensive.
Yeah, exactly. Thank you, sir. Thank you for your support, sir. So case 2. Case 2 is very simple, which is he was 55-year-old male with BMI 32. So as a dietitian, we all know that, okay, we have to just target on a weight management. He was hypertensive from last 3 years and on therapy for that. He came with HbA1c 7.5, creatinine was normal, HP was 13 and random sugar was 196. So doctor has advised him glycomet, metformin twice a day and advised him to check sugar. So dietary advice here goes to polyuria, weight loss, polydipsia, and fatigue he was facing. Because his food is not completely converting into energy, he was lacking energy, and that's why there's a fatigue. And osmosis process is giving him more polydipsia and polyuria. Weight loss is maybe, well, I cannot say so. In such case, the weight loss is very, very rare. In this scenario, the weight loss has been given, but the target is that we have to get him at least 60, 62 kgs to, take him out from diabetes.
So probably the weight loss in this case is not a healthy weight loss that we desire.
Exactly.
Part and parcel of diabetes. So if I have an incidentally related diabetes and a diabetes who's presenting with weight loss,
Yeah.
Diabetes with weight loss is likely to have an impaired insulin secretion. In that case, it is better advised to control the glucose once, say, a matter of 2 months and 3 months, and then we can try all those complex dietary regimens that we have discussed earlier, because he seems to be an ideal candidate for all these: obese, short duration diabetes, almost no comorbidities, and on just a single drug.
Exactly. So helping him to lose weight, I'm sure will be he maybe out of diabetes. And
most likely.
And dietary advice, like Dr. Gupta has already highlighted very nicely, that cutting down on calories, increasing fiber, giving sufficient protein, so that we can make him as a healthy individual. Even her hypertension also, sir, will be taken care if we lose weight.
Probably the requirements will come down, but whether he will be completely off all the drugs is very difficult to predict as of now.
So what is type 2 diabetes is, like, if you remember the presentation from one slide from Dr. Gupta's, that the irregular fat distribution correction is required. So because of the fat adipose tissue, the body is not able to utilize insulin very well, which condition is called insulin resistance. Target HbA1c. So if we tell them to, your HbA1c 7.5, and to take you out from diabetes, we have to bring you down to less than 6.5. And losing weight may contribute or help you out to bring down your HbA1c to this range. Importance of weight reduction, because adipose tissues act as a barricade. They don't allow insulin and sugars to gel well. So if we give them all these feedback, I'm sure the patient will be themselves want to lose weight. Dietary myths. It is commonly heard or seen that, okay, don't eat rice, don't have banana, don't have mango. Whereas I will say that banana, mango, or other fruits are the good sources of vitamins and minerals. So during COVID, we have seen that so much of, immunity boosters we were talking about, and the best immunity boosters are fruits and vegetables. So we have to tell them that there is no restriction to any fruit, but portion size to be taken care. Fruit not combining with meal is important. Take it as a mid snack. That is better with your all meals, adding on salads so that you are able to cut down on your carbohydrate. Protein should be added. Normal Indian diet, if you look at, the proteins are lagging. So if we advise to add on protein to every meal, to maybe in a form of dal or dahi or paneer or chicken or egg or something like that, I'm sure that will improve on his overall health, as well as help him to lose weight. So you want to add on something?
Absolutely right what you have said, ma'am. That no fruits are ideally contraindicated in type 2 diabetic individuals.
Exactly.
All of it, portion control and timing is very important.
Yeah. So third case is 60-year-old male with 31 BMI, type 2 diabetic from last 14 years, hypertension from 10 years. Okay, yes, here also I need your help. Now I remember this case. She was a female, not male. Thalassemia minor. So just want to add on here. And her lab value was 11.5, which was a month before, not month before, January report, she was showing 7. Her ferritin level was high, 374.6. So doctor has told her to restrict on any iron-rich food. Her hemoglobin was 10.7.
So few things regarding this case. This case typically tell us the natural progression of type 2 diabetes, where we progress from a state of insulin resistance plus insulinopenia to an absolute insulinopenia. So this patient has a diabetes duration of 14 years.
Yes, sir.
And 14 years diabetes duration, what we believe is that at certain point of time, after some times, the oral drugs are likely to fail, because the endogenous insulin secretion becomes almost nil. That is due to secondary to a progressive loss of beta cells that occurs with increasing time. So probably that has happened in this case. The another interesting thing here is she having a thalassemia minor, which is very common in the North Indian ethnicities, especially in the Punjabis group, where the prevalence is very, very high as far as thalassemia minor is concerned. Again, restricting a high iron content foods probably is wise, but the usual foods that we are taking, they are not that high in iron content, and no special dietary recommendation for thalassemia minor needs to be given to these patients. And in addition, other than these dietary regimen that has been prescribed, probably a prescription of folic acid in these cases is wise.
Will be a good idea. Okay. So because we want her to help her to lose weight, so we have added SGLT2. She was on metformin and she was on sulfonyl as well, but complaining of fluctuation of sugar and hypoglycemia. So we have cut down on sulfonyl and shifted her to SGLT2 that can help her to lose weight. So thalassemia minor we are aware about, but then ferritin, you said very correct that the iron content and the availability of the iron content in our diet is not that high. So maybe in such cases, supplement only need to be restricted. Dietary, not too much changes required. Her previous HbA1c a month before, as she told me, January was 5.8, and now she has reached to 11.5. Reason what I can assess is because she was having repeated hypoglycemia and she was consuming a lot of cold drinks and squashes. So can be a contributor to 11.5, sir?
Yes, it can be a contributor, but again, in the backdrop of 14 years of diabetes, my first presumption will be she's having a phenomena which we call as a secondary glycemic failures on OHS. So if somebody is put on OHS, they will have a good control for a certain duration of certain amount of time. It can vary from individual to individual, could be as low as 3 years and sometimes can be as high as 20 years. But when the duration of diabetes exceeds more than 10 years, what we can see is a progressively lesser response on the same drugs at same doses.
And so one more question, mine, like if she is minor thalassemia, should we look forward for fructosamine or HbA1c is good enough?
Thalassemia minor at her HbA1c of 11.5%, the attributable role of that as an interference in the HbA1c determination is going to be very, very, very mild. So if we are somewhere around our HbA1c target of 7%, then probably using fructosamine, or better than fructosamine, we can now have a CGMS place, continuous glucose monitoring sensors place to calculate what we have called as advanced glycemic targets in the form of time in range, time above range, and time below range. They can actually give more values than what HbA1c or fructosamine can give.
Okay, thank you. That's a good addition to my knowledge. Thank you, sir. So what would be the dietary advice? So dietary advice will be same, Dr. Gupta, as controlling the calories, giving enough fruit and vegetables, and giving sufficient proteins so that she can build up,
Yes, but just because of frequent hypoglycemia, I will really want to know what would be the glycemic profile of that individual throughout the 24-hour days. So one has to remember that any hypoglycemia is followed by a reactive hyperglycemia.
Exactly, very correct.
What happens in these cases is that they will spend, let's say, 4 to 6 hours in low blood glucose range, and then throughout the day, the glucose values will be in the higher range.
Yeah, many times, sir, when we are using flash glucose monitor, we have seen that, that's a very common pattern that midnight they're going low and then morning they wake up with 170, 190 kind of fasting sugar and wondering, मेरी fasting कभी control में नहीं आती है,
And the implication of that is that we have to actually reduce the doses of drugs that we are giving, or reduce the doses of nighttime insulin rather than increasing.
Exactly. So when we were not having this system of CGM, I'm sure we were doing the vice versa, but now we are changing the system that this is what we need to do it. Yes, sir.
Yeah.
So another last case, which is...
You can quickly wind up, please.
Sure. The last case, Soumya. She's a female, 26-year-old female, pregnant with in her third trimester. It's not mentioned here. So gained 10 kgs weight by second trimester, and OGTTs were D-range, HbA1c was 6.2, hemoglobin was 12.7. She was on 28th week of pregnancy. Fasting was 110 and postprandial was 160. So pregnancy, we know that gestational diabetes occurs after 24 week of diabetes, and HbA1c target value for pregnancy is less than 6%. If it is crossing more than 6.6%, then definitely we have to take a support of insulin. Insulin is most safe for pregnancy because it doesn't cross placenta, it cannot harm baby, but mother need to be monitored closely that she should not land up in low sugars. So treatment advice is Levemir 10 and Humalog 242, and dietary restrictions were advised. So gestational diabetes is diabetes in the third trimester after 24 week of pregnancy to 28 week of pregnancy. Risk factor, as she has gained too much of weight in first 2 trimesters, is also one of the contributing factor, and age is also one of the contributing factor. If 25 plus years of pregnancy, the risk of gestational diabetes is very, very high. ADA guidelines says that HbA1c should be less than 6% during pregnancy. So very closely monitoring and advising insulin is the most safer. Metformin has been advised, but now I think many studies are indicating that the children are developing insulin resistance with the treatment of metformin. Prenatal dietary advice for a healthy weight gain is very, very essential in this case. I think this is my last case. So conclusion is type 1 diabetes has a complete absence of insulin. They have to depend on insulin and they need to be closely monitored. Diabetes ketoacidosis occurs with type 1 with very high sugars, and ketones are poison to the body. So we must tell the patient that how to prevent diabetes ketoacidosis. Type 2 diabetes, weight management is very, very important because adipose tissues contribute to insulin resistance. HbA1c optimal control is, as per ADA guidelines, is less than 7% to prevent diabetes related complication. No fancy diabetic diet is recommended. More healthy and balanced diet with taking care of macro and nutrients should be taken care. Thalassemia minor, inherited blood disorder, but that can cause less hemoglobin than normal. Thalassemia can cause anemia. So as Dr. Gupta highlighted, that CGM is the very best module to keep them sugar closely monitored. Gestational diabetes during pregnancy normally disappears after delivery. But yes, the person having gestational diabetes has got very high risk to have type 2 diabetes later. So risk factors include high BMI, body mass index, family history, lack of physical activity, age, and previous gestational diabetes are the contributor factors for type 2 diabetes. So if you manage these factors, I'm sure we can prevent and we can reduce diabetes multiplying in our country. Thank you so much.
Thank you, Manju ma'am. Thank you so much for your beautiful presentation. And I would also thank Dr. Rahul for his in-between valuable suggestions during the case study. So it was very well understood. And just in interest of time, Manju ma'am, we can post the questions directly to her email, which you can answer separately, right?
Sure,
So
sure, we'll do it.
Move on to our next speaker, who is Ms. Reema Rao. So Reema Rao ma'am is an alumnus of Department of Food and Nutrition, MS University, Vadodara. She is also a former associate professor in nutrition and dietetics. She is a registered dietitian and she also holds a certificate in sports specific nutrition management from the Association of Sports and Nutrition and Fitness Sciences in India. She is member of Technical Advisory Committee, also a member of Madhyan Bhojan Committee, Rajkot District. So without any delay, ma'am, over to you.
Can you see my slides?
Yes, ma'am, we can see it.
Yeah. Hello, everyone. Thank you so much, Soumya, for that lovely introduction. I actually would really like to thank the organizing committee, Shilpa, Kajal, and Soumya to, coordinate and having invited me for this talk. Also, the IAPN core people, Shilpa Verma, Mansi, and Shiv Shankar. My talk is a little less clinical from yours, the previous two speakers. So basically, we have heard about obesity and diabetes from these two great speakers before me. And my topic is overnutrition and fat diets. Overnutrition is we all know it's a form of a malnutrition arising from excessive intake of nutrients leading to accumulation of body fat that impairs health, which we in simple words call obesity. Now, the chronic excess of dietary intake combined with reduced energy expenditure increases the positive energy balance. And this transition leads to obesity. Now, as ma'am earlier mentioned, that obesity has actually turned into a public health threat. People are undertaking fat diets with the hope to lose weight fast and easy. So the main reason why people are going after fat diets is that, there are hardly any government programs targeted at obesity. We have a lot of programs for pregnancy, lactation, or say children, but we do not have government programs for obesity and diabetes and cardiovascular diseases. So people are, trying to reach out wherever they can and whatever literature they find, most commonly from Google, and they try to undertake fat diets with the hope that they will lose weight very quickly. So as the CDC says that having a healthy weight is not a diet, it's a lifestyle. So that is the first thing which we need to understand. But a fat diet is any weight loss plan that promises quick results and is usually a temporary nutritional change. These diets are considered unhealthy as they provide individuals with less calories but very less nutrients. So they do lose weight, but along with that, they also lose the nutrients. So whenever you see any definition anywhere about the fat diet, it's always the same, that any weight reduction diets that either eliminate one or more of the essential food groups or recommended consumption of one type of food in excess at the expense of other foods. So naturally, you are also having certain nutrients, but at the expense of other nutrients too. So when you do a Google search for fat diets, there are a lot of diets which come up, like Atkins, South Beach, volumetrics, keto, raw food diet, paleo diet, zone diet. So obviously people are going to just look them up and start following without really consulting any qualified person. But is it a new phenomena? No. Fat diets are known for centuries. Since ancient times, it was reported that Greeks and Romans had used them, and it was Victorians later who really adopted fat diets, and they started using the fat diets for aesthetic purposes, to look good. And according to Foxcroft, in her book Calories and Corsets, A History of Dieting Over 2000 Years, The word diet originates from the Greek word dieta, which represents a way of life, including mental and physical health. So obviously, to look physically good, the idea of whole fat diets was developed. So here we can see that how through the centuries, the first fat diet introduced was by Lord Byron, who introduced vinegar and water diet, that is drinking water with apple cider vinegar. And just imagine, so many years later, we still follow this apple cider thing. Lot of people who come to us, dietitians, they talk about apple cider in the early morning. So since 1820 to almost 2022, we have been having different kinds of fat diets, and the fat diets also, the same diet is reinvented, and then we are following a similar diet probably which was followed 100 years ago. So how do you spot a fat diet? Recommendations that promise a quick weight loss, simplistic conclusions from a complex and a single study, and there is no peer review, there is no backing by scientific organizations, and they just it is such a controversial and such a shocking statement they would make that people will get attracted to it. So the fat diet would normally have elimination of one or more of the 5 food groups. There will be a list of good and bad foods, claiming that the food can change body chemistry, claims that are too good to be true. And at the end of that article, you will find that they are either selling a product or they are trying to sell a book. And diets which have lot of testimonials from probably some celebrity, some model or somebody to tell you that why this diet is so good. Now, the diet trends of 2022. Obviously, the first thing which comes up is the immune boosting diet, because of the recent COVID scenario. Everywhere you talk about, everywhere people coming in a social gathering, coming to ask you what are the immune boosting foods. Then there is flexitarian diet, which is again, a very recent addition to this diet trend. The MIND diet, paleo diet, the new keto or the sugar sucks diet, and the intermittent fasting diet, which is again finding lot of scientific support, as we just saw Dr. Rahul explaining us the intermittent fasting thing. So the immune boosting diet, COVID continues to be one of the key influencers. And post-COVID scenario, you will see health, wellness, superfoods continue to reign supreme. Everything high in vitamin C, vitamin D, sun exposure. People are talking about everything, good fats, bad fats, functional foods, curcumin, garlic, berries, to green tea, to protein bars are all selling like hotcakes. The next is flexitarian diet, which is again a little bit a mix of Mediterranean diet and veganism, where more emphasis is given on plant-based protein sources, and 50% of the diet comes from vegetables and fruits, and the rest 50% from whole grains, plant protein sources like pumpkin seed, almond protein, pea protein, hemp seeds, even ingredients like ashwagandha, turmeric, and reishi mushrooms are also given importance here, and unsaturated plant oils are also a part of the flexitarian diets, and only modest amount, you can say that 10% of the diet is from animal sources. The paleo diet has been, going strong since the last 10 years and comes back year after year. That is the raw food diet. As they said that, majority of the people, the Stone Age people used to eat raw food, and this is when they didn't farm and when they didn't cook. The kind of food, the processed foods were not there. So in the paleo world, there are no sauces. They are pure food which are eaten raw or slightly cooked. The Mind diet is another diet which is actually there are a lot of studies being done on Mind diet. It is a combination of Mediterranean and DASH intervention for neurodegenerative delay, because lot of Alzheimer's and lot of neurology, Parkinson's, autism. So all these neurological issues have, there are studies done, and this Mind diet has come up. It is a Mediterranean diet basically, with a low sodium and mostly plant-based, with large focus on real foods like whole grains, fruits, vegetables, nuts. Actually sounds a very good diet, but we need to see how really there needs to be more evidence for this kind of diet. Low FODMAP diet is not a weight loss diet, but still I have included it here because when I was reading the literature, I found that especially in the USA, where there is a lot of GI problems, people have started using low FODMAP, and because of this they have a very restricted carbohydrate diet, which help them to lose weight. And so as an unintended consequence of a low FODMAP diet is weight loss, people start believing that they could use this diet for weight loss. But as we have seen, the FODMAPs are a lot of prebiotics, which are good, bacteria for our gut health. And numerous studies have shown that unintended consequence of the FODMAP diet is it changes the composition of the gut microbiota. So if there is no sensitivity, this diet should not be taken, especially as a weight loss diet. Now, the first follower of low carb diet was reported by Banting, and he reported that at the age of 66, he was never hungry, and in a year, he had lost 47 pounds of his initial 202. So, that's how the low carb diet, which helped lose weight, started. So low carb diets, defined as diets limiting carbohydrates intake below 26% of total daily energy intake, and moderate carbohydrate restriction is 26 to 45% of the total energy. Now there are different types of low carbohydrates diet. Atkins low carbohydrate diet, which is based on very low, less than 50 grams of carbohydrate per day, and it actually is a stepwise diet which starts with a 2-week ketogenic induction period, and then slowly from 50 grams you need to limit your carbohydrate intake to less than 20 grams. So there is carbohydrate addicts diet, there is protein power diet, there is sugar busters diet, which is like the new keto diet, and the South Beach diet. So all these diets have different levels of carbohydrate restriction with a high protein intake. That is, it is all these diets are specially stepwise diet, and gradually the weight loss occurs. But Dr. Gupta has also explained how the weight loss occurs. The new keto diet, which is again a little, diversion, a little twist of the keto diet. And it is actually the keto diet is slightly tweaked to, the original keto force followers to push themselves into ketosis by eating mostly fats. That is 70 to 80% of the diet comes from fat. And, because it helped the bodies to switch from burning carbs to burning fat. But sugar sucks diet, typically they have higher protein content, unlike the traditional keto. Extremely low sugars with no more than 4 gram net carbs. And gluten free is sometimes a plus in this keto space, as you know, the grains are not given. It is such a low carbohydrate diet that there are no grains, and automatically it becomes a gluten-free diet. Ketogenic diet is again 70 to 80% of fat with very little carbohydrate, as I just mentioned. There are different types. Standard ketogenic diet, this is a very low carbohydrate with moderate protein and high fat diet, typically contains 70% fat, 20% protein, and only 10% carbohydrate. Cyclical ketogenic diet, it involves periods of higher carbohydrates, such as 5 ketogenic days, followed by 2 high carbohydrate diets as a cycle. Targeted ketogenic diet, this diet lets on adding carbohydrates around the workouts. High protein ketogenic diet, similar to standard ketogenic diet, as name itself indicates, it includes more protein. The ratio is often 60, 35, and 5% of carbohydrates. Now, my concern here is, it's very easy to start on some diet if you are slightly determined. But where do you stop? That is the main question in the fad diet. So how much can you take this such diets, and when do you stop? After stopping, how do you really move forward? Because anything, you just cannot stop and then go back to your normal diet, because it'll rebound. But you need to do it very gradual. And how do you do that gradually is normally people do not know. These diets, ketogenic diets, are used extensively, and they are used specially in the gymming population and the athletes. And the standard ketogenic diet is the most researched and recommended. Now we saw the composition of the ketogenic diet earlier. There is again opposite of ketogenic diet is very low fat diets. Fat is less than 15% in the protein diet. Ornish diet, where Dr. Dean Ornish was a doctor who found this diet, where fat is less than 15%. It's a variation of a vegetarian diet enriched with PUFA and diet enriched with omega-3 fatty acids. Low-fat diets contain 11 to 19% of fat. Proponents of this diets claim that reducing caloric intake and increasing energy expenditure is the way to achieve weight loss. And here the focus is on type of calories and the calorie density. So obviously, low calorie diets are taken. Now, the Indian problems with low-fat diet is that they are very similar to the sattvic diets, which, you know, are essentially a part of Indian culture and the Ayurveda diets. There's hardly any eating out option. It has to be food has to be made at home and eaten at home. So socially, a very, very restrictive diet. So here what happens is that people, because in a family where everybody eats normal food, the dieter has to choose, eating commercially prepared low-fat foods rather than choosing fresh fruits, vegetables, nuts as recommended in the diet. Intermittent fasting, that is actually the current, I would say the rage in all the whole, globally, you should say. And also, we have just seen there are scientific studies which show that even for diabetic patients, we can give intermittent fasting, which is a very, actually good news. Fasting was again done throughout, especially our culture, Indian culture, and the two most common forms of intermittent fasting are alternate day fasting and time restricted eating. Again, Dr. Gupta had shown a beautiful slide on the types of intermittent fasting. And the fasting feeding cycles should consider synchronizing with the circadian rhythm, since shift work is associated with a higher incidence of obesity, diabetes, cardiovascular disease, especially, people who are working in marketing, in sales, in a factory setup where there are shifts. So they do not eat according to their circadian rhythm, which is actually a big minus for them. Because the circadian rhythm governs the expression of metabolic genes, as the secretion of insulin from the beta islet cells peaks around 1700 hours with nadir at 4 o'clock. So time restricted eating regimens limiting caloric consumption to midday were associated with increased weight loss and glucose control, while energy consumption in the evening had negligible or worsening glucose control, BP and dyslipidemia. Again, it was there was a study which was mentioned earlier about eating earlier. Future studies should examine whether the alignment of the circadian rhythm with the feeding fasting cycle enhances the cardiovascular benefit.
You can start summarizing, please.
Yes. So this is my last slide. Diets have a huge impact on human health. Fat diets limit the range of food types included in the meal plan and do not reassure a balanced and a healthy diet, and metabolic benefits may vary. They promise fast weight loss. Nevertheless, they suffer from many drawbacks, such as introducing health risk and low sustainability. There is no scientific evidence proving their safety, and there is a paucity of long-term data also in certain acceptable fat diets. Fat diets have been linked with many physiological conditions as cardiovascular, renal dysfunction, and osteoporosis, and eating disorders, and modification of dietary calories and macronutrients have been tried to decrease the risk or maintain metabolic status. So a take-home message from me that a long-term high-fiber, low-sugar, well-balanced diet will overcome these complications, as the weight loss results are more likely to be sustainable. Thank you so much.
Thank you, Rima ma'am. Thank you so much for taking us through a short trip to different kind of diets which are available these days. A very quick question to you, ma'am. What do you think can be pros or cons of a high protein diet or maybe a very low calorie diet for a quick review?
Yeah, so nowadays we are seeing the how these fat diets, and we have seen people dying, especially people working out in the gym, and we have had so many sports persons recently, dying of a heart attack. So these, rapid weight loss could, they have, as we know, keto has a very high fat. It may cause other micronutrient deficiencies. It may be detrimental to the kidney or the heart or the brain. And maybe if I talk about, pros of high protein diets, it could be rapid weight loss. There is an increase in satiety, and probably there is improved triglycerides and maybe improved cholesterols. But it depends on what kind of fat is taken along with the high fat diet. Also, there are diets where as you asked, very low calorie diets. Normally, these diets are liquid diets, which are very low calorie diets. And, they are available in those sachets and packets, and you just mix water with them. There might be electrolyte imbalance, there might be, diuresis and acid-base imbalance might be there. And so I would say that such extreme diets should be taken under strict medical supervision. That is my mistake.
Thank you, ma'am. Thank you for your beautiful explanation. And again, if we have any other questions, maybe we can just email you and you can reply.
Sure.
Thank you, ma'am.
Sure. Thank you so much, Soumya. Thank you.
So we come towards the last session of this evening, and I would like to introduce Dr. Anurag Srivastava, who is ex-HOD Surgery AIMS faculty, Medical Education and Training at AIMS. Over to you, sir. And your talk is all about how to read an article well and get the best out of it.
Thank you. Good evening. Namaskar. Thanks for allowing me to express my views on how to evaluate a research and how to read a paper. And, there are special techniques for critical appraisal or reading or evaluating a study based on therapy or based on diagnosis and based on prognosis and prevention. So for sake of brevity, I'll just focus on how to read a paper on therapy, because Dr. Rao has just spoken about the different types of diets. So diet is a type of therapy, dietary therapy. Full name, I think, would be dietary therapy or dietetic regulation in health. So basically it's a therapy. So we should know how to evaluate a particular diet. So the principles start with this formula of PICO, P-I-C-O. Whenever we do any research or any intervention on human being, we must focus on this P-I-C-O. P stands for patients or participants. If they're all healthy people, like dietary changes will be mostly on healthy people also. So participants or patients or population. I stands for intervention, what intervention you are using. So a particular diet versus the controlled diet or standard normal diet. And comparison group, what is the control group? And lastly, what outcome or observations you are making. So PICO, always remember PICO whenever we evaluate any study or design any study, always remember PICO, P-I-C-O. The general guideline is ask some questions to yourself. What is the research question being asked? So in dietary regimen, say Mediterranean diet, we may ask how quickly does the Mediterranean diet reduce the body weight or BMI from say 30 to 25, for example. So you can choose a research question. You can choose, say, diabetes. Dr. Rahul Gupta was talking about regulating the blood sugar or HbA1 and all. So you can choose what research question they have asked in the study. And then decide whether this is appropriate question for my clinical practice or not. Then what type of patients have they studied? Again, coming to PICO, what patients they have chosen. So patients you can classify, whether there's diabetic or renal failure or liver disease or obese, just obesity. Then what are the methods of intervention, say Mediterranean diet versus say Indian diet, North Indian diet. Then what are the methods of intervention they have used, and then come on main outcome, and so whether it is BMI or weight reduction, blood sugar level, blood cholesterol levels, because low fat diet will be aimed at reducing the different lipids. And then finally, what are the predictors or the risk factors? So these are general principles, and we should ask ourselves, what are the main results of the study and how likely the results are true. That is, they do not have any bias, and are they result just due to chance? In other words, they have analyzed the data statistically and the play of chance has been eliminated, meaning thereby results are statistically significant. And when we say statistically significant, we look at the actual values, and also the p-value, confidence interval and the p-value. Because based on that, you decide whether there is an element of chance in the results or the results are really true. And then we should ask whether results are clinically as well as statistically significant. If you find that somebody has studied on 1 million people, 1 kg reduction in weight or 1 unit BMI can become highly statistically significant if you study 1 billion people. But is that what I am looking for? Is 1 kg reduction in weights really meaningful? So results are not only statistically significant, but also it should be clinically significant. And then finally, how do I apply these results to my patients, or how these results apply to my group of population? So you should ask in a paper, are all the patients entered in the beginning of the study followed? In other words, there is no loss to follow-up. Because if you have loss to follow-up, then you don't know what were the outcomes in those who were lost to follow-up. They were not liking a particular diet because of taste, because it was difficult to comply, and so on. So you must see whether all the patients entered in a study have been followed till the end. So minimum loss to follow-up. And usually the rule of thumb is that any loss to follow-up of more than 10%, then it raises the question, or you should look at the result with some suspicion, whether the more than 10% loss of responders or population questions the validity or the truth of the study. Then the second question is, are the risk factors or predictors measured without bias? So what can be the risk factors for, say, a study on, say, morbid obesity? It can be their dietary habit, whether they are sedentary lifestyle, whether they are sedentary workers or they are housewives. So there may be risk factors, their race, and whether they have diabetes or not, hypertension or not, and so on, other factors, whether they're taking steroid. Madam was giving a story of a lady who was taking prednisolone. So that will affect the final outcome of blood sugar. So all the risk factors and predictors have been recorded without bias. So there is no measurement bias. We should read the paper and find that out. And then the question is, are the outcomes assessed without bias? So if you are measuring the outcome as, say, BMI, so you must choose your BMI measurement very precisely. That means height and weight both have been measured without any error. So has the same weighing machine, for example, being used throughout the study. And height also has been recorded with the same scale. Because that if somebody measures with some scale and others measure the body weight with some different machine, then the error of the machine will come into picture. So outcome of BMI or outcome of body weight will not be recorded without bias. There will be a bias due to measurement error in the machine that is measuring the body weight or measuring the blood cholesterol. Say if you use lab data from different labs have their normal values, cutoff values, based on what chemical reaction they use, what autoanalyzer they use, and so on. So again, we should have all those variables to a minimum. And finally, we should check whether all the patients which have been studied included have been followed up till the end. Then I'll take the example. So this was about the follow-up study, okay? Follow-up or cohort study. So most of us, I think, in the field of dietetics and nutrition are doing follow-up studies. There are some randomized trials as well, but most of you, I think, are involved in follow-up study, also called cohort study. So the cohort, these are the parameters to look for. Whether they all have patients the same disease. So if you mix some patient with cirrhosis, some have renal failure, some have diabetes, some have just morbid obesity, then it is a heterogeneous mix of people. So that is not a good study. So baseline, PICO, that is PICO, then I intervention, and then outcome, and then the follow-up. If you are evaluating a randomized trial, then what should we look at? We should look for all the guidelines. You know that there is a CONSORT guideline, CONSORT. CONSORT is an acronym for Consolidated Result Reporting, and Result Reporting, CONSORT. So if you go on internet and type www.consort-statement.org, consortstatement.org, you will get all the guidelines related to how to report results of a randomized trial. And throughout the world, all the publication journal editors insist that the results of a randomized trial must be prepared according to CONSORT guidelines and must be printed or published following the CONSORT guidelines. So you should ask whether they have fulfilled all the guidelines or not. Was the sample size calculated appropriately or not? There are methods, there are formulae for calculating the sample size based on what outcome you are measuring. If you are measuring, say, BMI, then you should say that with this Mediterranean diet, I expect 10% reduction in BMI after 3 months of Mediterranean diet usage. So you calculate the sample size based on what outcome measure you are recording. If you are measuring body weight or blood sugar or fall in some cholesterol, then sample size formula will be different. So has the author published the sample size calculation and given explanation why they have chosen a particular sample size? So that should be seen, because if sample size is inadequate, is very small, then statistical tests are not valid. When we calculate the p-value or confidence interval, that is influenced by the sample size. If sample size is very low, even if you show 10 or 20% difference, it will not be statistically significant. If sample size is huge, say 100,000 or 10,000 patients, then even 0.2 kg change will become statistically significant. So it all depends on the sample size. So you must look at in the paper whether sample size is reported and whether authors have calculated the sample size and what is the justification. Then if you have, say, randomization into Mediterranean diet versus South Indian diet. So whether the patients who were randomized to Mediterranean diet adhered to the same Mediterranean diet throughout 3 months or 6 months of therapy, or halfway they did not like the taste and they went to other dosa and idli, that type of diet. So that must be recorded. So this is called contamination. So you have contaminated the study samples by two different types of diet because they did not like the taste or whatever, or the dietary system did not work. Then was the method of randomization described in detail? Now there are statistical methods for randomizing. If you go to a good statistician, they will tell you how to randomize the patients into two or more groups. The simplest is a table of random number. At the few last pages of any statistical book, you will find table of random numbers. These days we have many internet-based
it's 21
programs where you just type www.randomization.com. That's the easiest website for, and it is free. So we just go to www.randomization.com and then you can fill the numbers and it will make the randomization table automatically for you. So whether it has been described or not, whether it is simple randomization or block randomization, there are different methods of stratified randomization. So adaptive randomization, there are many methods of randomization. So, and then finally, was the allocation of treatment concealed? That means few things you cannot conceal or hide. If you are giving me only vegetarian diet, only broccoli and green leaves and vegetables, I will know that I have to eat unless I put a patti on my face, like Gandhari did. But most of us will be eating openly without blinding. So the person who is allocated the regimen will not know, will know. But if you make a paste, say some madam was telling that the many fat diets are like liquid based. So in liquid based diets, you can conceal. You just put on the bottle sample A or sample B, diet 1, diet 2, and no other name and composition. Only the scientist who is doing the study knows about it, and at the end, the statistician who is doing the analysis. So you can hide if it is liquid-based diet, but in normal diet, you cannot hide it. So you should describe who was blinded towards the allocation of treatment. And then it's assessment of response. If response is, say, measurement of body weight or serum cholesterol or some LDL, LDL, and blood sugar, BMI, whatever the outcome was, whether that measurement was done in a blinded manner or not. So the person may know that he is eating broccoli, but if you have chosen objective outcome such as BMI, now he cannot alter the BMI by knowing whether he is eating broccoli or not. So you have a same machine to measure his weight and the height. So you can make the outcome in a blinded fashion. The nurse or the research fellow who is recording the BMI at the end of, say, 3 months or 6 months of a study, you do not tell her that what diet this patient is. You just say, you go to this room and there's a research fellow sitting there and she will take your height and weight. And so without knowing what intervention, what dietary regimen this person is, you can measure the outcome in a blinded fashion. So it can be masked or blinded, and that will increase the validity of the study. It will reduce the measurement bias. Then contamination. So if a person who was allocated to, say, broccoli diet also took cabbage, so that will be a contamination, right? If a person who is allocated to pure vegetarian diet also took some meat or egg or fish, then that will be a contamination of the regimen. So that will vitiate or that will alter the results. Then the follow-up is very important, and if the loss to follow-up is more than 10%, again we question the validity of the results. And more than 20% loss to follow-up is certainly a bad thing. But we should try to keep the follow-up as high as possible. But in human being, it is not possible. Some people travel from far off places and they have some sickness in the house. They cannot get a transport to the hospital. There are so many factors which determine the follow-up. So we should make every effort, every endeavor to keep the follow-up as high as possible. And in some dietary studies, you can even do home follow-up. You can just phone them or WhatsApp them and say, Madam, how are you feeling? And just show me your weight today, or give your blood outcome, blood sugar level, LDL level. So you need not have to have everybody coming to your clinic. You can do the follow-up based on these phone calls and emails also. And if there are some loss to follow-up, then how many were lost to follow-up should be recorded. And in the randomized trial, we use a principle called intention to treat analysis. Intention to treat analysis means that if I had the intention of Mr. Gupta taking broccoli diet or Mediterranean diet, then and halfway, after 1 month only, he stopped taking broccoli, he started taking cauliflower. So, but I will analyze Mr. Gupta's result only in the broccoli diet because I had the intention to treat him by broccoli. Even if he did not take any broccoli, he took cabbage or cauliflower, I have to analyze his data because that is the way randomization theory works. So randomization theory means that I distribute the persons into 2 or 3 groups with equal probability of getting treatment A, B, and C. If I ignore that and analyze whatever they took, if they took Mediterranean diet or South Indian diet, I analyze as per protocol, it's called per protocol analysis, that will vitiate or make the problem in theory of randomization. Theory of randomization says that all the persons were distributed equally in the 2 groups. Their baseline characteristics like height, weight, BMI, age, gender, comorbidities, co-therapies like anti-diabetic, antihypertensive, steroid, everything was distributed equally in the 2 groups. And whatever difference I got in BMI is exclusively due to my particular diet. So that principle will happen only if we follow intention to treat analysis. So this is very important. Then, of course, we need to know whether there are any biases in measurement or confounding. And lastly, what is most important is at the end of the study, I wrote a paper, but then I questioned whether these results apply to my patients. If the study has been done in, say, Ukraine, and they follow a particular type of diet, mostly meat-based, red meat, and some other poultry products, which is not the eating habit of people living in, say, Delhi. So even if the results are very valid, they have done intention to treat analysis, there is no confounding, no bias, good scientifically watertight, good study, even then the results do not apply to our patients because our patients are eating chapati or paratha or dosa. So this is most important, whether the results apply to my patients or not. So I think this is the last slide. Thank you very much. And there are principles, there are guidelines published in British Medical Journal and Journal of American Medical Association, how to critically appraise a study and extract the truth from the study. So I have the Dr. Soumya Srivastav's email. So I will send these slides and also some guideline papers. We have been working with the guidance of a very renowned clinical epidemiologist and Dr. Kamishya Prasad. He was head of our clinical research unit and also chief of neurology. He is now director of Rajendra Institute of Medical Sciences in RIMS in Ranchi. So he has published quite a lot. He has written a book actually. I think all the researchers in the field of nutrition and diet therapy should read this book, Evidence-Based Medicine by Dr. Kameshwar Prasad. So I'll send an article written by Dr. Kameshwar Prasad sir on your email. And if there are any questions, please let me know. I'll try to answer.
Thank you very much, sir. Thank you very much for taking out time on this Sunday evening. And thank you for giving us insight on how to read a paper. And please surely share the link and the other articles on my email so that I can share it further.
Please.
Any of the speakers want to say anything, you can comment. Or otherwise, at the interest of time, everybody's interest of time, we maybe can close this session.
So I will just say that while as Dr. Reema Rao was presenting various fad diets right from history, from Greeks till today, it's very important to critically appraise the results. And if there are just 10 persons, taken from a hostel or from some dormitory, and they were given 10 days of a particular diet, and then the results are published, I think that is useless, because it will take at least 2-3 months for your body physiology, liver, and intestine to adopt to a particular, and taste buds to adopt to a particular diet. So you should very critically appraise. And if some of you are teachers in schools of dietetics and nutrition, then it's all the more important to teach only those dietary regimen which have been tested by the rigor of science and ideally randomized trials. If not randomized trials, at least long, well-designed cohort studies, follow-up studies. But otherwise, there's no point, praising or adopting a particular dietary regimen.
Surely, sir, your point is well taken and accepted, of course.
Thank you.
So we come to the closing of this session, and on behalf of IPN India Delhi chapter, I would like to propose a hearty vote of thanks to Dr. Anurag, Dr. Rahul, Reema Rao ma'am, and Manju ma'am for their active participation in this and making this meeting a great success. Thank you very, very much. And also a big thanks to all the audience. And if we have any questions, sir and ma'am, we will surely share on your email ID.
Sure.
And maybe you all can reply it individually and separately. Have a very good evening ahead, sir.
Thank you, Soumya. And you did a wonderful coordination right from the beginning. So thank you so much.
Thank you so much.
Yeah.
Bye.
And she chose all the speakers also very correctly. Very eminent
Thank you for your coordination, sir. Thank you so much for giving time. Dr. Rahul, thank you so much.
Thank you, everyone.
Thank you so much. Dr. Nag, thank you so much. And Manju ma'am, thank you so very much.
Okay, bye-bye. Good night.
Bye. Good night.
Thank you. So stop sharing. And leave the meeting now?
Yes, sir, we can.